Good morning to all. We welcome each and every one of you to our annual CME Nethram 2022 conducted by BCMCH in association with Pathanamthitta Ophthalmic Society.
It is indeed a pleasure to see all of you on a Sunday morning. I myself, Dr. Aishwarya Xavier.
I am Dr. Jayalakshmi R.
We are the masters of ceremony for today.
Now we will begin with our first session, Cornea. Moderators for the session are Dr. Sabida S. and Dr. Reshmi P. Haridas. We welcome Dr. Sabida S. and Reshmi P. Haridas. Dr. Sabida S. She graduated from GMC Alapi and completed her post-graduation from MP Shah Medical College, Jamnagar. She was District Mobile Ophthalmic Surgeon at General Hospital, Pathanamthitta. She has received State Award from Government of Kerala for doing the maximum number of cataract surgeries in the state for 3 consecutive years. She also received National Award for the Best Community Doctor from National Society for Prevention of Blindness, Government of India. She is currently working as the Director and Chief Ophthalmic Surgeon at Sabida Eye Care Hospital, Pathanamthitta.
Dr. Reshmi P. Haridas. She graduated from Government Medical College, Trivandrum and completed post-graduation from RIO, Trivandrum. She completed her fellowship in corneal surgery from Aravind Eye Hospital, Tirunelveli. Her areas of interest include ocular surface disorders, ectatic corneal diseases, keratoplasty, refractive surgery, and anterior segment disorders. Now over to you, ma'am.
Good morning to all of you. So we shall start with the first session. It's on cornea. We would welcome the first speaker, Dr. Prashok Mohan. He has worked in a lot of institutions across Kerala, and he's currently working as a consultant in cornea and refractive surgery at Chaitanya Hospital, Trivandrum. We welcome you, sir, to have your presentation here. He'll be discussing about the importance of microbiology in microbial keratitis treatment.
Thank you for that introduction. A very good morning to all of you. The downside is that hall is not full, but the upside is that nobody will be sleepy. You just had your coffee and you'll be able to hear the talk nicely. First of all, I'd like to thank Pathanamthitta Ophthalmic Society, Believers Church Medical College, for inviting me for this talk. So without much further ado, I'll just start on the topic. Importance of the humble microscope, the light microscope in the management of microbial keratitis. So this was thought to be a battle between the two instruments that we have. One is a slit lamp and the simple light microscope. It was thought to be a battle between the ophthalmologist and the microbiologist, which the ophthalmologist thought that we have won. But is it so? Is it a battle? We'll find out. Now, there are people who believe that they are awesome clinicians. So why would we ever need microbiology? We are very good clinicians. We can make diagnosis just by looking at the cornea on the slit lamp. Why do we ever need microbiology? So as you know, I'm interested in a lot of quizzes. So I think we'll start with a pop quiz here. So this is a history of a gentleman who flew in from the Gulf. He was wearing soft toric lenses, and he had an history of overnight wear of the contact lenses. And he gave a history of 1 day of intense pain and redness in one of his eyes. So this is how he presented. So I'd like this to be an interactive session. What do you think it would be? What would the clinician say? Seeing an ulcer like this, just a 1 day history, severe intense pain, it would be either Pseudomonas would be the number one diagnosis, or it could be acanthamoeba. So that was my clinical diagnosis as well. Started the patient empirically on antibiotics, took the scraping, mind you, and empirically started on antibiotics. It worsened quite badly. In a matter of 2 days, it became like this, and we had to take him up for therapeutic keratoplasty. But by that time, we did get the scraping and the culture results, and it was KOH positive. And on the gram stain also, you could see a lot of hyphae and turned out to be a very aggressive form of aspergillus. On the lactophenylcotton blue staining, you could see clearly that it was aspergillus. So this is a case of a contact lens where fast progression, not an insidious onset, and clinically we would not really go ahead and diagnose this as a fungal keratitis if you did not have microbiology. Another one. So this is a gentleman who came with a mild pain and defective vision for about a 1 month duration. There was a mild epithelial haze, epithelial and subepithelial haze, and he was apparently diagnosed as a viral keratoconjunctivitis from elsewhere, and he was on steroids. He was on a dose of topical steroids. So what would you'd obviously can't think that was a mild keratitis. So to make a diagnosis, what I did was I stopped the steroids. The moment you stop the steroids, the organism, the ulcer revealed itself. It worsened very badly, and it on scraping, we suspected a Acanthamoeba. So on scraping with and plating on a non-nutrient agar with E. coli ole, we could get a growth, and Acanthamoeba was confirmed. So again, a patient who has a microbial keratitis which has been modified by antimicrobials or steroids, they do not really follow the regular course. One more case that I can discuss is this. This is a patient who underwent uneventful penetrating ketoplasty. About 1 month later, he presented like this with a history of pain, not severe pain, moderate pain and redness. And this on scraping again turned out to be multi-drug resistant Pseudomonas, which is only sensitive to imipenem, not sensitive to any other drugs. So there again, our microbiology came to our rescue. If we had given the other usual fortified medications, it may not have responded. The other scenario where microbiology comes into the picture are secondary infections or mixed infections. This is a case of a fungal keratitis who underwent therapeutic ketoplasty, and he presented a month later with this kind of an infiltrate in the periphery. So the most common sense would be that this would be a recurrence of the fungal keratitis in the graft. However, on scraping, it came out to be Pseudomonas. Again, microbiology came to our rescue. This is a case diagnosed as a peripheral ulcerative keratitis, immune PUK, on topical steroids. However, the patient initially showed some improvement, but later on it worsened. Now, whenever you have a worsening of keratitis on steroids, you have to do a scraping. The scraping was done and came out to be Staph aureus. So this was a secondary infection of a immune PUK with Staph aureus. And there again, microbiology came to our rescue. You can have mixed infections. This was a viral stromal keratitis on steroids, initial response and then worsening. On scraping, again, KOH positive. You have fungus, super infection. Also, microbiology comes to our rescue when you have extremes of sizes. These are very tiny ulcer. Patient presented with pain and redness of a few days duration. And normally we would just start an antibiotic and leave it like that. We wouldn't scrape this ulcer. But I had a suspicion and I did a scraping. Came out to be KOH positive. They are fungal filaments. And very large ulcers also do not follow the our textbook clinical description. This is a very large ulcer and it turned out to be Pseudomonas. Again, microbiology leads to diagnosis of not so common microorganisms. Like this was an alternaria ulcer. So nocardia keratitis, showing the classic reed shape pattern. But in a busy clinic, you may not really suspect nocardia keratitis unless you have microbiology. This was some strange organism called Lactobacillus, which is only sensitive to amikacin, not sensitive to any other drugs. Now, to summarize, why is ocular microbiology a necessity? Number one I would give is the steroids in corneal ulcer trial. So in the treatment of corneal ulcer trial. So this is a landmark trial, and if you read only the abstract of the trial, you would think that steroids are not helpful. But if you go into the fine print of the trial, you would know that steroids are really beneficial in culture proven non-nocardial bacterial keratitis. After an initial period of loading dose of antimicrobials, if you start steroids, they are really beneficial, especially in large pseudomonas ulcers. So this trial has really changed my management at least, and it has really helped in managing microbial keratitis. However, the necessary precondition is culture positive. So you need to have a microbiologist support before you start any steroids. You have to make sure it is not fungal, not nocardial, and it is bacterial only. Again, you can use antibiotic sensitivity to guide treatment. This is the era of superbugs, which are resistant to all antibiotics. The other day we had an ulcer which had a multi-drug resistant pseudomonas, even resistant to imipenem. We did not check the colistin sensitivity, but finally responded only to colistin. So this is the era of superbugs, and we have to be mindful of that. Again, steroids and antimicrobial exposure, that is prior antibiotic or antifungal exposure, can modify the clinical appearance. This is where I would like to appeal to all the general ophthalmologists and those who have no support of microbiology in the periphery. Please do not start a cocktail treatment. It makes it complicated for the clinician to diagnose it clinically. So antibiotic is fine, but if you start a multiple cocktail of different antibiotics, antiviral, antifungal, then it complicates the clinical scenario further. Mixed infections again, which may not give you a typical clinical appearance, and if you have suspicion of secondary infection in immune conditions, and in very small and very large ulcers, microbiology is very helpful. Also, you can diagnose ulcers caused by rare organisms and publish them. This was a study that was conducted in two large institutes, the F.I. Proctor Foundation and Aravind Eye Care System, and what they basically did was they sent photographs of ulcers to the best cornea specialists that we can have, and just to find out whether they can clinically differentiate between bacterial and fungal. Just if they were asked to differentiate between a bacterial and fungal, just broadly, the hit rate was less than 70%, some 63 or 65%. So 30 to 40% cases they missed. And when they are asked further questions, the results were even below 50%, like the gram stain pattern of the ulcer. When such questions were asked, the results were less than 50%. So that again shows that even in the hands of experts, microbiology is needed. And this is another study which tried to differentiate, which tested if people can differentiate between Pseudomonas and Acanthamoeba, and both have ring infiltrates. And that also showed that there are overlapping inflammatory features, and if you have recent empirical treatment, the etiological recognition clinically is made difficult. So my suggestion would be, if you can, please invest in a light microscope. It is not very expensive. All you need is microscopes, lights, and this humble 10% KOH. KOH is a very sensitive test which you can simply scrape the cornea, put a drop of KOH, put a cover slip, and see under the microscope. It is a very sensitive, more than 80 to 90% sensitivity for fungal keratitis. At least this you can do. Or what you can do is refer. Please, maybe not the really small ulcers, but a moderate to large size ulcer, especially if not responding to antibiotics, please refer. Overconfidence can lead to a lot of problems. So it is actually not a battle between the slit lamp and the microscope. It is a synergy, and it is a complement. They complement each other. So I'd like to say that you should use the help of the ocular microbiologist whenever necessary. Thank you. And with that, I'd like to invite you to our CME next. It is on the 3rd and 4th of September. That's next week. To Trivandrum. Please attend. Thank you.
Thank you, Dr. Prashov, for the excellent presentation in ocular microbiology and microbial keratitis. So even though we tend to diagnose these conditions clinically, it's very much important to have a microbiological examination also, and even gram stain and KO staining we can do in our clinical setup. It's so simple that we should practice doing that. And the importance of steroids also you explained in pseudomonas keratitis. So thank you very much. Now we can have a discussion or any doubts at the end. Yeah.
Prashop, you had mentioned about the use of steroids.
Yes.
So I think in your clinical practice, what would be the threshold? When, during the course of the treatment of the ulcer, would you start a steroid? And if so, what is the steroid of your choice? I mean, that is very important.
Yes.
To know.
It is important to know that the steroid in corneal ulcer trial, the important caveat is culture positive, non-nocardial bacterial keratitis. So you have to be sure that it is not a fungus and that it is not nocardia. So usually when your culture report comes, it at least takes 48 hours. So in the trial, what they did was, Dr. Prajna et al., what they did was they gave an intensive initial loading dose of antimicrobials, empirical fortified antibiotics. So that's what I do. So for the 48 hours, hourly or 2 hourly fortified antibiotics. And by the time I have the culture report or at least the gram stain, and I'm sure that there's no fungus or nocardia, you can start prednisolone acetate, 1%, 4 times a day. And I taper it over the next week, 3 weeks or so, along with the antimicrobial cover. So this is not something controversial or difficult. I mean, it is not a controversy right now. It is a established practice. It's no longer a controversy. The trial has dispelled all these doubts. Yes, ma'am. You were asking.
Yes, along with the antibiotics, as soon as the culture report comes,
Yes.
you start both of them simultaneously.
No, the antibiotics are started initially itself, empirically.
Yeah.
By the time the culture report comes, once the culture report comes, and you're sure it is not fungus or nocardia, you can start the steroid.
Prashop, do you start? Do you do a scraping even for very small ulcers in the beginning itself?
Not practically, you cannot recommend that for the really small ulcers.
I was wondering regarding the positivity of that, because there will be hardly any space to scrape and take it out.
Yeah, but good. If you have an in-house microbiology, you will be surprised the percentage of positivity that you get. Now, when I did not have that facility, when the microbiology was not in-house, the positivity rate was very low, because you used to scrape, send the sample somewhere else. By the time it used to reach there, it used to get dry, or it used to touch other surfaces and get displaced. But if you have an in-house microbiology, if you are looking at it either yourself, or if you have a microbiologist in-house whom you are in contact with constantly. I mean, ocular microbiology is slightly, you can consider it as a subspecialization of microbiology. Regular microbiologists may not be able to pick up everything. So if you have one person whom you are constantly sending samples and you are in contact with each other, you can talk to each other. That way, even the skill of the ocular microbiologist improves. So you will be surprised to see how positive it comes. We have very high positivity rates in Chaitanya, at least 80 to 90% we get positive. It makes a big difference.
Is there any study which has compared weaker steroids to prednisolone, and is there any advantage or disadvantage of this?
No, not to my knowledge. In the SCUT trial, they use prednisolone phosphate actually. That is not commercially available. I use prednisolone acetate and I've been having good results. But if, in my opinion, if you're going for steroids, you want the activity of the steroid, you want the action of the steroids, that's reducing the inflammation, especially in Pseudomonas, etc. More than the damaging effect of the toxins of the bacteria, it is the immune system that produces damage. So you want if you're going for steroid, go full Monty. Give the full strength prednisolone.
Yeah, I absolutely agree with every point you said. The only small point I want to make is that make sure the patient is on an antibiotic which is bactericidal antibiotics. And slight different from what you said is that I tend to start steroids only after I get a clinical response to the medication. The reason why you've burned your hands quite a few times, and that's the reason why I've changed it slightly. At times there can be mixed infections, okay, which is not picked up on your scrapings or culture. That is when you get the problem. You get a culture report, the patient is on the right antibiotic, and you start within 48 hours the steroids, but then there can be worsening. That is the mixed response. So I generally wait till I get a clinical response before starting topical steroids.
Yes,
That's just a practical point. That's all. So the message to be taken from this is that do not start steroids if you don't have a etiological diagnosis.
Absolutely.
To start steroids once you start getting a response. Okay, and then to answer your question about microbiology, the yield. Well, it depends upon the microbiology team. You need to have somebody who is actually tuned to ocular specimens. It's going to be very minute, unless many a times when we send outside, there is no, they gave the report saying that there is no material in the slides. Okay, it's not that there is no material, it's just that the microbiologist is not tuned to that. Okay, unless, as he mentioned, you have an in-house team, or you have a very good tie-up with an external team who actually will take time to learn the ocular microbiology characteristics. It is very difficult to get a good report.
I think it's important to talk to your microbiologist, have a good liaison. In that way, both of you learn. I mean, I learned quite a few things from microbiology also.
Yeah, yes. Prashok, just one question about steroids and viral infections, epithelial versus stromal.
Epithelial, obviously contraindicated. Stromal, you have to give steroids. I mean, it is the management. I mean, stromal is basically an immune keratitis, so you have to give topical steroids under antiviral cover.
Prashok, I have a question. Is there you start empirically fortified antibiotics, but is there any situation where you might start an antifungal as soon as possible? I mean, even if we get a culture positivity.
Now, this is not a written rule anywhere, or there's no textbook that says don't start antibiotics, or study that says don't start antifungals. But it's my personal rule that I don't empirically start antifungals. Empirically, I only start antibiotics. There's hardly any case where I've started antifungals, especially if you have a clinical microbiologist support. Then it is unless it is a case like the rare one that I showed, which worsened in 1 or 2 days. Fungal keratitis usually doesn't worsen that fast. So nothing happens if you don't start the antifungal on day 1 itself. Because if you do start empirical antifungals, what happens is it complicates the issue further. You don't know which is working, if your antibiotic is working, whether the antifungal is working. And there are many cases, I'll tell you, where the fortified antibiotics has worked for the antifungal, as an antifungal. It's not that fortified antibiotics don't work for fungus. I mean, for not virulent fungi, which is of a very load, sometimes even the fortified antibiotics also work. So I would always wait for a scraping, at least a KOH mount report, to start antifungals. That is my personal thing. Anybody has any different opinion? I don't know. Our fortified antibiotics, the cefuroxime and the tobramycin. My regular antibiotics are now cefuroxime and tobramycin. Used to be cefazolin. Somehow we are not getting cefazolin that commonly. So what I give is fortified cefuroxime 5% and tobramycin 1.3%.
Now these days a lot of conjunctivitis going on to superficial punctate keratitis staining. Would you give a mild steroid, soft steroid in such cases?
Again, that the steroid, when we give, the timing is important in the adenoviral keratoconjunctivitis. The steroids should not be given in the initial stage. In the acute phase, it will calm down the patient, it will reduce the inflammation, it will make the patient happy, but you will have the patient coming back to you for a long time. It has been shown that early steroids in acute conjunctivitis prolongs the viral shedding, prolongs viral replication, increases spread to other people as well, although it gives slight symptomatic relief in the beginning. So what I tell my patients is usually fight out the initial stage. At least 9 to 11 days is what is the timing that is said. 9 to 11 days, of just lubricants. Nothing else is required. You can keep the lubricants in the fridge, in the refrigerator. That will provide some relief, and cold compresses. And nothing else other than that. Unless the conjunctivitis is very severe, you have pseudomembranes which are removed, then you can give a very short non-tapering course of steroids. That is my personal thing. And then steroids would be started later on, maybe 2 weeks later, once you have subepithelial lesions which are involving the center. If they are not involving the center, not involving the visual acuity, there is no need for steroids. The adenoviral keratoconjunctivitis is a self-remitting illness. So most will just resolve. There will be a few which are going to affect the cornea. So for those, you may need to start steroids later. Mild steroid would be enough. Loteprednol would be enough.
What about marginal keratitis? What looks like a marginal keratitis?
Marginal keratitis, definitely you need steroids. You need steroids.
Would you combine it with an antibiotic or?
Yeah, for the antibiotic for the lids, it is the infection is in the lids. The staphylococcus is sitting in the lids. So the antibiotic would be for the lids. Usually I give azithromycin ointment, and along with the lid hygiene and warm compresses, and steroids for the marginal keratitis. Marginal keratitis is an immune phenomenon, so you need steroid. That is a problem. It's a question of short-term versus long-term relief. You can give short-term relief if it is in the acute phase, in the early stages. I would avoid steroids as much as possible. If they can fight through those 2 weeks, then they'll be symptom-free for a long time. But if you give steroids in the initial beginning itself, you can have a course of 2 weeks extended to 1 month, 2 months. There are patients who come back for months. So some people will get a chronic course even if you don't do anything, but you are just making it you are making the chances of making it chronic more if you're starting steroids in the acute phase. So I would advise against steroids unless absolutely necessary in the acute phase, such as if you have a pseudomembrane or a very severe inflammation. Other than that, acute phase I'll avoid steroids, and in the chronic phase obviously you need steroids. Not really. I never started. Maybe one case or something I have started a systemic steroid. Otherwise, you don't need that kind of. Children, they cry, and the parents, it produces a lot of distress to the parents. I think more than steroids, consoling words are important. So you have to tell them it looks bad, but it's not that bad. That is what you have to tell them.
Sir, any role of corneal cross-linkage in microbial keratitis?
Again, little controversial area. I don't do it. I have not done it. Studies have not shown a conclusive evidence of cross-linking in microbial keratitis. There are a few authors who claim that their version of cross-linking, that machine is not yet available in India, Hafezi et al., that it works in microbial keratitis. I wouldn't do it.
Do you prescribe antiviral drugs in viral conjunctivitis? You told subepithelial along with the steroids, or only low dose of steroids?
We are talking about adenoviral keratoconjunctivitis.
Yes.
Absolutely no role for any antiviral.
And only subepithelial pseudomembrane, only low steroids is okay.
Low dose steroids in the chronic phase, not in the acute phase.
Yeah. Tapering doses, how long?
4 weeks tapering, that would be enough. If it persists after that, then you will have to consider tacrolimus.
Tacrolimus one. Okay. Thank you.
Thank you, Dr. Prashov, for this informative session and discussion. Now we move on to our next speaker, Dr. Sanjana. She will be presenting about the ectatic disorders of cornea. And Sanjana has done her MBBS from Enapoya Medical College, Mangalore, and MS Ophthalmology from SDM Medical College Hospital, Dharwad. She did her fellowship in cornea, refractive and cataract surgery at Shankara Eye Hospital, Bangalore, and she is currently working as consultant in cornea, refractive and cataract surgery at Chaitanya Eye Hospital, Tiruvalla. She had done 3 to 4 publications in the national and international journal and presented multiple papers in the state and national conferences. Now I invite Sanjana for her presentation.
Very good morning to one and all. At the outset, I would like to thank KSOS as well as Pathanam Thitta Society for giving me this opportunity to speak on keratoconus. Now, as we all know, there are 4 different types of ectatic disorders, of which keratoconus is one of the most commonly seen clinical form of ectasia. By definition, keratoconus is a bilateral asymmetric disease which results in progressive corneal thinning, leading to irregular astigmatism and decreased visual acuity. Traditionally, it was known to be a non-inflammatory disease, but over a period of time with lots of research, we have come to know that ocular inflammation is one of the major causes for keratoconus progression. Typically, it is seen in the range of 16 to 30-year patients, with more commonly higher significance in male patients compared to females. Middle Eastern and Asian ethnicities are more commonly affected with keratoconus. Pathogenesis of keratoconus is more commonly related with atopy, eczema, collagen vascular diseases, or syndromic associations like Down syndrome, Marfan syndrome. Patients who present to us clinically normally present with blurry vision or frequent change of glasses. Some of them also present that even though they are seeing 6/6, they are not very comfortable with the vision that they are appreciating. And occasionally we have patients complaining of diplopia and colored halos. If we further question them, most of the patients would either be suffering from chronic diseases like VKC or would have occasional eye rubbing history. On external examination, some of the common signs that are seen are the Munson sign, the Rizzuti sign, and the Charlotte's oil droplet reflex. Now, on slit lamp examination, the signs that we commonly appreciate are the prominent corneal nerves, which are commonly seen in early keratoconus, the Fleischer's ring, the apical scarring, as well as the Vogt striae. Both Vogt striae and apical scarring are more commonly seen in advanced cases, where patient commonly says that if he is rubbing his eyes, his vision improves. That is basically because of the thinning, there is appearance of Vogt striae, and when the patients rub their eyes, the thinning goes off, because of which they are able to see better. The diagnosis of keratoconus is still gold standard is the corneal topography. Earlier, there used to be placido disc based diagnosis, which used to mainly identify the anterior curvature of the cornea. Over a period of time, we have been introduced to Scheimpflug based image, which gives us both the posterior curvature as well as the anterior curvature and the pachymetry of the cornea, thus helping us to check for the progression. And of late, we have machines like Galileo and Sirius, which gives a combined picture of both the placido based as well as the Scheimpflug based images. Other ways in which we can diagnose keratoconus are anterior segment OCT or ocular response analyzer. Coming to the corneal topography, this is a pentacam report, where firstly we go by the K readings of the patient, followed by the steepening exclusively at one particular area. Next, coming to the anterior float, where any anterior float value is above 15 or posterior float values above 25 is most likely to be keratoconus. And the pachymetry, normally there will be a pachymetry apex, and very close to it there will be a thinnest pachy, which would be around 10 to 15 microns lesser than the pachymetry reading. So in the benefit of pentacam is most of the values are already given over here, and because of which we can make an early diagnosis. Now, Bellin and Ambrosio came up with an enhanced ectasia report, where in one shot itself we get to know most of the values, where all the K readings, the pachymetry indexes, as well as the thinnest pachy is given in one sitting. The Bellin Ambrosio basically overlaps the regular cornea with the keratoconic cornea, thus giving the enhanced ectasic ratio as well as the deviation values. So with this, we can also identify patients who are contraindicated for LASIK, as well as those developing early keratoconus, as well as in the progression of keratoconus. Now, classification, there are various types of classification of keratoconus. Earlier, we had the classification based on the severity of the curvature, followed by based on the shape, that is a nipple cone and oval cones, and then with the indent of pachymetry as well as keratometric reading, we had the Amsler-Krumik classification. Currently, we follow the Bellin-Duncan's ABCD classification, which is mainly a topography based classification. Now, what is more important is how do we go by the management of keratoconus. So it can be divided into 3 segments, that is vision stabilizing procedures, vision corrective procedures, as well as vision rehabilitating procedures. Now coming to vision stabilizing procedure or keratoconus, as we all know, Wolensack et al. Introduced this principle of collagen cross-linking in 2003 in the Dresden University, hence it was called as the Dresden's protocol. The protocol basically involves 30 minutes of riboflavin soaking of the cornea, followed by passing a UVA light at 3 milliwatt per centimeter square for 30 minutes. So this is the classical Dresden's protocol. Over a period of time, people found out that this could be altered into accelerated form, for which they introduced the accelerated C3R based on the Bunsen-Ruskow's law of reciprocity, where the total energy is maintained at 5.4 joules per centimeter square. The power was increased and the time was decreased. So these are all the different protocols which came into action. But over a period of time with studies, it is shown that any energy that is more than 9 milliwatts would be less effective because of the oxygen depletion action of the riboflavin effect. Now, another type of C3R that has come into action is the pulse C3R, where they give 30 milliwatt for 8 minutes at a pulse dose of 1 second off and 1 second off. So all these are in the study process, and we are still not sure at a long term how effective is this collagen cross-linking. Now, as we all know, the cutoff for classical collagen cross-linking is 400 microns. Now, they came up with a thin cornea collagen crossing for up to 350 microns, where initially we had a transepithelial collagen cross-linking, where epitheliotoxic medicines like EDTA or even BAC were being used in the riboflavin solution, which basically helps the hydrophilic riboflavin penetrate into the corneal stroma. Then they came up with hypoosmolar riboflavin technique by Hafezi et al., where they basically used a hypotonic saline mixed riboflavin, which helps in swelling up the cornea and thus making the collagen cross-linking effective and preventing the endothelial toxicity. But the only thing with this is what has been found is the hypoosmolar riboflavin basically stretches the collagen bundles. Thus, the collagen cross-linking may not be very effective. Then we had the customized epithelial debridement technique, where the thinnest area of Pachy was spared of debridement and all the other areas were debrided. Even in this, the most important part of the keratoconus ectatic area was not being cross-linked because of the intact epithelium. Then they came up with something called as a contact lens associated cross-linking or smile lenticule associated cross-linking, wherein these substitutes were being used to actually increase the thickness of the cornea, and these were actually soaked with riboflavin for at least 30 minutes to 1 hour prior to the procedure, so that the penetration of UV light will be adequate at 300 to 350 micron. Now, coming to vision corrective procedures, we have the intracorneal ring segments. These are divided into 2 types. One is the synthetic PMMA type, which most commonly is marketed as Intax, and the other one is by our very own Dr. Susan Jacob, who's come up with the corneal allogenic intracorneal ring segments. Now, both these work on the principle of hammock effect or decreasing the arc length, thus flattening the center of the cornea. And the benefits of Intax or CAIRS is basically they help in better contact lens fitting, as well as delaying the requirement for DALC or penetrating keratoplasty. Again, the cutoff for intracorneal ring segments is 450 microns, and these are basically placed at 80% depth. The thicker the intracorneal ring segments, the more the flattening is normally achieved. Now, finally, coming to keratoplasty, the indications for keratoplasties are basically poor vision with contact lens, intolerance to contact lens, or cases of scarred or healed eye drops. So in keratoplasty, we have both the penetrating type of keratoplasty and the deep anterior lamellar keratoplasty. Of late, most of the cases are converted into deep anterior lamellar keratoplasty, going by the benefit of preserving the patient's endothelium and comparatively lesser rates of rejection. Now, Sandali et al. Came with a classification for DALC versus PKP based on the OCT, where stage 1, stage 2 and up to stage 3, where the Bowman's level is only scarred, were taken up for DALC comparative to other stages. Now, even there are recent studies where also shown that even if there is a panstromal scarring, but if the scarring is comparatively in the periphery, still a layer by layer technique of DALC can be attempted compared to penetrating keratoplasty. Now, one of the latest intervention is the Bowman's layer transplantation, which is of late being done by some of the corneal surgeons. So, it's an isolated Bowman's layer, which is basically inserted in the mid-stromal level. So, the benefit of this is this can be operated for patients who are now very early for DALK or penetrating keratoplasty. This is indicated at the thickness of 350 microns in cornea or when the curvature is more than 65 diopters. So, benefit is it halts the progression, and being acellular in nature, the rejection rate is very, very low. Now, as we all know, acute eye drops is one of the dreaded complication of advanced keratoconus. Here, basically, there is a break in the decimate membrane, because of which there is a fluid pocket collection in the cornea. So, this can be medically managed as well as surgically managed with the help of C3F8 or air bubble injection. The advantage of early management of this and closing the break is basically it prevents vascularization, because if there is vascularization, future ahead going in with DALK will be difficult and the patient would be needing a penetrating keratoplasty. So, generally, if at all it is not treated, it is self-resolving within 6 to 8 weeks, and that will be with scarring and vascularization. Now, coming to visual rehabilitation, we have two types of methods, that is glasses for patients or hard contact lenses, which could be gas permeable, or scleral contact lenses. Now, in scleral contact lenses, we have two types, the rigid contact lenses as well as the scleral lenses. Now, the benefit of scleral lenses is the bearing is mainly on the white part of the eye compared to the rigid contact lenses, which are basically sitting on the apical cone of the keratoconus. So, it has a thicker fluid reservoir. So, if the keratoconus patients are associated with dry eye, comparatively scleral contact lenses are better than RGP lenses. But the only thing is the fitting process for scleral contact lenses is slightly complicated. So, the patient compliance becomes a little difficult. But simultaneously, RGP, there is a risk of loose fit and the risk of losing of contact lenses faster. So, basically patients need to be acclimatized as to how to use these lenses, and the lenses give the best results to the patients and can delay keratoplasty for these patients. So, coming to the follow-up of keratoconus, if the patient is being followed up without any C3R procedure, just to make sure that whether there is progression or no, these are some of the points which are basically to be considered to evaluate the progression. One is the subjective assessment, that is to check the refractive error of the patient and see if it is frequently fluctuating. Checking the visual acuity of the patient to find out if there is any kind of change in the clarity or glare of the patient. And last but not the least, the topography is one of the most sensitive method of checking for the progression, wherein the Kmax reading as well as the pachymetry thinning can be closely checked upon to see whether the patient is progressing or not. Now, how do we prevent the progression? As we all know, C3R is only the way in which we can permanently prevent the progression, but other ways in which we can prevent are avoiding eye rubbing or for temporary benefits by using contact lens. So, in a nutshell, to tell you about keratoconus, we can briefly divide it into a progressive keratoconus as well as non-progressive keratoconus. If the patient belongs to progressive keratoconus, we have to first find out whether the patient has good vision with glasses or contact lenses. If he has a good vision with contact lenses, we have to go for rigid contact lenses or glasses. If not, we can go for a phakic IOL in these patients who want to go glass free. Now, if the patient is having not a very great vision with glasses and contact lenses, they are intolerant to contact lenses, or it could be an eccentric cone or a very, very steep keratoconus. But if the corneal thickness is more than 450 microns, patients can undergo intact procedure. If the thickness is less than 450 microns, then the patient needs to undergo DALK or PKP, depending on the Sandeli's classification. Now, for progressive keratoconus, there is no other alternative, and collagen cross-linking is the only way in which we can prevent progression. Thank you so much.
Thank you, Sanjana, for that excellent talk you've covered in this topic about everything regarding keratoconus. It was a wonderful presentation.
Thank you.
For the want of time, probably we'll have the discussion at the end of the next topic
Sure,
also.
no problem.
So next we invite Dr. Vinay sir for his talk on ocular surface disorders. Dr. Vinay sir, he is working as a senior consultant and head cornea and refractive surgeries services, Giridhar Eye Hospital, Kochi. He has worked in as a consultant in many renowned institutions like LVPI, SN Chaitanya Eye Hospital. He has had multiple publications in national and international forums. So, sir, we welcome you to give us a talk. Thank you.
Thank you. Good morning, everyone. My throat is not all that okay. At the outset, I'd like to thank POS and Dr. Sanjana and Leena for asking me to be here. So, I was asked to speak on ocular surface disorders. So, when you think about ocular surface disorders, first, what do you mean by ocular surface? Well, it constitutes the whole eye surface from the lid margin, upper lid margin to the lower lid margin with the preocular tear film and all the adnexa. So this is a intimately linked structures and function as a single unit, and it's terribly interdependent in the sense that you need a stable tear film for the health of the ocular epithelium. At the same time, the ocular epithelia actively participate in maintaining a very stable and healthy tear film. So this is the the rough way how you get a stable tear film. You have the various components of the tears, at the same time the so-called hydrodynamic factors, which is lid blinking, lid position, closure and all those things, and the surface epithelia being integrated in a complex way to get a stable tear film. Now, any disruption in this delicate unit can result in ocular surface disorder or ocular surface failure. So, when you get a patient or a person with some kind of ocular surface problem, how do you approach them? What do you do? So, in management, there are basically three things to look at. One is the tears. The second thing, is there any inflammation of the surface? If there is an inflammation, what is the cause of inflammation? There can be mechanical factors that incites inflammation, like the lid position. You may have a misdirected lash, lag of thalmus, and so on and so forth, or lid margin keratinization as it's seen in certain conditions, or it might be because of intrinsic causes like an autoimmune process or some other causes. And finally, assess the surface failure. Is there any surface failure? What do you mean by surface failure? One, squamous metaplasia. The surface epithelium is a non-stratified squamous epithelium, non-keratinized stratified squamous epithelium, which can get transformed to keratinized epithelium. That is what is meant by metaplasia. Second is scarring. So, I was asked by Dr. Sanjana, probably I can talk about certain conditions which is common. So, one of the most common condition what we see with surface problem is allergic eye disease. Now, surprise, right? What does allergic eye disease has got on the surface? So, basically, this is what is allergic eye disease. What we commonly see is vernal disease. Okay, 77% of allergic eye disease which present in our clinics is because of vernal. It's males, childhood. All these are risk factors for allergy, and I don't think I have to give you the clinical features of VKC. Palpable form, yes, papillary hyperplasia, and based on the size, you have micro, macro, or giant papillae, which can actually coalesce, form the cobblestone appearance. Limbal form, thickening of the limbus, gelatinous appearance. You can have trunta spots, so on and so forth. But generally, when you see what you see these patients first, if there is no severe inflammation, what you see is the discoloration of the conjunctiva, what we clinically call as or muddy conjunctiva. So these are some of the clinical features. But then, what has got to surface on the cornea? In active disease, you can get erosions which can combine to form large defects and then lead to shield ulcers. Chronic stages, pseudogerontoxin or keratoconus. Shield ulcer is not that common. It's only 0.3% in our Indian population. It's a vision threatening problem, okay, depending upon the site where it occurs. And what is the reason for shield ulcer? It can be because of the mechanical causes, a large papillae rubbing on the epithelium directly causing epithelial debridement or erosion. But more commonly, it is believed because of other reasons like toxic cytokines released from the epithelium, especially eosinophils. Okay, they are highly epitheliotoxic, can cause breakdown of the epithelial adhesions and then lead to shield ulcers. But then generally once the epithelium breakdowns, because of the inflammation, the mucus gets stuck onto the bare stroma. That inhibits epithelialization and the chronic process of shield ulcer. So let's see how we can think about this as an ocular surface disorder. So tear film problem, does it occur in vernal disease? Yes. What is the reason, or how does it occur? It actually causes a short tear film breakup type of a dry eyes or tear film instability. Now why is that due to? Because of the inflammation, the alteration in the mucin component of the tear film. There is, in chronic cases, there is drop of the meibomian glands, and there can be reduction in the goblet cells in the conjunctival epithelium, and there is a reduction in the corneal nerve density. Then surface inflammation is obvious. And how do you manage inflammation? With steroids. In chronic cases, you may even have to think about systemic steroids and immunosuppressives, and then a lot of other agents to break the inflammatory cycle and to keep the patient in the quiescent state, which is beyond the scope of this talk today. This is a nice article to go through it, which will give you a very good concise idea about what to do and when to do in vernal disease. And then surface failure, does it occur? Yes, it can, especially in cases with very large papillae that can keep on rubbing on the surface, causing all sorts of problems. You can manage them with all these things. But yes, suprastiratal steroids is quite effective. Of all the other methods, what has actually been shown to prevent the recurrence is only mucous membrane grafts. Okay, very rarely required, but then yes, works wonders. Shield ulcer, again, all of us know, but the grade 1 you can manage medically. Once there is a mucus on the surface, it has to be debrided and probably an amniotic has to be done. Then finally, yes, in severe limbal form, over the years patient can go in for stem cell failure. So what do you do for that? Stem cell transplant, but again bilateral disease, so we may have to think about allotransplants or even prosthesis. Now next one is probably pterygium. Okay, what is the etiology? We still don't know. Maybe a focal limbal stem cell damage, but then what does it cause? It causes for localized tear film instability and localized ocular surface failure. There is progressive conjunctivalization onto the cornea. So when do you treat them? When it's symptomatic, when it is on to the visual axis or threatening the visual axis and cosmesis. So what is the treatment? Gold standard is excision with autograft. So what is the goals of treatment here? Removal of the reactive fibrovascular tissue, restoration of the normal limbal barrier, restoration of a smooth surface, and to prevent recurrence. So how do we do it? My technique is, in primary pterygia, other than the cutting the conjunctiva at the neck, I don't do any dissection with sharp instruments here. Once the conjunctiva is opened at the neck, do a wide subconjunctival dissection, okay, to free the tenons. Actually the basic this is believed to be in the subconjunctival tissue. The conjunctiva has been shown to be normal, so you don't have to sacrifice much of the conjunctiva other than probably what is onto the cornea, and then peel off from the cornea. It comes out beautifully in a plane. Okay, there is no need to go with a sharp instrument onto the cornea at all in primary pterygia. Peel it off, separate it from the limbus, which is usually quite densely adherent, cut it out. Then the graft has to be as thin as possible and fixed with various techniques. So, and now the next, because of the lack of time, we'll go to the last one. This is a not a very common disease, and people in institute like this are in a unique position to address this at the root cause, or when the problem arises. Why? Consider this 27-year-old female who we had the opportunity of addressing her problem at about 10 days after the acute event. So when does when does the ophthalmologist's role come in a case like this? It has to be in the initial 5 days to 1 week. If you have the opportunity to see them in that period, don't hesitate to intervene. Most of us, we've been taught that nothing can be done at this stage. It just had to be drops, something, that's all. See later, the eye is gone. But no, there is enough and more evidence now to prove that if you are able to address cases like this within the first week of occurrence of Stephen Johnson, the outcome is huge compared to not addressing. By addressing, what we do, you do a amniotic membrane graft. Okay, in this case, if the pictures are not very clear because of it was taken in the ICU, if there is any erosions or ulceration in anywhere in the ocular surface, tarsus, bulba, conjunctiva, cornea, that is an indication for amniotic membrane. And how do you do amniotic membrane? Drape it from lid margin to lid margin along with topical steroids and antibiotics. Sorry, this lady, we did at 15 days, I believe, and then this is how it healed. Vision reasonably okay, but then what is seen here is you can dense lid margin keratinization with epitheliopathy because of that rough tissue rubbing on the cornea. Underwent mucous membrane graft, and at 3 months after mucous membrane graft, this is a vision. And finally, this is another case. If you can see the difference in inflammation, mucous keratinization after mucous membrane. So finally, rushing through because of the lack of time, end stage disease like this, where you cannot transplant any ocular tissues, what do? You think about keratoprosthesis of the different types. If the adnexa is normal and it's a normal wet eye, so you can do a Boston keratoprosthesis, or if it is a dry keratinized surface, the only option is a modified osteoodontokeratoprosthesis, which gives excellent visual results. Thank you. And at this stage, I'm proud to say that we are 25 years old. This is our silver jubilee year, and in this year, again, I'm happy to announce that we have initiated the modified osteoodontokeratoprosthesis program at Giridhar Eye Institute with ample support from SSM Foundation. The program is started as a non-profitable, not-for-profit program, and the idea is to help these unfortunate patients as much as possible. And we cordially invite you for our CME on September 18th. Thank you.
Thank you, Vinay, for the excellent presentation. You have covered almost all the important areas.
Thank you.
And the importance of the maintaining tear film in infective, infiltrative, even degenerative and post-surgical cases of cornea. So thank you for that presentation once again. And now we can have a short panel discussion, and meantime we have to arrange the stage for the inaugural function also. So can I ask Sanjana, what is your experience of DALC in this keratoconus?
This gives good result in DALC. I basically prefer a layer by layer technique of DALC. So as I said, if you are going by the OCT classification, and if the scarring is in the superficial areas and at least 150 microns of cornea is clear and spared in the deep level, then DALC works very well for these patients actually, ma'am. So that spares the endothelium of the patient, thus going more for DALC in keratoconus patients is much better, ma'am.
And opinion regarding rose scale lenses?
That's all, ma'am. Rose scale lenses, if patients having good fitting, advanced keratoconus who have almost more than 60K diopter of curvature will not help with the rose scale lenses. They prefer scleral lenses. But otherwise, if patients are compliant to wearing the contact lenses, ma'am, they work very well for the patients, and it delays keratoplasty actually. We have seen patients who are having a vision of CF 3 meters who have improved very well with the rose scale lenses, and couple of them with scleral contact lenses. They improve almost up to 6-9. because of which we can delay their keratoplasty procedures for such patients, ma'am.
And how long we can wear one rose care lens? It's very
It
costly
comes
also.
it comes almost for 3 to 4 years, and polishing, as long as yearly polishing of the contact lenses are done, it comes for a very long time. So cost effectivity is much better compared to other lenses actually.
Thank you.
Yes.
I also have a question for you. Suppose a patient has undergone a C3R and you still see there is progression. So what would you do next?
See, normally they say that this collagen linking effectivity is at least for 7 to 10 years is what the research says. So in patients who are keratoconus above 20 years, very rarely progression is seen following C3R. But there is no contraindication for repeating C3R if the patient has undergone it at least 5 to 6 years before. And if the corneal thickness is still above 400 microns, then there is no contraindication in repeating the C3R. But that very rarely happens where we see progression if it's a slightly older patient. But very young patients at the age of 7 or 8 years undergo collagen cross-linking, there may be high chances of progression when they come to their 20s actually.
On the age-wise, is there any contraindication when you would, how long you would wait to do a cross-linking, collagen cross-linking?
No.
Have you done very young?
No, I don't have a personal experience in doing it in a very young patients, but definitely senior cornea consultants have also have an experience of doing it at the age of 6 years, 7 years. They have done collagen cross-linking. But what is their experience report is that after 10 years of cross-linking, definitely there will be signs of progression. So in such cases, if the cornea has good thickness, then these patients might require a repeat collagen cross-linking. So the best results would be to do an early cross-linking, because younger patients have more commonly associated with eye rubbing. So in such cases, preventing the eye rubbing as well as going ahead with the early cross-linking is better.
Can I ask you also one question?
Yes.
Here.
Yes.
Yeah. Right. If it is not it's a non-progressive type, would you still do a CTR?
No, sir. If it is a normally my preference is patients who are about 26 years, and if it's a male patient and they are first time visiting with a vision of 6/6 yet showing keratoconic changes, I would prefer to follow up every 6 months, and only if I see a progression, then I go ahead with the collagen cross-linking for these patients. But if it's a female, unmarried, then in such cases pregnancy would lead to a progressive episode of keratoconus. So such patients I would prefer doing collagen cross-linking. But preferably I avoid doing patients collagen cross-linking if their vision is 6/6 and they are slightly above 26 years. Because normally post C3R again there will be a vision drop at least for 6 to 8 months, which will generally come back, but the patients are not very satisfied in such cases. So.
And how do you actually judge a cornea whether it is progressing or not progressing?
Based on the topographic findings, sir. So when the patient...
What interval?
First, when the patient presents, so I get their pentacam done, sir. So the K value, K max value, the anterior and posterior float values, as well as the pachymetry. So these are the 4 parameters that are taken into consideration. So if I feel that the pachymetry is decreasing by 10 to 15 microns, or if there is a K max increase by 1 diopter, or if there is anterior posterior float elevation again by 5 to 10 diopters, then we go in for C3R, sir. So.
Thank you.
Welcome.
My question, how you will manage acute eye drops with perforation?
So generally acute eye drops is more of a decimate membrane perforation. So they present with acute stromal edema. So perforated corneas are slightly less likely in such cases. So when we do an ASOCT and we find that the anterior surface is intact and there is only a break in the DMs, immediately these patients are taken over to the theatre. Either air bubble is injected or SF6 can be injected, sir. And sometimes if there is a large tear, a traction suture might be required in these cases, sir.
Compression sutures?
Compression sutures. So
okay.
our main aim is basically to bring down the stromal edema so that there is a healing with the simple scarring without vascularization. So that in future these patients can be fitted with contact lenses, or these patients can go ahead with the anterior lamellar keratoplasty, sir.
Okay. Any role of piggyback lens?
I don't have much of a personal experience, since with the advent of rose scale lenses and scleral contact lenses, piggyback lenses are not very commonly used these days, sir. and patients are compliant. If they are told to wear it in a particular manner, where initially they wear it for 2 to 3 hours a day, and slowly over a period of a month they get used to these contact lenses, then they are very compliant to them, sir.
Thank you, madam.
Any questions to Dr. Vinay? Anyone?
Yeah, before that, can I add a couple of points here?
Yeah.
Like any disease, in keratoconus, our aim of treatment is to give good vision to the patient. So the entire, from entire gamut of things presented, how do you choose which one for which patient? Okay, that is a question which has to be answered here. Okay, so first thing is glasses. Okay, what is the vision with glasses? Is the patient happy with the vision with glasses? If not, contact lenses. Okay, these are the two things which are used for visual rehabilitation in these patients. Okay, now the decision on C3R or Intax or keratoplasty depends on the vision. Okay, patient has absolutely good vision with contacts and comfortable with contacts. The idea there is to maintain that. Okay, so then you think about C3R. Whether do C3R is based on what Dr. Sanjana said. It depends on the progression or not. Right. Now consider a case. Okay, patient is not happy with contacts. He is not tolerant to contacts. Okay, he is coming to you for the first time. What is the point in doing C3R for that patient? Practically nothing. Okay, and most of these cases who are not tolerant or not able to maintain contact lens are extreme cases where Ks are more than 58 to 60. In such cases, I would say there is no role for C3R here. You have to think of ways to make the cornea better. And how do you do that? Probably Intacs in a very small group of patients, but majority of them will need a transplant. Okay, so in my practice, when a keratoconus patient comes first, what I do is, if spectacle vision is not good, I send them for a contact lens try. I don't personally do a contact lens myself. We have a very good contact lens clinic, very trained optometrists to do that. Okay, they try from A to Z of contacts, from soft lenses to scleral lenses, everything. Which is the best one the patient gets, or gets a fit. If with that the patient is happy, his vision is good, then I advise C3R. Otherwise, that is surgery.
Now,
just to add to that, like sir said, we shouldn't be thinking of how to do C3R for a patient. You should be thinking of how to improve the vision. So nobody should. I've had the misfortune of doing dial more than 4 or 5 patients who had undergone C3R in the past. So we shouldn't be thinking about how to do C3R. We should be thinking about how to visually rehabilitate. So nobody should have to do a dial on a patient who has undergone C3R. That is one thing. And the other question that sir asked, when to do C3R, absolutely, if there's progression or if there's a high risk of progression, that is very young patients with a very bad allergy, which you are almost sure will progress, there I would like to do C3R before waiting for progression. Or patients who are not coming for follow-up, who are not going to come for follow-up, who are going abroad or etc. And the other group is, we have a latest modality which is very much in vogue now, only in few centers though. We do have it. It's called topo-guided PRK with C3R. It also provides some amount of visual rehabilitation. And the past 1.5 years I've had experience with it, produces fantastic results. It also has provided uncorrected 6/6 vision in many of the moderate keratoconus patients that I've had. So in those patients, obviously, when you are doing a topo-guided PRK, you will have to do a C3R. There you are not looking at progression, because you are already weakening the cornea with the PRK. You have to strengthen it with C3R. Yeah.
So thank you. Dr. Prashok Mohan, Dr. Sanjana and Dr. Vinay Pillai, as we are running short of time and we have to go for the inauguration, we are concluding this session here, and thank you all once again. Thank you.
Thank you all for the wonderful session. Now I request Dr. Rachel Jose to come forward to give memento to the speakers and moderators.
I welcome Dr. Prashok Mohan to receive the memento. I welcome Dr. Vinay S. Pillai to receive the memento. I welcome Dr. Sanjana to receive the memento. Thank you, Dr. Rachel. I request Dr. Samuel Chitranjan sir to come forward to give away the mementos to the moderators. I welcome Dr. Sabida to receive the memento. I welcome Dr. Reshmi P. Haridas to receive the memento. Thank you, sir. Now we will move on to the inauguration ceremony.
A very good morning to all of y'all. To begin with the inauguration, I would like to request Dr. Rosu to come here for a prayer song.
എങ്ങുമെങ്ങും നിറയും വെളിച്ചമേ എൻ കരളിൽ കുടിയിരിക്കണമേ എൻ്റെ പാദമിടറാതിരിക്കുവാൻ എന്നും എന്നിൽ ദയ ചൊരിയണമേ എങ്ങുമെങ്ങും നിറയും വെളിച്ചമേ എൻ കരളിൽ കുടിയിരിക്കണമേ എൻ്റെ പാദമിടറാതിരിക്കുവാൻ എന്നും എന്നിൽ കൃപ ചൊരിയണമേ പൂവിലൂറുന്ന പുഞ്ചിരി നീയല്ലോ പുസ്തകം തരും ജ്ഞാനവും നീയല്ലോ പുല്ലുമാടവും പൂമണിമേടയും തുല്യമായി തൊഴും ശക്തിയും നീയല്ലോ എങ്ങുമെങ്ങും നിറയും വെളിച്ചമേ എൻ കരളിൽ കുടിയിരിക്കണമേ എൻ്റെ പാദമിടറാതിരിക്കുവാൻ എന്നും എന്നിൽ ദയ ചൊരിയണമേ നല്ല ചിന്തയായി എൻ്റെ മനസ്സിലും നല്ല ഭാഷയായി നാവിൻ്റെ തുമ്പിലും നല്ല ചെയ്തിയായി എൻ്റെ കരത്തിലും നന്മയാം നീ കടന്നിരിക്കണമേ എങ്ങുമെങ്ങും നിറയും വെളിച്ചമേ എൻ കരളിൽ കുടിയിരിക്കണമേ എൻ്റെ പാദമിടറാതിരിക്കുവാൻ എന്നും എന്നിൽ ദയ ചൊരിയണമേ
I have the opportunity to introduce some eminent personalities to be welcomed on the dais. To begin with, we have Dr. Rachel Jose. Madam is the president of Pathanamthitta Ophthalmic Society. She is completed MD from AIMS, following which she has worked for almost 20 years in the Ministry of Health as NPCB program manager, and she then retired as an additional director general in the Ministry of Health. So after retirement, she's worked for a couple of years at St. Mary's, Ayan Nagar, New Delhi, following which she shifted to Trivandrum. So at Trivandrum, she's worked for 4 years as medical superintendent in Geetanjali Hospital, and currently she's running a clinic at her residence at Tiruvalla. Madam has been conferred various prestigious awards for her academic as well as professional work. Madam, kindly come to the stage. We next have Dr. Arup Chakravarti sir. Sir is a senior consultant at Chakravarti Eye Care Center. He is currently the president of Kerala Society of Ophthalmology. Sir has been conferred multiple awards, both national as well as international. He has received the Senior Achievement Award from American Academy of Ophthalmology. At the national level also, he has received a lot of best paper awards as well as state awards for the best paper. I welcome you to the dais, sir. Dr. Samuel Chittaranjan sir. He is the medical associate director of Believers College. So sir is a leading orthopedician specialized in arthroplasty. So he's been the associate director and HOD of orthopedics at CMC Vellore. He has been training a lot of young orthopedic surgeons, especially in spine and microvascular hand surgery. We welcome you, sir. We next have Dr. Philip Kuruvilla sir. He completed his MBBS from CMC Vellore, followed by PG in CMC Ludhiana. So for almost 1985 to 2000, he's been working at as a chief in GMI Hospital, Mettupalayam. Following which he came to Kerala in 2000 and founded the Aradhana Eye Care Center. So he's having 4 branches of Aradhana Eye Care, and he's received the Gullison's Award from Canada for excellence in ophthalmic work. We welcome you, sir. We next have Dr. S.J. Sai Kumar sir, who is the president-elect of KSOS. Following his ophthalmology course at Government Medical College Trivandrum, sir did his fellowship at anterior segment in Lotus Eye Hospital, following which he's had more than 20 years of experience in the field of cataract as well as glaucoma. He's been holding multiple posts in Kerala Society of Ophthalmology, and currently, as I mentioned, he's the president-elect. We welcome you, sir. To join all of them, we have Dr. Satish Thomas sir, who is currently the HOD of Believers Ophthalmology Department. Following his postgraduate ophthalmology at RP Center, sir specialized in pediatric ophthalmology and strabismus, following which he received the FICO by Sydney. So he's been the faculty of Christian Medical College and Hospital in Ludhiana for 15 years, following which sir joined Believers Eye Hospital. Yes. We welcome you, sir. We would like to have a few words from the Dr. Rachel, ma'am.
Good morning, friends, and welcome to this CME Nethram 22. This physical CME is being conducted after a long time, maybe after about 2 years. So we could not do much because of the corona. Today we are conducting sessions like cataract, cornea, glaucoma and oculoplasty. Another important thing I want to mention is the National Eye Donation Fortnight. I think Sanjana must have forgotten, she's a cornea person. She could have mentioned about the National Eye Donation Fortnight. It is being celebrated all over the world from August 25th to September 8th. A lot of activities are being done in the form of encouraging the eye collections, diagnosing the corneally blind patients, earlier diagnosis of corneal blindness, and also do more and more keratoplasty so that the poor corneal blind persons are benefited. We in Kerala, we collect maximum number of corneas from LV Hospital Angamali and LV Prasad Institute of Hyderabad. Dr. Arup is the owner of the, as well as the CEO of the Chakravarti Eye Center. I think the detail has already been talked about. He is the present KSOS president. He's a very reputed and dynamic personality. I had interaction with him when I was in Trivandrum for 4 years. We worked together in many places. And I welcome you, sir, to this our CME Nethram 2022. Thank you for coming and finding time to grace the occasion. Dr. Samuel, the Associate Director of Believers Hospital. He is, as already mentioned, is an orthopedic doctor. Thank you, sir, for giving this beautiful auditorium, for conducting this CME. This is a thank you very much, and also we are welcoming you to this CME. Dr. Satish Thomas, HODI department. He is also an alumni of RP Center like me. He worked in PGI Ludhiana for many years. From 2016, he is in Believers Hospital. He is the head of the department as well as head of pediatric ophthalmology and skin. I welcome you, Satish. Lots of encouragement has been given by you to our society by you. Thank you and welcome to this CME. Dr. Philip Kadula, CEO cum Chief Eye Surgeon in Arasana Hospital, Manakad. Apart from cataract surgery, he is taking interest in all specialties like oculoplasty, squint, and cornea. I think he is a multi-speciality doctor. He worked in UP, Karnataka, Uttarakhand, Himachal Pradesh. I know him when I was in the blindness control program in Delhi. Dr. Sai, welcome you, Dr. Philip. Dr. Sai Kumar, the medical superintendent, head of the cataract and glaucoma in Giridhar Eye Hospital, Ernakulam. Apart from academic and clinical work, he is also interested in lots of KSOS activities, held almost all the positions in KSOS. Now he is the president-elect. I welcome you, sir, to this CME. Thank you very much for coming and gracing the occasion. Now I welcome all the speakers of the 4 sessions, the moderators. They came and they could find time to spend time with us and grace the occasion. I welcome my society office bearers like Leena, Sumi, Sanjana, Chaitanya, Sabita, Kartika and Shishir. Without their support, I could not have done much to make this CME possible in this Believers Hospital. I welcome all the society members, all eye surgeons who have assembled here today to take part in the deliberations and discussions. I also welcome all sponsors, everyone who is associated with the CME, and also welcome all the participants of the CME and also thank them for finding time to attend the CME. I hope the discussions and deliberations is going to help a lot. I welcome all the PG students who have come from various medical college and eye hospitals prepared for the PG quiz program. I wish them a success for their work. Thank you very much.
As a part of eye donation fortnight, we at Chaitanya Eye Hospital, Tiruvalla are conducting certain activities which will run along from this Monday to Saturday, which will involve the staff as well as the patients who are visiting. So it basically trying to create certain awareness on eye donation and the importance of donating the eyes, and also regarding myths and certain facts about eye donation. So I'd like to request Dr. Arup Chakravarti sir to come and give the inaugural address.
Respected dignitaries on the dais and off the dais, dear friends, very good morning to you all. I'd like to thank Pathanam Thitta Ophthalmic Association, and rather congratulate them for having a physical meeting. Last time I think I attended a meeting here was in 2019 when the Kerala chapter of SICS was inaugurated here, and then now we are having the second meeting. So congratulations for conducting this meeting. I'd also like to thank the organization, thank the club for involving KSOS, for doing it under the banner of KSOS, and we really appreciate this gesture. And I, as president of KSOS, feel myself privileged to be delivering the inaugural address on behalf of the 2,500 plus KSOS members. The program, of course, is great, and we have seen the cornea talks, and these have really international class talks. Unfortunately, we couldn't have much discussion on this. I would just want to make a few points about our society activities. It is Kerala Society of Ophthalmic Surgeons, not any other term that is used for our society. So we are on a membership drive. So would can I see a show of hand about how many of you are members of KSOS here? All of you members of KSOS. That's really heartening. I'm really very glad. And how many of you are members of AIOS? So I think almost about 80%, 75 to 80% are members of AIOS. So that is also, as president of an organization, I think that is quite heartening to see this. Another, I would like to thank the organizing committee. Dr. Lena had been in touch with me so many times. In fact, on the way itself, I kept getting messages whether I'm lost on the way or not, though I was, I had the Google to help me out. So one interesting thing, why I mentioned this incident is one interesting thing about this particular CM is it is not live, not going live. So which is quite rightfully so, because we see a lot of delegates here, and if it was live going on, streaming live on YouTube or the various the Facebook, then many people might not have come. So I think in a week's time it is going to be, it is getting captured and it will be put up on the on-demand on the KSOS website, and all of us can view whatever the deliberations has happened. Okay, now KSOS has been very active. There has been number of CME programs, webinars. There has been PG classrooms. There has been journal clubs, and it is the people there, the secretary, the scientific committee chairman, the treasurer, journal editor. They're doing tremendous work. So we just want to, as office bearers of KSOS, we want to harness their energy and streamline it in such a way that KSOS benefited to the hilt. So with that in our mind, we have been trying to have the standard operating procedures for the society. We already have a financial audit committee, and KSOS is one of the cleanest organizations that I have ever seen. I am a member of more than 20 state level organizations in the country, and financially this is absolutely squeaky clean. We are also trying to introduce an administrative audit to ensure that, as I just mentioned, the tremendous amount of energy that all of us have, all the office bearers bring in to the organization, that is streamlined, and even after they have left their office and new members take over, the good activity is continued, and it is again going to be amplified more than that. A few upcoming events that are happening. We are going to have a leadership development program. It has not happened in KSOS before, but we have very vibrant and very energetic, very enthusiastic members from KSOS who participate in the AIS LDP program. So something like this is going to be recreated, and it is happening the last weekend of October, Saturday, Sunday. And we are also going to have a family get-together after a lapse of couple of years, again because of COVID. So I would like all of you to, like to encourage all of you to attend the family get-together. Gopal has selected the venue. It is close to Cochin, about 1 hour's drive. It's a Mahindra resort, Mahindra resort, and it's a very nice place. Though I haven't visited, I've seen the pictures. It's very nice. So please come and attend that meeting. And our annual meeting, Drishti 2022, is happening in Kozhikode, And I know the local organizing committee is putting in extremely tremendous efforts to make it a total success. It is going to be after a gap of so many years. Last meeting was in 2019, isn't it, Sai? 2020, 21 you didn't have, we had, Trichet was the last meeting. So we are expecting huge numbers, humongous numbers, and when the local organizing committee is gearing up, and our scientific committee chairman Srini also has, and we have a couple of members, and Prashov is sitting here, he is one of the scientific committee members. There has been a lot of submissions in terms of instruction courses and free papers, videos, posters, etc., invited programs. So it is going to be an absolute feast, academic feast. I would like all of you to come and attend, participate as a delegate as well as faculty for the annual meeting. So with these words, I would like to wrap up my presidential address and wish this meeting all the best.
I would like to request all the dignitaries gathered on the stage to join for the lamp lighting. Now I would request Dr. Samuel Chittaranjan sir to speak a few words.
Dr. Arup Chakravarti, the president of the KSOS, Dr. Rachel Jose, the president of the local chapter, other dignitaries on the stage, Dr. Satish and colleagues, presenters and delegates. It's my great honor and privilege to welcome all of you to Believers Church Medical College Hospital. And we are very happy and proud that Nethram 22 is being conducted here today. And at the outset, I would like to wish all success in every way for this meeting, this conference, and coming together of the ophthalmologists of this region to share your expertise, to increase your knowledge, and to support each other. As an orthopedic surgeon myself, I suppose I'm far away from the eye. The only time we ever meet is when some patient is on chloroquine, and so we have to refer the patient to the ophthalmologist to make sure that it's not causing a problem. And And when you're young and energetic and you have no problems, you're not aware that the senses that we possess are only for a short period of time. And so the traditional 5 senses, we begin to start losing them as we get older. And at a certain stage, things become quite critical. And I myself have had the privilege of getting help from ophthalmologists in many places. And I must thank all of you for keeping me going so that I'm not stuck in darkness, but I can still see something. Also, I must share this one event where I went to see my ophthalmologist, and as a routine, they did a field of vision test, and they discovered there was some problem with that. And so I was shunted off to get a brain scan, and it was discovered that I had a huge subdural hemorrhage. I had fallen a few days before that, and I didn't realize that I had a problem. So because I went to see my eye doctor, this was noticed, and I had emergency surgery to set that right. So there are many ways in which the whole body of ophthalmologists is so important for all of us, whatever the age. And so I must once again thank you and welcome you very warmly, and wish the CME program all success. Thank you.
Thank you, sir, for your wonderful words. Now request Dr. Philip Kuruvilla, sir, to come and speak a few words.
I want to thank the Pathanam Thitta Ophthalmic Society, Dr. Rachel Jose and Dr. Leena especially, and the team here for inviting me. I just want to emphasize one thing, and we ophthalmologists, the positive impact that we give to the nation and the building the nation is fantastic. You must realize this. And the ophthalmologists, please remember that you are not doing this work just to get some money, some salary, but really we are helping the nation. The media will not accept it, and they will not give any credit for it. But just imagine, it is like a splash and a ripple. And a patient comes to you and you give glasses, or you treat just conjunctivitis, or treat glaucoma, or diagnose a diabetic retinopathy, or diagnose a glaucoma, or operate on a cataract. And now that is a splash. Some relatives come, some noise is made. But the ripple effect is fantastic. If a person's eye is restored, vision is restored, what happens? He can go back and work, earn a living. Or if he's old and he cannot work, he can be at home so that the children can go for work, and he can look after the grandchildren. And the economy of the house gets built up. And many thousands and thousands and thousands of families are helped, and economy is helped. And please remember this, our mission is something very noble and effective. And people may not accept it, but then we should have that intrinsic satisfaction that we are doing this great work. Now, when I was a very young ophthalmologist, I took up ophthalmology thinking that there's tremendous amount of need in India. And at that time, they said 15 million blind and 9 million are cataract preventable blindness. Curable blindness. But now I find, I looked up Google, and one paper says now the blind people in India is 31 million. And another paper says, some controversy there, another one 22 million. Out of that, 80% is cataract. So we haven't done much, because the number of people living above 50 has become older, is more, and there is more work to be done. 3.6 million patients are getting blind due to cataract every year. So then to backlog, we have to work hard. So think about these things, and please remember that you are doing in a very noble profession. Thank you very much.
Thank you, sir, for those wonderful words. I would request Dr. Sai Kumar, sir, to please come and speak a few words.
I am a misfit for this. No. For that platform there. Yeah. So, Rachel, madam, Samuel, sir, Dr. Arup, my president, and the wonderful hosts of Pathanamthitta Ophthalmic Society as well as Believers Church Medical College. It's a real privilege to be here. Nice morning. Not a very big crowd, but a very attentive crowd. And I'm sure all of you are going to be really benefited by the deliberations in today's meeting. It is nice to see, because Pathanamthitta Ophthalmic Society for many years, it was just Sabita. Whatever you want, you ask Sabita what is happening in Pathanamthitta. We have a very vibrant team now. Thank you, Rachel madam, for building up this new team. And I look forward to interacting more with you, because I am the next president of the KSO. So the next 1 year I am going to be behind you to conduct more programs. And thank you very much, and wonderfully organized CME. And special thanks to Dr. Leena, who did fellowship with me, one of my best fellows. It is nice to see that she has organized this meeting very well. So I wish you all the best. Thank you.
Thank you, sir. I would now request Dr. Satish Thomas, sir, to come and speak a few words.
Respected dignitaries on the dais, off the dais, my colleagues and friends. I think about 3,000 years back, King Solomon, who was considered one of the wisest people, said, "Of the making of many books there is no end, and much study wearies the body." Then why have one more conference, isn't it? We now live in a world where there's so much information explosion. Information is right at our fingertips. In such times, what we really need is wisdom and perspective. What do we do with what we have? And for that, we really need perspective. We need to take a step back to see the bigger picture, to know where this one thing fits in with everything. And so that's where I think we need to take time off from our routine work, daily work, where we are too close to what we see. So a wider field of view would help us gain perspective. Wider, not just wider because it spans our view across disciplines, and also against the broad sweep of time. How would something stand up against the test of time? Things like that. So a wide field of view would help us. Another thing that would help us gain perspective is binocular vision. How to hold two different views in tension. And so that's something again that we can gain from this when we hear slightly different perspectives. And the third faculty that can help us develop a perspective is color vision. That life comes with different hues of color, nuances, rather than just the black and the white. So I hope that this conference will also help us gain perspective and wisdom. And I really want to thank Pathanamthitta Ophthalmic Society for helping us to host this CME. And I hope all of you have a great time. Thank you.
Thank you, sir, for those motivating words. Now we will be concluding the inaugural session by the vote of thanks by Dr. Leena.
Thank you, Dr. Sanjana. Respected dignitaries on and off the dais, my colleagues, friends, and my students, a warm welcome to each one of you. It's indeed a great pleasure for us, Pathanamthitta Ophthalmic Society, as well as believers, to conduct a physical meeting after so long, to renew our bonds, to re-energize ourselves, to meet new friends. First of all, I would like to thank our God Almighty. With His grace, we have been able to organize such a good CME. I, on behalf of Patnamthitta Ophthalmic Society and believers, would like to express my gratitude to our KSOS President, Dr. Arup Chakrabarti sir, for coming all the way from Trivandrum in between his busy schedule to be with us and share his knowledge. It's a privilege to have you, sir, here. Thank you. I thank Dr. Samuel Chitranjan sir, our Associate Director, for being here to bless our occasion and supporting us in our CME. I'm thanking you, sir. I'm grateful to our management, Sijo Achan and Director George Chandi sir, for encouraging us and letting us conduct the CME in this wonderful hall. I especially thank Dr. Philip Kurla sir for taking that extra effort to come here and share his experience with us. Thank you, sir. I am grateful to my sir, Dr. Sai Kumar, for coming down to our CME and being with us and to give us his advice regarding all his experiences. I would like to thank Dr. Rachel Jose, madam, our president, for being there with us from the beginning of the CME, encouraging us, guiding us throughout every step. Thank you, madam. I especially thank our HOD, Dr. Satish Thomas, sir, for helping us and telling us what to do, what not to do, and being with us in the CME. Thank you, sir. Without you, the CME would not have happened. I'm really grateful to our seniors in our society, Dr. Shane, Dr. Verghese sir, Dr. Amita Verghese, Dr. Sabina madam especially, for going on encouraging us and helping us to conduct the CME. They were always ready to give us advice and help us with this. I am blessed and I thank God for my wonderful team, Dr. Sanjana, Chaitanya, Karthika, Sumi, my colleague Rosu, Jacob sir, Shaji sir and Saju sir for helping me organize the CME. I especially thank our operations team who has helped us organize the CME. I'm thankful to Ronnie for this wonderful brochure. Thank you Mahadeva Audiovisual for the spectacular arrangements. I thank our transportation team and canteen for helping us with our CME. I thank all the pharma companies for the support they have given us. My love and thanks to my students who have been there with us for making sure that all the things have been going on well in the CME. I express my gratitude and thanks to all the doctors who came to our CME. I hope we have a wonderful session. As Albert Einstein said, we learn from yesterday, we'll live for today, we hope for tomorrow. The most important thing is not to stop questioning. So we'll have a wonderful session. We have so many experienced doctors with us, so we can go on questioning them throughout. Enjoy the CME. Thank you.
I request everyone to come to hall for the next session. Now we'll start our second session, cataract. Moderators for this session are Dr. Verghese Joseph, Dr. Rachel Jose, and Dr. Sai Kumar. We welcome Dr. Verghese Joseph. Dr. Verghese Joseph completed his MBBS and DO from Maulana Azad Medical College, New Delhi, and MS Ophthalmology from Lady Hardinge Medical College, Delhi. He completed his fellowship in vitreoretinal surgery and phacoemulsification. He was awarded Rambo Medal for Best Postgraduate. He has many publications and presentations in journals and conferences. We welcome you, sir.
Now Dr. Rachel Jose, after completing her MD and senior residency from AIIMS, she was working as ophthalmologist in Safdardjung Hospital, New Delhi for 30 years. She was NPCB program manager. She retired as the Additional Director General in Ministry of Health, Government of India in 2010. She received various prestigious awards for her academic and professional works in her career. She has also published various clinical and research papers in various national and international journals.
Dr. Sai Kumar S.J. completed his graduation and post-graduation from Government Medical College, Trivandrum. He did a fellowship in anterior segment in Lotus Eye Hospital, Coimbatore. He has more than 20 years of experience in this field. He has made a number of presentations in many international, national, and state meetings. He has held many posts in Kerala Society of Ophthalmic Surgeons, including editor of journal, chairman of scientific committee, and as honorary secretary. He is currently the medical superintendent of head of glaucoma and cataract in Giridhar Eye Hospital. We welcome you, sir.
Now, we welcome Dr. Arup Chakrabarti onto the stage to talk about optimizing IOL power calculation. Now, Dr. Arun Chakrabarti completed his graduation and post-graduation from JIPMER. He completed his fellowship in IOL and anterior segment microsurgery at Aravind Eye Hospital, Madurai. He has an experience of 36 years in his field. He was elected as the Vice President of KSOS in 2019. He has received many international awards like Best Paper of the Session at American Society of Cataract and Refractive Surgery meeting in San Francisco 2009, the Achievement Award by the American Academy of Ophthalmology in 2011, to mention a few. He is the president of KSOS and is currently a senior consultant at Chakravarti Eye Care Hospital, Trivandrum. We welcome you, sir.
Thank you.
We have already introduced you a lot, so it's better that you start with your sessions. You will be talking on optimizing IOL power calculations, Dr. Arup.
Yeah. So, good morning once again to everybody, and thanks for the double introduction. So, when the organizers got in touch with me regarding the topic, and I had a discussion with them, so I realized that it won't benefit much if I talk about cataract surgery in complex situations. I have dealt with all kind of complex situations, I have videos, but I thought I'll talk on a topic which is close to my heart and which is of general importance to all ophthalmologists. So I'll be talking to you about optimizing IOL power calculation. Nothing financial here. It is a cliche to say that cataract surgery has become refractive surgery. We always want to hit the bullseye each and every time we perform cataract surgery. The holy grail is plano 6/6 or whatever be your target refraction. So as we begin our journey as a refractive cataract surgeon, we need to know our destination. Where do we have to reach? So I will give you an answer to this question from this particular evidence in the literature, a study by a friend of mine, Giacomo Savini from Italy. So this was published in JCRS a couple of years back, and he used the best formulas, the most current formulas, and used measurements obtained, that is axiometry and all this biometry obtained through a swept source OCT based biometer. And he found out, and results are quite interesting, that 88% to 90.67% of normal patients can get a vision within a refractive error or a prediction error of 0.5 diopter. So this is where we stand today. Can we go beyond that? People feel that it may not be possible at present because we have reached the upper limit of biometry. We are getting very accurate results. Formulas are doing extremely well. And there are certain uncertainties. We know about the effective lens position. We are not able to predict it, and there may be some other uncertain factors. So I think this is where our bar is set right now, and our journey should be to reach that particular destination. Now we have been helped in this process by the newer devices and equipment that have been coming up in the market, or software upgrades or hardware upgrades of the existing machine. We are having newer and newer formulas, or the older formulas are going into newer versions. And then the lens constant optimization concept is something which again we have all understood. So I'm going to talk to you about the current standard operating procedures that I follow for my cataract patients. This is a very dynamic presentation. The slide deck that I have keeps on changing depending upon my post-operative outcome. I track each and every patient that I operate upon, the refractive outcome, the literature that I see that come up in the journals, and peer review, like whenever a new lens comes up, and I talk to my friends and how the new lens has been doing in the market. So it keeps on changing. So what I talk today is valid as of today, and it may change during my next presentation. So what I have learned over the decades, that IOL power calculation is not a one-off event which has to be ticked off in the preoperative checklist of a cataract surgery. No, it is an experience. It is a process. It is an experience which pervades the preoperative period, the intraoperative period, as well as the postoperative period. Patient examination and evaluation is very important. Before a patient goes for a cataract workup, I would like to know what are the sources of vision loss, because many patients may have additional sources of vision loss and they get automatically ruled out for certain type of intraocular lenses. Then I also look for factors which may make biometry difficult. For example, patient with a staphyloma, patient with strabismus, patient with nystagmus, post-polar cataract, or very advanced cataract, so on and so forth. So I would know how to interpret the biometric results. Over the years, we have learned that ocular surface is very, very important, and Dr. Vinay gave a very nice lecture on ocular surface related issues. So what we have realized that cataract happens at an age where ocular surface disease is very common. More than 50% of the patients who present to us for cataract surgery have ocular surface disease without any symptoms. Only when you look for them, you find out that they have some issues with the ocular surface stability. And this may adversely, a jeopardized ocular surface may adversely impact the keratometry. So much so that you may end up with the wrong axis of the astigmatism, you may end up with the wrong absolute value of the keratometry. So this definitely will not mark the results of toric IOL or toric IOL or multifocal toric IOL, or even for routine IOL. So please make sure that when a patient comes to you for the first time for cataract surgery, you have the cataract workup done. That's what I do, and then get the other evaluation done. No contact procedure should be done before the biometric evaluation is performed on the patient. And sometimes when a patient comes without being aware that he requires cataract surgery, and at the end of the day, when you have performed all the tests, you have dilated the patient's eye, done a contact gonioscopy, appendician tonometry, so on and so forth, it's better to call the patient back on another day for the evaluation for biometry. Or if you do it on the same day, and then I would definitely tell the patient that it is important that you come on another day for me to reconfirm. I want to get 2 consecutive values which are more or less the same. So basic idea is to perform your keratometry on a virgin cornea. There should not be any previous contact procedure that has been performed on the patient. So this is what I do. So recently I was surprised to see an article with a contrarian point of view. It said that the Goldman appellation tonometry did not significantly change keratometry or axial length measurements. So but one swallow doesn't make a summer. But if this is true, then it saves us from a lot of hassle. We can perform all the workup on the same day instead of asking the patient to come back on another day, which may, logistically speaking, be quite impractical from the patient's point of view. Sometimes we dilate a patient's eye for A-scan biometry or even for optical biometry to get better results, otherwise we may not get. So I have always wondered, does the dilatation process alter our biometric parameters, the variables that we measure? In fact, many studies have shown that there is an increase in the anterior chamber depth after pharmacological dilatation. So if we use the multivariable formulas, all the current formulas, not the old generation 2 variable formulas, which use the anterior chamber depth as one of the parameters in the calculation, the results may be inaccurate. So I reviewed a lot of studies, and I'll just present you the latest study, which showed that after dilatation, the central corneal thickness and anterior chamber depth increase, and this is in a statistically significant manner, and the lens thickness reduces. So that if we use the biometric values after dilatation, there is 1/4 of a patient, the range is about 20.4% to 30.6% of your patients, you will end up calculating an IOL power which is half to 1 diopter more than what was required for your target refraction, whether emmetropia or whatever. So basically, remember that cataract surgery patients should receive biometric testing in an undilated state, especially if multivariable IOL calculation formulas are being used. Sometimes, the dry eye patients, we have patients who had Stevens-Johnson syndrome or otherwise, dry eye. We may have a tendency to put a lubricating agent before we perform the biometry, which is not really desirable, but sometimes we end up doing it. So if you do that, make sure that you wait for a minimum period of 5 minutes between installation and starting of your biometry, the keratometry, for you to get more accurate results. As I mentioned earlier, it is always better to use one single constant device which gives you more accurate results. And for me, it happens to be an optical biometer. So I no longer perform a manual keratometry or autokeratometry for routine patients. Optical biometry, so this gives me, the keratometry values and all the other variables that are required by the formulas. I also perform a topography and eye trace. This is very important, particularly when you're considering a toric IOL or when you're considering a, multifocal intraocular lens or any presbyopic arrêting intraocular lens. If a patient is on a contact lens, particularly hard contact lens, it should be off the patient's eye for at least 2 to 3 weeks. In spite of our repeated appeal to ophthalmologists that optical biometry is the way to go about it and discard ultrasonic biometry, it is still done. And to make matters worse, contact apprehension tonometry, because I move all over the place and I interact with the postgraduates and junior consultants, it is still being done. Please remember, if you perform a contact apprehension tonometry, apprehension biometry, we can expect a mean average shortening of axial length to the tune of 0.25 to 0.33 millimeter diameter. This particular slide is courtesy late Hygis. He had given me this slide. So this actually is a meta-analysis comparing the performance of optical biometry versus immersion A-scan biometry, not contact, and it shows the red bars that you see is the optical biometry. So the prediction error is within plus minus 1 diopter was much less with the optical biometer. So this is a conclusive evidence that optical biometry is the way to go about it. Now there are wide variety of optical biometers. We have the new ones that I just mentioned based on swept source OCT and the precursor ones, and most of us have been using the precursor ones. So the question comes up, is one particular biometer, optical biometer, better than the other one? Okay, so I just looked into the literature and found out that more or less all the biometers, the basic biometers, the old generation biometers are quite reliable, and they give you almost similar values. So for example, this particular study compared Lenstar with the Aladdin, and it concluded that there was a high level of repeatability and agreement between these two biometers. So you can go for any of these biometers depending upon various other factors, and that is not part of my talk today. Again, for example, the IL Master 500 has now come up with the swept source OCT based. Even the Lenstar also has come up with the swept source OCT based biometers. So if you throw in more money, get the higher end device, do you do it any better? So there was an article in BJO which compared IL Master 500 versus IL Master 700 and found out that agreement between the two devices are excellent. However, IL Master 700 has certain additional applications. It gives you additional features. That has to be accepted. But if you are using IL Master 500, you are still going to get accurate results. Just because you have an optical biometer or a very high-end biometer, can I just take another 5 minutes? Yeah, another high-end biometer. It does not mean that it's not like a magic wand that you're going to get perfect values. So you need to have validation guidelines. So these charts are put up in my the biometry room. So every measurement that is done is validated, whether it falls within the normal limits. And if it doesn't fall, then it has to be deleted and a fresh reading has to be taken. And the surgeon has to know what is going on. Most of the time we relegate responsibilities to a postgraduate student or to an optometrist or a nurse, and we really do not know. They have discussions with the vendors. Should not be the case. You should know exactly what is being done by your staff, and then only you can really control the traffic. You may do a perfect surgery, but advanced technology intraocular lens. But if your biometry has not been done properly, then you go, it doesn't serve any purpose. I just mentioned that in optical biometers, some of them, the older generation may not, the one with the precursor optical principle, the techniques may not function well with advanced cataracts, total cataracts or a posterior polar cataract. So I have a very simple way of dealing with this issue. I look at the fellow eye. If the fellow eye is pseudophakic or has an immature cataract, then I perform optical biometry as well as ultrasonic immersion biometry for that eye and compare the values. If both the values are more or less same, then I assume the technique is doing well, is being utilized well by my optometrist, and I do an ultrasound biometry for the cataract with the advanced eye with the advanced cataract and repeat it twice. And this technique has given me a very, very good visual refractive outcomes. So now I have spoken to you about how to get good values, reliable values, the variables, they have to be accurate, they have to be precise. It is also important for us to have newer, good formulas, current generation formulas. So these are all the formulas. Barrett Universal to a go-to formula for most of us. Heal RBF version 3 has become more versatile compared to the previous versions. What I would like to bring to your notice that the new kid in the block is the Kane formula. And then anybody is using SRK2, show of hands. SRK2 still is being rampant, use is rampant, and a lot of people use it. And I had spoken to Dr. Haggis, asked him, can you give me in writing so that, this is abolished, it should not be used. Likewise, Hoffer Q, anybody is using Hoffer Q? Ken J. Hoffer himself has been advocating against the use of Hoffer Q formula, but since it is not happening, people still use. So Hoffer has modified his formula, Hoffer QST. This is again free, you can get it in the website. This also I have found that it is quite reliable. Now another interesting thing I would like to tell you here is most of these formulas, the Barrett's Universal to Heal RBF are free softwares. They're available in the appropriate website. Kane formula is a free. Eva formula is a free formula. So now if I want to get all the formulas for a particular patient, it becomes very cumbersome. So Dante Boasonte from Argentina, so he developed a website. Actually, this is going to be integrated to the ESRS website because ESRS is the only website which doesn't have an IL calculation formula. So where this is basically this is based on web scraping, so that if you put in the data biometric values in this particular website, it sends information to all the formulas website that you are interested in and collates and gives a simple printout. I think September next month it will be available. Barrett Universal 2, it is my go-to formula. It is everything under the same roof. All your IL power calculation requirements are given in this formula. And it can also be used with immersion A scan. So even if you are not doing optical biometry, you can still use immersion A scan, but you have to use the immersion A constant for this patient. Heal RBF formula again has become quite versatile now. And so basically, Kane formula, it is good for non-toric lenses, keratoconus lenses. And another important concept that has come up is, as intraoperatively again, you have to make sure that your lens is within the bag. You make a central rex is 5 mm with symmetrical overlap on the anterior optic surface. That is very, very important. Post-operative period is the moment of truth. You just do a good surgery, forget about it. It should not, forget it and feel it and forget it. It's not like that. That is the moment of truth. So you need to find out how exactly these lenses are doing, surgeries are doing, particularly new lenses, and then you might have to modify the lens constants accordingly. Another thing that I do is, when the fellow is getting operated, see, experience always makes us wiser. And so I always get data from the first operated eye and see how I have done and use that data to modify the power in the fellow eye. So this is what I follow. The first eye, of course, has to be stable for at least a month. I usually take it 2 weeks. It should be more than 0.5 diopter refractive error. Second eye parameter, there has to be interocular symmetry. Both eyes are similar, in dimension. And your refractive surprise should not happen because of transcription error or IL malposition. So you have to use an adjustment coefficient depending upon the formula to set the target refraction for the second eye that is to be operated. So the Pearl DGS calculator also has a second eye calculator. And the role of gender is again becoming increasingly appreciated. For example, Barrett Universal 2, it is more accurate for the males compared to females, particularly in the extremes of axial length. And remaining formulas are more accurate for the female gender than the male gender. So gender differences are important. So friends, I'd just like to conclude by saying that preoperative measurements must be done on a naive cornea as far as possible. Use validated measurements, work with properly optimized lens constants, adapt to new technologies as they present in a judicious manner, employ the right formula, and strive to use all available resources to their best advantage. Thank you so much for your attention. My apologies for exceeding my time limit.
Thank you so much, Dr. Arup. As usual, there was a wonderful overview of the IOL calculation formulas and methods. In the chart you mentioned, Dr. Arup, the EVO was among the top. Can you shed some light on the EVO, one of the newer?
EVO formula was actually written by a fellow of Dr. Graham Barrett. He's from Singapore, so he has. It is based also on, to a certain extent, on artificial intelligence. And in fact, we had done at KSOS, under KSOS, we have done a webinar on that. It is available on the website. He has found very good results, particularly for the high myopia patients and sometimes low myopia patients. Now, most of these formulas are never published. If you are asking if it is available, no, these formulas are not available. Other than the Hygis formula, it is a published formula. SRK formulas, group of formulas are published formulas. Hoffer K is published, but most of the other formulas are not published. This Damiel Catinel DGH, Pearl GGS formula is published. I tried to read it, too much of mathematics into it. So, EVO formula, Ken has, in this particular study, according to Ken, the Giacomo Savini, so that came on top. And Barrett was 88 point something, and this was 90 point something. So there was just a 2 patient difference for a prediction error between 0.5 plus minus 0.5 diopter.
So the go-to formula across axial lengths is the Barrett's universal.
For me, it is becoming Kane now. For me, it is becoming Kane. Yeah, Kane is also free.
Thank you, Dr. Aru.
Thank you, sir, for that informative talk.
Now we invite Dr. Philip Kurivilla to talk about posterior iris claw lens, an overview. Dr. Philip Kurivilla completed his MBBS from CMC Vellore and post-graduation from CMC Ludhiana. He started doing extensive work in North India, conducting eye camps in Punjab, Himachal Pradesh, Uttar Pradesh, Jammu and Kashmir, operating on many thousands. He was chief of Garnet Memorial Eye Hospital, Mettupalayam. He is the founder of Aradhana Eye Care in Trivandrum. He has received Gullison Award from Canada for excellence in ophthalmic work in South India. He has also received award for excellence in eye work from Sharda Educational Society, Trivandrum.
Thank you once again. Posterior iris claw, I will right. This iris claw lens was invented by Dr. Jan Wurst Holland, and he was for some time working in a Christian hospital in Pakistan. And Dr. Daljit Singh got connected with him, and Jan Wurst invented it, and Dr. Daljit Singh popularized it in our country. Now, this is a anterior chamber iris claw lens, and this is for correcting a high myopia. But one problem was endothelial decompensation. I was in the early 80s, I was working in the Macropod Hospital, Dariwal, Punjab, and I had the privilege of watching Dr. Daljit Singh, those early 80s, and IOL surgery was just coming into India, and but the greatest criticism against the anterior chamber iris claw lens was endothelial decompensation. Those days, seniors among us, maybe Dr. Shobna and Dr. Rachel and many of the seniors will know that in early 80s, nobody knew which was the good lens, where to keep. They had the anterior chamber Kelman lens and AC Shepard lens and pupillary Sputnik lens from Russia, Momose glass spider lens from Japan, Jan Wurst Daljit AC iris claw lens, and regular PC lens in the bag or Salkas IOL. And I put all of this, each and every lens I have put in. And in fact, I wrote an article in Kerala Journal those days about my experience with 500 IOLs of various types. And after some time, everybody came to realize that PC IOL in the bag is the best. So anyway, when nobody knew which was the best lens, an idea came to my mind: why not clip the iris claw lens posteriorly? It was not done earlier. But of course, I didn't publish it, or nobody knows about it. And but then one claw came off after a while, and I gave up the idea. But then I realized it was becoming very clear that a regular PCIOL is the best for regular cataract surgery when the posterior capsule is intact. Now, what about IOL for a case, aphakia, when posterior capsule is not there or defective? So in the last 2 decades, revival of interest has come for iris claw fixation posteriorly. I have done a lot of studies, and we found that endothelial cell loss is minimal. This is a vitrectomized eyes, iris claw lens fixed, and the pupil margin is chewed up with the probe, I think, but otherwise it looks okay. Now there is an objection that you cannot dilate the pupil well after a retropupillary iris claw fixation, but that's not true, as you can see in this case. Now again, several studies are done, and findings are positive. So I just want to show you a couple of cases where iris claw lens comes in very handy. In a case of subluxated hypermature cataract, for instance, now you find that here the zonules are not there. Actually, even here the zonules were not there. So I had a tough time doing rexus. I had to cut with the Werner scissors. Now this kind of cases, when the posterior capsule is not attached, doesn't have the attachment with the zonules, and most of the time you have to be extra careful. And the best way to take it out is with a sandwich method. Any other method of taking it out can result in disaster. And you find here there is no posterior capsule, but I would like to stroke the posterior capsule back into the pupil as much as possible. Some people pull it out fully, but then I would like to do this so that there is some barrier for vitreous from coming into the anterior chamber. And vitreous is the last thing I would like to see on earth as an anterior segment surgeon. Hold it nicely and enclave it peripherally so that the pupil is round and dilatation is possible. But then even if the pupil is beaked postoperatively, it doesn't really matter, although another ophthalmologist seeing it might say that, oh, pupil is beaked. Iridectomy is a must. We must do that. Should not leave it without doing an iridectomy. If you are doing a vitrectomy also, then of course you can do the iridectomy with the vitrectomy probe itself. Now another case, phacolytic glaucoma with subtotal subluxation. Again, you have to cut the anterior capsule. This kind of cases, when there are no zonules in most of the areas, you cannot put CTR, and it's the whole CTR and the lens, everything may go into the vitreous after some time. Otherwise you have to think of a scleral fixation lens, which in my hands I like to put an iris claw lens. Again, taking it out, a sandwich method is the best method. Stroke the posterior capsule back into space so that you will have some barrier for the vitreous to come into anterior chamber. In such cases, at the end we must also do a tricot wash to see that there is no vitreous. introduce it vertically. You must check the claws, integrity of the claws. And enclave it peripherally. And the right side also. Now this is a patient. I did a cataract on him when he was 5 years old as a child, congenital cataract. And in November 2017, by then he had become a tall young man working in Jet Airways. But then over the years, he became progressively myopic. It was -7 in the right eye and -3.5 in the left eye. And I was wondering what to do: rigid PCIOL, Sulcoflex lens, or iris claw AC, iris claw PC, LASIK, what? So his father said, see, you did surgery on him when he was 5 years old. Now you correct it. He cannot do the work. So then I thought a lot, and I decided to put in a retro add-on, what I call as add-on retro fixating lens. Some of you have seen this video. Apologies to that. Regular SICS kind of a incision. I'm trying to make some space for the iris claw lens to go in. Left side enclaving was not too bad. One advantage in this case was the PCIOL was there. So this is a second lens. So the chances of the vitreous hurting the posterior capsule and vitreous coming into the anterior chamber was minimal, because the lens was there, the original lens was there. But the problem was the synechia. I just couldn't release the synechia. So I decided to try with iris repositor, did synechulisis. And somehow I was able to push the haptic behind the iris and enclave it. Postoperatively, what happened was there was an area in the lower part which was having one lens, and on the upper part 2 lenses, so I had to do a pupilloplasty, the 4th row pupilloplasty, which Dr. Agarwal described, and he became alright. Thank you for your attention.
Thank you, Dr. Kurula. Excellent videos. I just want to ask you, you don't use any pilocarpine, or do you constrict the pupil before putting this?
If it is a vitrectomized, yes. Vitrectomized eyes, we have to constrict the pupil. Put pilocarpinol and then constrict the pupil, put in the lens. Otherwise, the lens will sink into the vitreous. But if it is not vitrectomized, and in a case like this, there is some barrier is there, the posterior capsule, then there is no. That's a very good question.
Second thing is that if it is dilated,
yes,
isn't there a chance of the pupillary margin being incorporated into the, or closer to the pupillary margin into the claw?
Yes, there is a chance. You have to I enclave it with a hook.
Yeah.
So I push the pupillary margin into the center, and then make sure that the enclavation is in the periphery.
Did you ever explant such lens?
No, I never had to have to explant. The one complication I had was that one patient on whom I did this. He is a badminton player, and he had a shuttlecock injury, and one came off. But then I fixed it back. I went back and fix the enclavation. Otherwise, I've never had any. See, I told you in early days, that is 40 years ago, when I did that, this thing came off automatically, and that's why I gave up. But that was a regular cataract surgery those days. But then, so when I started again, about now 15-20 years, I asked the manufacturers, are you sure that the grip is good enough? So he said, sir, the manufacturing is different now, it is better, and so on. So now after that, I have never had a patient, the enclaving came off.
Thank you.
Yeah.
I have had to answer your question, I have had at least two that I can remember. One, again, a single haptic getting disenclavated spontaneously, one behind and one actually, now the lens is sitting in front. This person I'm going to enclavate the second haptic in the coming theatre day. He disappeared and he came back with a bit of inferior corneal decompensation, and I found out that one was enclavated, the lens was in the anterior chamber, the other half.
You did that, or it was done somewhere else? And
No, I did that many
so
years
you did
back.
you did it posteriorly only?
I did it posteriorly only.
But then how did it come anteriorly?
I don't know. He's
He
again
had
one very active player, shuttle player, football player and all. I don't know how it has come. He came with an inferior corneal decompensation, and now I find that one is properly enclavated, the other portion is actually sitting in the anterior chamber and it has not fallen back.
Oh, really? Okay.
Yeah, but then he's got a bit of corneal decompensation, so I have to,
yeah, in my two cases of disenclavation, it had sunk, and so it was like a descended lens. So it didn't come anteriorly.
And regarding pilocarpine, I think I use a bit of dilute pilocarpine, because if the pupil is very widely dilated, you have done a vitrectomy, then it's very difficult. Even if you use a hook, it's very difficult to get the mid-peripheral iris. So a bit of one problem is if you use the normal pilocarpine, it gets very small, and somehow you have to struggle to get the lens behind the pupil. So a bit of dilute pilocarpine, a bit of constriction is good enough to get the right
You use
position.
carpinol intracameral?
Yeah. And I dilute it. So you don't get a very small pupil, but you get a reasonably small pupil, enough for your enclavation.
As interestingly, one symptoms these posterior enclavated patients sometimes may say that because of pseudophacodonosis, they say that, interestingly, I had a fisherwoman whom I implanted this, and she said, "Meen bedakkunna pole irunnu." So this is one complication, especially for young active individuals. It might be a little disheartening. The main question which I wanted to ask is, at this point, see, I keep doing glue IOL, I do iris claw IOLs, I do scleral fixated IOLs. To the panelists as well to the audience, what is our take-home message? Which is the best secondary IOL? I would like to pose that question.
Is Dr. Sinamol here? She's a big advocate for scleral fixation. She's not here.
No,
but then she
studies are we are all doing SFI.
Yeah.
Blue fixated or otherwise. Now
the studies are quite clear.
Arvind has come up with a new where they don't use a glue.
Glue at all,
Yeah. With a 24 gauge needle they pierce, and they use a vitreous forceps to grab the hook, and there is hardly a opening.
So shall we conclude by saying that what is good under the surgeon will be the best secondary IOL?
No, it entirely depends on the surgeon.
Yeah,
it doesn't.
So I think the take-home message is that, I think.
I feel that you must try this, and then if you're comfortable with the glued IOL or SF IOL, do that. But in my hands, I've done SF.
Especially if a lady cannot stay on table for long, and you want to finish off the matter fast, I think iris clip may do the job fast, rather than spending more time on a scleral fixated IOL.
Why a lady alone can?
Well, even gents too. I'm just taking a scenario.
It's not a right.
Well, I take that back. You know, any patient, I can recorrect it to any patient. Yeah.
Dr. Prashu.
Yeah, sir, I had a question. Suppose while you're doing the surgery and you enclavate one haptic, or you enclavate it not in the ideal position. Maybe it was not peripheral enough. Maybe it was too much towards the pupillary margin. Is there a way to disenclavate it and re-enclavate?
Very difficult. Very difficult.
Is there a technique for it?
I've come across similar situations. What I've done is, of course, it was a vitrectomy. I'm a vitreoretinal surgeon, so it was a vitrectomized eye. So what I did is, with the same IOL holding forceps like you had, I held the lens with IOL holding forceps, and through the scleral port, I put in the light pipe and used that as the leverage for the other haptic and disenclavated it. So that is a method by which you can.
Not a cup of tea for anti-retinal.
No, it's very difficult. You end up tearing the iris, and you land up in.
So I did this, and I found it useful in disenclavating. And as you said, yes, it is difficult. But once one instrument is there posteriorly and the other instrument anteriorly, you can probably sort of twist it to perfection.
For me, the biggest advantage of an iris claw in an ideal situation, when the iris is intact, other anterior chamber morbidities, the ease of doing. It just takes another 5 minutes for you to finish the procedure.
Absolutely.
You don't have to take the patient back again to the OT. Extensive dissection is done. So this is for me. And in my practice, I have practically stopped doing AC IOLs. So anterior chamber IOLs are almost.
You're right. I've seen a lot of complication with AC IOLs. So I think I've also.
Sir, I'd like to ask just one more question. Is there a particular IOL holding forceps that is better for holding the iris claw lenses?
I prefer a forceps which looks like a McPherson's forceps, but it opens like this, not like that.
Yeah, that is the forceps that I think I am after for a long time. But where is it available? I mean, is it? What do you call it? Is there a name for it? Okay.
I'll give you the number also if you want.
It's an iris claw IOL forceps with the serrations. Then no, without serrations. I am using the serrated one till now. Yeah.
What sir is talking about is the 90-degree rotated McPherson. That doesn't do like this, but.
Yeah. That is, I find, I've used all sorts of forces, but this I find is the best because the forceps is thin at the end.
Yes.
The others are thick, and
all the visco, everything comes out.
Everything comes out anterior, and then you have a risk of touching the endothelium. Yes.
Sir, a word on the IOL power calculation for how do you
I use the same as the
posterior
chamber lens, maybe 0.5 diopter less in some cases.
I mean, maybe for the sulcus fixation, whatever.
Let's say you have.
What we are using is 117.2. So that adjustment you have to make. And over and above that, probably you can.
So if you have a posterior chamber lens where the calculation is 21 diopters for an A constant of 119.2, so you just subtract 2.
2 diopters. The A constants are given on the iris claw lens packets.
Yeah, but that's almost 3 diopters off.
No, you have to consider the A constant, see what the power is, and that power should be about 0.5 diopters less than what you have calculated.
So that's why I was just trying to give an example. So if you have a 21 diopter PC IOL in the back calculation for an A constant of 119.2, and during your surgical maneuvers you've lost the bag, now you want to put in an iris claw lens which has an A constant of 117.2. So what should be the power that we put in? So if you only correct the A constant, it should be 21 minus 2, 19 diopters, or should we do any correction for the fact that these lenses would be probably slightly anterior? Yeah.
But my understanding is that the iris claw lenses, the A constants provided on the packet are for retrofixation, and I usually don't change it. I just put it there.
So that's what I wanted to know. Like this. No. What I'm saying is.
Recalculate.
Yeah.
No, you can immediately put in the IOL mask
Now, whichever formula that you're using, you can use the A constant, and if you're using, I have an ACL, because I just wanted to go back to what Shane had raised. There I have been watching this development for this discussion for the last 20 years. The latest one came out in 3-4 months back, and no technique is in. There is no study which shows that one technique is superior or inferior to another technique. I have explanted plenty of iris claw lenses, and I predominantly use AC lenses. I have explanted a lot of AC lenses instead, and I put in PC lens, when there was a bag. So I would strongly recommend that please do not go home with the message that the AC lens is a big culprit. It is basically the surgeon who has massacred the eye during phacoemulsification or SICS or whatever, surgeon who does not know how to implant an AC lens. I have taken out lenses which are kept, one have taken the scleral tunnel, the lenses which are flipped. Even live surgery also I have seen people do that. And then I have seen lenses which are very small cornea, they didn't have any lens, so they just pushed in a lens, so it is AC lens is cramped for space. So I still measure the white to white diameter. For every surgery that I do, I keep a standby AC lens available with me. And very rarely I use them, but I use them. I have a long follow-up of 20 years. I don't think I've lost a single cornea in my practice. And all the corneas which people claim are put the blame on AC lens is basically the surgeons have to take the blame.
Yeah, I agree with you. Totally agree with you. But AC lens, I said as a general rule, there is this, because I've seen removed a lot of AC lenses. The haptic is inside the wound, and so it is very difficult decision. We have to take it out. The future is very bad, but then after taking it out and putting a new lens, again the prognosis is bad because the AC is already this thing, and sometimes the AC haptic is stuck in the bag in the wound so much that it's so difficult to take it out. Then you have to cut it. It is a surgical problem. You are absolutely right.
Same time you can use this glide AC lens while using. You can use the glide and introduce the lens into the anterior. No.
See the prints.
Yeah.
Carry on.
Regarding the other modes of fixation,
yeah.
We have given up glue dials because we do not know how they do in the long run. Glue dial, of course, is a pseudo definition. It's not a glue that is used.
Yeah.
We have, instead of using 9-prolene, now you've gone to say S7 Gore-Tex suture, 7 Gore-Tex.
Gore-Tex is very costly, sir. Yeah.
Yeah, but they do extremely
4,000.
well.
Yeah.
We have followed for more than 5-6 years.
Yeah.
They come in a box also, 56,000 per box of 12. Yeah.
The same scenario for the what is the IOL calculation for sclerally fixated IOL? We are going back again, sir. Sclerally fixated IOL, what is the IOL for the same patient, same scenarios? How much you detect or how much you add?
See, this basically a little posteriorly located.
Posterior,
yeah. So basically, whatever I would plan for the bag, I would use the same calculation for the bag.
No need to add or
I don't think so. And most
no rule of 9. Yeah.
And most of these cases are actually salvage cases.
Yeah.
They have a detachment, they have a dislocated nucleus and things like that.
Yes.
So refractive accuracy is not that much of an issue when you're doing a presbyopia-correcting lens.
Yeah.
But I target for the same back power lens.
Okay.
Yeah.
Okay. Thank you, sir.
See, those
using,
who do
using the A constant.
Those who want to do ACIOL, it can be very beautiful. Two things. One is the angulation of the optic should be a little forward. It should not be back pressing on the pupil, on the iris. So the angulation, put it in such a way that there is a clear aqueous flow between the pupillary margin and the lens. Number one. Number two, you have to, if you have had a PCR, make sure that vitrectomy is done, vitreous is no more there. If vitreous is there, you are in trouble. Number three, good iridectomy is a must. These three things, if you follow that, and then the size of the IOL should be all right. Then no problem. So many years ACIOL works quite well. Thank you very much. എടുക്കട്ടെ.
Call upon Dr. Sai Kumar to talk on small people FECU.
So I'm going to speak on one of the not very uncommon problems that we face in cataract surgery, which is a small pupil. And as you all are aware, every small pupil is not the same. There are various scenarios. So we'll just briefly go through some of the common scenarios of small pupil that we come across and how it is managed. I acknowledge my fellows, Dr. Tindu and Dr. Juhi, who have edited and the videos for me. So let us go through the common clinical scenarios. First one may appear very silly, but known as applied tropicamide in the patient's eye. The patient is in the OT, you are ready, you are scrubbed up, the patient is ready, the pupil is small, due to various reasons. Sometimes they have missed it. Most commonly is because the patient has got an allergy to tropicamide, and so they have not applied. They have put 1 drop of hometropin or something, the pupil is just about dilated. That is the first scenario. The second one is a routine senile small pupil. You have to ask in the history whether this patient is on any of the alpha blockers which they use for prostatic hypertrophy. Patients on tamsulosin are a slightly different group altogether. Those who you have to expect IFIs in them and manage them slightly differently. The other subset of patients are the patients with posterior synechia, the post uveitic eyes with posterior synechia. The next subgroup is the pseudo exfoliation eyes with small pupil, and along with that you also expect to have weak zonules and very rarely some core ectopias and ectopia lentis sort of situations. So let us just go through the videos. This is the first scenario. Very happy for all of us. We use intracameral dilating solutions. So earlier we used to use preservative-free adrenaline, dilute it and use it. Usually gives an immediate dilatation. Nowadays, especially under topical anesthesia, most of us are using Phenocaine Plus. No financial interest. Similar brands are available from various other companies also. So this is a combination of tropicamide, you have lidocaine, and you also have phenylephrine. So it gives good anesthesia and also gives you a good pupillary dilatation. So happy surgeon, happy patient, good intraocular lens, everything is fine. Now this is a case where the pupil is not bad. It's about mid dilated, slightly more than mid dilated, but you know that this patient you can expect an IFIS. So you all know what IFIS is. I don't want to explain that. So initially in all these patients you do put a bit of phenocaine inside the eye. The pupil still remains reasonably large. You do a good rhexis. Till that time usually the pupil is not disturbed much. So till your rhexis stage you are reasonably okay. The moment you start doing your hydrodissection, you know that this pupil is going to give you some trouble. There's a bit of flutter there, the pupil starts coming down, and this is where most importantly I use a dispersive viscoelastic. Again, my personal choice is Viscoat, no financial interest. Viscoat saves you the day. What it does is it actually pushes the iris away from your surgical field, and because it is dispersive, it does not go away very easily. It remains there. You may have to supplement the Viscoat 2 or 3 times during your procedure, but keeps the iris away from your surgical field. It reduces the flutter of the iris and makes things very, very easy. So once you have sort of cordoned off the iris away from your surgical field, don't go to the far periphery trying to fish out the pieces. Remain in the center, sticking to the basic principles of phacoemulsification. You can see the iris fluttering a bit halfway through the procedure, but at the end everything is absolutely fine. So this is another clinical scenario of small pupil. Now uveitic cataract, as you know, is totally different. There is a lot of posterior synechia. Quite often you have a membrane. So if you have a membrane in these sort of eyes, if possible you have to peel off that membrane. So here I have made 2 openings. put some air and put some trypan blue, a bit of it at least, under the iris, so that you don't know what is the density of the cataract. Once you have dilated, sometimes, the visibility of the capsule goes away. And in these sort of situations, peel off those membrane. Now, once that membrane is gone, the pupil is slightly more freer now, and now you can use your Kuglen hooks to dilate the pupil. Mind you, in uveitic eyes, once you do this with Kuglen hook, the multiple sphincterotomies are created. These are the fragile or the friable irises, unlike the thick irises you see in IFIS, and these usually, dilate to about mid-dilated level. You can use a bit of cohesive viscoelastic to again push the iris towards the periphery, what they call a visco dissection or a visco dilatation, and then you can with this mid dilated people you can go ahead with a routine phacoemulsification. All the basic principles of phacoemulsification, like replenishing the chamber with dispersive viscoelastic, maintenance of the anterior chamber throughout the procedure, are again mandatory in this situation also. Elderly person, a pupil like this, whom you are on an alpha blocker, don't try too many gimmicks. These sort of pupils, the moment you put in a bit of intracameral dilating solution, the pupil does not dilate, and I have found that some of these pupils actually constrict, and this to me is a very important sign that this is going to give you trouble. So here I use iris hooks. This is my indication for using iris hooks in these situations. The basic principles of iris hooks I am not going to explain. The reasonably equally sized 4 paracentesis. Make sure you don't touch the anterior capsule with your hook. Inspect your hook just under the microscope before you actually use them. And once all the 4 hooks are in place, you need not widely dilate like what I have done here. Even a mid dilatation is good enough. And then there is no fluttering of the iris, there is no IFIS problem that you are going to face in these situations. The phacoemulsification, just like routine, cortical aspiration, implantation of intraocular lens, and while removing the iris hooks also, please be careful. Don't hook the the iris, don't hook the capsule. Be careful while removing the hook. Some people actually remove the stopper and remove the hook through the wound itself. I do it the other way, and I just put a bit of pilocarpine. I'll just show you a few post-op photographs. The irises, the pupils don't look very bad in the post-operative period. And sometimes the problem that occurs when you use 4 hooks, like what I did, was you have to cross over the iris to reach the center of the eye. So sometimes you touch the iris at multiple points. So here you can use what is called the 5 hook technique. Actually, in a box of the iris hooks that you see, you actually have 5. It is for 2 reasons. One is either you can use a 5 hook technique, or suppose one hook falls down, you can have a spare hook. So, and even the capsule hooks which come in a box of 5. So after making the main wound, just make a small separate track just under your main wound, and this gives you a plane to go in for the 5th iris hook. Now when you go in and out with your phaco probe, if you have a 5th hook, then you don't touch the capsule anywhere. You don't injure the edge of the rexis, and that gives you some extra space. It's not mandatory to have 5 hooks. You can even have 4 hooks with 1 hook subincisional. That is also possible. 1 hook subincisional, 1 hook exactly opposite, and 2 in the sides. So with 4 itself, you can get a square which is with the triangular portion near you. So again, routine phacoemulsification, intraocular lens implantation. So this is another technique that you can use. I don't use pupil expansion devices. This video is from my colleague Dr. Vanishri. So this is the Malugin ring. This is a very elegant device that can be without multiple paracentesis that you can use. You have to be careful. You need a reasonably deep chamber. In very, very shallow chambers, I think you should not try out any of these devices. And also, if the pupil is extremely small, then putting this Malugin device is slightly tricky, because the iris has to be stretched too much. This is the 2-handed technique, the 2-instrument technique to hook the iris in the rings. And then once the ring is in place, then the technique goes on just like a routine phacoemulsification. And after implanting the intraocular lens, this hook can be removed either by the injector itself, or the hook is very thin. You can actually remove it with a small hook, or even the Kuglen hook. You can just hook it and just take it out. A similar ring developed by Dr. Suvain, who's a good friend of Dr. Arup and many of us here, is the B-hex, which is slightly thinner than the Melugan ring. I'm sure some of the surgeons here are using the B-hex ring as well. This is the post-op picture I showed you of that gentleman whom we used 4 hooks. So we have this feeling that when you stretch it too much, there is a lot of sphincter tears and the pupil looks very ugly in the post-operative period. Not all of them. Some of these slightly elastic irises do reasonably well in the post-op period also. This was an extreme case of chorectopia which I did. The pupil is somewhere there, one corner of the eye. So here you have to use hooks to, you have to first hold the iris, push the iris towards the center, the pupil towards the center, and then hook it. And after this, actually I did a small incision cataract surgery because the lens was a bit wobbly. There was some zonule dehiscence there. So this also answers one possible question that is likely to come up: can you use hook for an SICS? You can use a hook for the SICS, mainly to do the rexis. Once you have done the rexis and there are some sphincter tears are created, the pupil remains about mid-dilated, and then you can remove the hooks before you rotate the nucleus into the anterior chamber. So at least 2 hooks you can remove. This was actually a very soft cataract, and unfortunately, this patient, after using a CTR and putting in the intraocular lens, and I thought this much of stretching would create some sphincter tears here and there, but this pupil went back and to the corner of the eye. The patient had about 6/18 vision, but this hook again, and this pupil went back to the original position. And when I did the second eye, after finishing everything, I enlarged the pupil with a vitrectomy cutter in this patient. So in summary, not all small pupil scenarios are similar. Each requires an appropriate technique to handle it. Have good dispersive and cohesive viscoelastics in your OT all the time. Drug history is extremely important. It's not that it's only tamsulosin or the alpha blockers. There are many other drugs which can cause IFIS on the table. Look for evidence of pseudo-exfoliation. I have not shown pseudo-exfoliation videos because of the paucity of time, but when you have a pseudo-exfoliation, what I usually do is, in case I am anticipating a weak zonule, I go in with a capsule hook, and with the capsule hook you can serve both the purposes. You can hold the rexis margin as well, and by slightly enlarging it, you can also dilate the pupil. And always have pupil expansion devices. Develop one of your techniques which in your hands gives you good results to handle small pupil. Thank you so much, and invitation, like Vinay said, to our Silver Jubilee Symposium, September 18th in Cochin. Thank you very much.
Nice talk, Dr. Sai Kumar. I just want to add one point that in IFIS, it is always better to use a iris hook rather than a pupillary dilating device. It also flutters.
Thank you.
Thank you, sir, for the wonderful talk and beautiful videos. Now, I call upon Dr. Jacob Koshi to talk about pupilloplasty. Dr. Jacob Koshi did his undergraduate and post-graduation training at CMC Ludhiana. He has also done a fellowship in glaucoma and medical retina at Aravind Eye Hospital. His areas of expertise include routine and complicated cataract surgeries, complex anterior segment surgeries, glaucoma and medical retina. He has made many indexed publications in national and international journals. He is currently a professor of ophthalmology and the dean of undergraduate students at Believers Church Medical College, Tiruvalla. We welcome you, sir.
Thank you so much. At the outset, I'd really want to thank Patnamthitta Ophthalmic Society and all the office bearers, and I'm proud to be a part of this institution. I've been working here for 6 years. I thank the college for all the support, and I would be failing in my duty if I don't thank the organizing secretary. I have the privilege of working with Leena. We always knew she's a astute clinician and a wonderful surgeon. Now we know that she's a fantastic organizer, so more power to you. And yeah, today I'll be talking about pupilloplasty. I'm an anterior segment surgeon. I don't do any, I do just anterior vitrectomy, that's about it. I'm going to talk about a technique that works well in my hands. I know there are various techniques, but this is something that each one of us can do. Every anterior segment surgeon can do. And okay, I don't think they've got the right slide, but anyway, we'll start about. I'm going to be talking about CEPSA pupilloplasty. Pupilloplasties have been in vogue since McCannell started describing pupilloplasties. In '94, Dr. CEPSA, he came up with this technique, which I'm going to show you here. Now, this is a patient who was operated and had a posterior capsular rent. An anterior vitrectomy was done. Peripheral iridectomy was probably attempted, which was probably a little over enthusiastic. And the patient then came with uniocular diplopia. And fortunately, there was a good anterior segment, anterior capsular rim. So a posterior chamber IOL in the sulcus was placed. And now I'm going to be doing the CEPSA pupilloplasty. This is using tenoproline double-armed long needle sutures, and you make 2 paracentesis, and you engage the pupillary margin on one side and then the other. Once this is done, you can introduce a bent 26 gauge needle from the other side, and just like we do an SFIOL using the railroad technique, we can bring out the long needle of the proline suture outside. And so once that is passed, then we pass a Kuglin hook through and we bring out the suture through the first port. So the suture is brought out through the first port there, and it is a little tricky because a Kuglin hook sometimes gets stuck in that wound. Once you bring out, and you can see the loop over there, the proline suture is now passed through this. There are different techniques described. I use the 3-1-1 technique, where 3 throws on one way, 1 throw the other way, and then 1 throw again the other way. There are people who have tried different techniques. There is a modified CEPSA pupilloplasty. I mean, of course, there is a Dr. Amar Agarwal's technique where they do that as well. Any technique is good if it works in your hands, as we discussed about iris claw and SFIOL. So the suture is being brought out again for the second throw, and this has to be done 3 times. Remember, this is proline sutures. They don't knot as well as silk or nylon. You have to put multiple throws, and if anyone has done SFIOLs, you will know the need for that. Here we cut the suture. It's not very short, but it is short enough. A little bit of you just check again, make sure that there's no vitreous in the wound. This patient was already having an anterior vitrectomy, and that PI a little bit is left over there, and that takes care of the upper lid will take care of the diplopia that the patient had. So I'll show you one more. This is a patient who came following a trauma repair. You can see that there is no lens there. The iris is totally smashed, and the patient came for a secondary procedure. There was no option of doing an iris claw here. So I'm planning to first try and do an SFIOL here. And I do a 4-point technique. I find in my hands again that works really well. Bringing out the sutures through the main wound, which is an SICS wound on top. And this is a regular scleral fixated lens that you pass the knots through. I was also considering doing a pupilloplasty in this patient, but I was first wanting to make sure that the scleral fixated lens, that part goes through well. And you need to make sure that everything is working fine, the lens is well centered. 4-point fixation is being done here to make sure that everything is in order. And you can see that the lens is well fixed and that part is taken care of. Now I was wondering what to do with the iris. I didn't want to leave this patient with a lot of glare. Anyway, superiorly the upper lid will hopefully take care of it. Do a anterior vitrectomy, make sure that the vitreous is clear. First you sweep through the edges. Sometimes there is some peripheral anterior synechia there that you can release, and once you have swept the edges properly, you might find a little bit more rim. This encouraged me. I had something to work with which I thought I could put a suture through and make it a little smaller. Anyway, I had decided only to do inferiorly. And you can see on the nasal part, actually, there is another hole there and some iris atrophy following the first surgery. So I didn't want to do anything over there as well. Vitrectomized eye, sometimes all these procedures are a little difficult. Again, I'm passing a tenoprolene suture here. So you use 9-oprolene if you're doing an SFIL. Definitely the results are far better than tenoprolene, but for pupilloplasties, tenoprolene is recommended. And the same technique that I showed earlier, you pass the long needle suture through two edges of the iris and pass a 26 gauge hook needle through and get the long needle out of the eye. This is the difficult part. Everyone feels that tying the knots are difficult. Tying the knots are very easy. Getting the correct positioning on the iris when you're passing the needle through is probably more difficult. Once you get the loop out of the eye, then you can just trim the suture there and then tie the knots. And once the knots are tied, you will find that this patient would do quite well. And that's all we managed to do. Unfortunately, we couldn't do any better, but the patient seemed quite happy. Fortunately, uncomplicated SFIOL there and a little bit of a pupilloplasty, nothing on the upper side. And that was as much as we could do for this patient, and he was fairly happy. So this is the CEPSA technique, popularized by Dr. CEPSA in 1994. There are modifications of this. I have done a few with some of the modifications, but I won't go through that in the interest of time. Just regular CEPSA pupilloplasty, and I'm happy to take any questions on this. This is something that each one of us can do. If you have a anterior vitrector, and if you have 9-oprolene, these sutures are freely available. Long needle, double arm long needle. This you can use 9-oprolene even for the iris, pupilloplasty, but it's better to use 10-oprolene. Thank you very much for your patient listening.
I think chamber maintenance is extremely important in these sort of cases. So sometimes we usually have an AC maintainer because so much of manipulation that we are doing flattens the chamber, or you have to repeatedly replenish with HPMC, some of it goes behind. So I think either if you are doing it along with the pars plana vitrectomy, you can keep the maintainer on, or better still, in my hands, I put in an AC maintainer throughout the procedure so that the chamber is well maintained for all your manipulations.
Absolutely right, sir. Could not be more emphasized. Even for SFIOLs, iris claws, the biggest problem is to maintain the AC. With all this maneuvering taking place, you don't want to damage the endothelium.
Can't you use vitreous forceps to hold the iris while passing the suture through the other port?
You can. If you're struggling to pass the needle through the iris, that would be helpful. To exteriorize it, you don't need to. In fact, some of the newer modifications of the CEPSA pupilloplasty, they don't actually make a second port. You just make one primary port, and the other side you just pass the needle through and do an exchange. So they say don't make too many openings if you're not going to use it, or you don't really use it. But this would be an easier technique to do, and if you're comfortable with this, then you can go in for the modifications, which are all slightly more difficult to do.
I have a question. This
Yes,
all this you did in pseudophakic or aphakic patients. Have you done in a patient with a normal lens, phakic lens?
No,
because
sir, I haven't
really
had.
struggled.
Yeah.
A patient
It's
came
tough.
with injury, and there was an iris prolapse, and it's a huge iris coloboma, but the lens was clear, and I thought I'll do a 4th row thing. It was really tough because the AC is very shallow.
You will cause some touch. There will be some cataract, so it's very difficult. I haven't had any experience in a phakic eye. I've had one experience where it was following trauma, severe injury, but then there was traumatic cataract which had to be addressed, and it was a partially subluxated lens which was taken care of, and then it did the repair. So I have done that, but I've not done pupilloplasty on a uncomplicated non-cataractous eye, to say that. So
Yeah, that is
but
really
it's going to
tough
be
because
really
in
tough
that-
because you
yeah.
will have some capsular touch and you might cause some cataract.
Anybody else has any experience on that? And a phakic eye.
with clear lens. Oh, it was really tough. So
there's a question to Dr. Sai. So it's regarding the patient with correctopia. You operated the other eye as well, and there you made a central pupil, isn't it? So I mean, out of curiosity, did the vision improve in that eye more than this eye?
in fact, the patient was, I think, a bit amblyopic due to this long-standing problem.
Yeah.
The first eye had 624 vision. The second eye had 612. But the patient was very happy in both the eyes. I think she was used to that sort of a...
I was wondering how she used to view through that correctopic area,
So
because it's
that
infronasally.
It wouldn't have made any difference. Only thing is for us to visualize the eye later on, the central opening with a cutter is slightly better than the other one.
Yeah, and also the correctopia in the first eye, your rhexis margins would have been corresponding to the area of correctopia infronasally. So probably
no, but I fully enlarged the pupil and then did the rhexis. No, the rhexis margin wouldn't have been different. But maybe she was used to that sort of an slightly eccentric vision. I don't know.
Yeah. Thank you.
Just a question about the CPSA pupilloplasty. When you're putting the knots, the 3-1-1 technique that you said, so you do 3 throws, three passes in the first time, you tie it and then bring it out again, and then do the
so the loop is brought out of the eye. So the suture is passed through three times. And then when you pull both ends, that's why it's called the sliding technique. The knot slides in and goes into position. Then you have to go in with the Kuglen hook again.
So 3 times totally you have to hook
3
it up.
times. So there is a bit of maneuvering taking place. And remember, this is nylon. So you might think that, oh, the first 3 knots are loose. So and you can't just leave it there and take your own sweet time. You have to do it fairly quickly. But there is a certain amount of tension that you can bring by depending on how tight you want to make it. So the second throw is actually the most crucial, which gets the correct amount of tension onto the iris.
Because what I've been doing is Dr. Amaraga's technique, the single pass 4 throw.
Yeah.
So that there are only 4 throws in the first time, and then you leave it like that.
Yeah.
Do you think it is going to get loose later, or is there a problem?
Yeah, I don't know, but see, the problem with this technique is that, like Dr. Sai said, that you have to keep forming it with visco, or have an AC maintainer, or have some irrigation port through the pass planer if you can do that. Because every time the AC is going to shallow down because of the maneuvering and bringing out the suture. It looks very simple. If you're doing it for the first time, you'll really be sweating quite a bit. After some time, it gets a little easier.
Sir asked about the phakic eye pupilloplasty. I did take up one patient with traumatic mydriasis. And I did tell the patient that on table I might have to do the cataract. So the patient was prepped for a multifocal. I had to do a multifocal on table. This is really almost impossible to pass the needle without touching the lens. It's very hard. And yeah, that's it.
Interestingly, I saw a video by a Russian guy who did pupilloplasty. It was a widely dilated pupil like yours, but he actually took sutures through entire pupillary margin and then tied it and literally came to a very normal pupil. It's a tremendous task which he did. I'm just trying to find out how he did that.
Yeah, the only problem with that is it won't dilate. But the good thing about this is if you've done something and you feel the pupil is too small, you don't have to go back into the eye. You just take the YAG and one short tuck, and then your only thing you'll have that suture lying there. But otherwise, you can release it. But yeah, if you bring it down too small, then you're hoping that, I mean, we don't need the vitreoretinal surgeons to do anything after that. Yes, sir.
Right. One comment about the small pupil. Those of us who are doing SICS for a very small pupil, and if you know that there's going to be IFIS, then one precaution that you can do is make the internal entry a little closer to the center of the cornea. So that will prevent the iris from coming out every time you manipulate. So I found that very useful.
Okay, thank you, Jacob. I think because of the shortage of time, we have to move forward.
Thank you, sir, for the wonderful talk. Now I invite Dr. Satish Thomas to talk about pediatric cataract surgery, where it departs from adult cataract surgery. Dr. Sadish Thomas did MBBS from Kottayam Medical College and MD Ophthalmology from AIMS New Delhi. He did fellowship in pediatric ophthalmology and strabismus from Shankara Nethralaya, Chennai and Westmed Children's Hospital, Sydney. He was a faculty of CMC Ludhiana for 14 years. Currently, he serves as professor and head of department at BCMCH Tiruvalla.
So we've just crossed from morning to afternoon. Good afternoon, everyone. This is the only talk on pediatric cataract in an adult cataract session. So I have to keep it as a general talk. It won't be a surgical talk. So where does it depart from adult cataract surgery management? So it's pediatric cataract management is considered one of the most challenging and complex tasks confronting an ophthalmologist. And that's not just about the surgery, the entire management. And treating a pediatric cataract like you would do a senile cataract is a sure recipe for disaster. The reason is that in a pediatric cataract, it just doesn't block the visual input on the retina, but it also disrupts the development of visual pathways in the brain. So in an adult cataract, your management is directed towards restoring the vision that was already formed. Whereas in a pediatric cataract, you are actually fostering development of vision. So this makes it really crucial. So what's different between a pediatric cataract and an adult cataract? To exaggerate, I would say that the only thing common is cataract. Everything is different. The etiology, is different, and that would influence your preoperative workup. The anatomy of the is different. Like all pediatricians would like to say, a child is not a miniature adult. So similarly, a child's eye is not a smaller adult eye. And this would influence all the intraoperative considerations when you're operating. The way the eye reacts to an insult, to surgery, is very different in a child as compared to an adult. And so this would influence your postoperative management. Amblyopia is obviously the thing that would require the highest consideration in pediatric cataract. You're operating or you're managing an eye that is still growing. So that makes the IOL power calculation, the size of the IOL, all these very tricky and even uncertain. And the complications in a pediatric cataract, again, might be slightly different as compared to an adult, so that would influence how you follow up these children. Morphology, I won't go into the details of it. It's again different as compared to an adult cataract, lamellar cataract, coronary, all that. Indications of surgery, pediatric cataract is different from an adult cataract. Obviously, for any management, we weigh the risks and the benefits, but in a child, again, not every cataract has to be operated. You know that apart from the risks and the complications, any post-cataract surgery patient is going to lose accommodation. So in a child, you have to weigh that in. However good your distant vision is, you're going to lose near vision. Therefore, not every opacity has to be addressed. It's only an opacity that is going to affect this child's visual development. If in your estimation this cataract, this lenticular opacity is going to affect the child's visual development, then that's a cataract that needs management. The others can probably be left alone. How do you assess that? By the visual behavior in a pre-verbal child, and also by looking at the opacity. A distant direct probably would be a very good judge. A centrally located opacity which obscures the red reflex on distant direct ophthalmoscopy will be a cataract that needs to go. Again, is it unilateral or bilateral? A unilateral cataract is more amblyogenic. A bilateral cataract, less dense, not really obstructing the red reflex, you might choose to wait. If you already have squint and nystagmus, that suggests that you're late. You need an urgent surgery. So timing for surgery, you know that with bilateral cataract, you can wait a little longer. The intraoperative factors that are different in a child whom you're operating as compared to an adult is that when you're operating on a small eye, all your maneuvers, the space that you have is much less, so that makes it more difficult. The scleral rigidity in a pediatric eye is much less as compared to an adult. So this will result in frequent shallowing of the anterior chamber. So you'll need to repeatedly keep forming the anterior chamber. Your capsulorhexis becomes more difficult in a pediatric child, in a pediatric cataract. The younger the child, the more difficult. The reasons are two. One is the chamber keeps shallowing because of the low scleral rigidity. The second thing is that your capsule is elastic, and an elastic capsule needs more force to tear it. So these are the two reasons why capsulorhexis becomes difficult. And because of the low scleral rigidity, you always need to close the wound at the end of the surgery. The good thing is that the nucleus is soft, so your nucleus management becomes much easier. You may not even need any phaco energy. And the need for posterior capsule management is what differentiates a pediatric cataract surgery from an adult cataract surgery. If you don't do a posterior capsule management, your surgery ends up being a waste. And along with the posterior capsule management, you need to do limited anterior vitrectomy. Otherwise, if you just do a posterior capsulorhexis, leave the anterior vitreous face intact, your epithelial cells are going to grow over the anterior capsule as a scaffold. So just a very short video on a pediatric cataract surgery. So you can see the anterior rhexis. The force that is applied is centripetal because it has a tendency to keep running out. And now this is the posterior capsulorhexis after the lens removal. So it's absolutely mandatory, and you do a limited anterior vitrectomy. And this is a PMMA IOL put into the bag. It's a little tricky. So here you can see the two rings, the anterior capsulorhexis and the posterior capsulorhexis. This is a hydrophobic acrylic IOL in another case. So putting an IOL in a bag with the posterior rhexis is a little more tricky, but it can be done. So here again, at the end of the surgery, the anterior rhexis and an adequate posterior rhexis is what defines the success of the surgery in a pediatric cataract. So in the bag, fixation is the preferred site for an IOL. It reduces the chances of optic capture, tilting of the lens, and extrusion into the anterior chamber. I think all of us would have seen cases where the lens lies in the anterior chamber in a pediatric cataract. This is because there's violent postoperative inflammation. When the bag contracts with fibrosis, it can push the lens. Therefore, it's very important to get a good capsulorhexis. And a can opener or any other type of capsulotomy is not a good capsulotomy for a pediatric cataract. So the anterior capsulotomy shape, size, and edge integrity is crucial for long-term centration in a pediatric cataract. And obviously the primary posterior capsulotomy and anterior vitrectomy is also mandatory in a child who will not cooperate to sit on a slit lamp for a YAG capsulotomy post-op. So maybe 8 years or so, it depends on the child's cooperation. So this is what you get post-operatively. You can see that the anterior capsule has got opacified, the posterior capsule has got opacified, but because you have a posterior capsulorhexis, you have the visual axis clear. So that's the most important part in a pediatric cataract. Whether to put IOLs or not, the cutoff age is coming down. If you look at textbooks, you'll find that go for it only about 2 years of age. But the current practice of all pediatric cataract surgeons is that they have brought it down to 1 year and even less. The risk is the higher rate of visual axis obscuration and resurgeries. So yeah, and now most of us start putting it in younger age groups, especially if you have a unilateral cataract. And if you leave this child aphakic, then the chance of visually rehabilitating this child for amblyopia becomes almost an impossible task. There are contraindications. Not every case can be fit for an IOL, especially if the eye is small, then you don't go in for a IOL. Size is not a big issue now because of this material, but otherwise when we had rigid IOLs, that was where it was insisted that you put it only in an older child. These are big issues. I think my time is running out. I'll rush through these slides. These are the big issues about choosing the IOL. The power, what power do you put? Because you want a power that will help this child, that will suit this child for the majority of the child's life. So when the child attains the growth, completes the growth, that power is what you want to estimate, but that's only an estimation. There are so many factors which are unpredictable, and so that's the whole problem. How much to undercorrect? There are different tables, and yeah, these are most of these recommendations, but you definitely undercorrect more the younger the child. In postoperative management, the most important thing is to manage the postoperative inflammation, which is violent immediately. So you need to be aggressive on your post-op steroids, and it is your immediate inflammation control that is going to decide the long-term prognosis and success of surgery. So you will need to give very frequent topical steroids, frequent follow-up to see if anything is going wrong, and you may even consider systemic steroids. Sometimes at the end of the surgery itself, you will see fibrin forming in the pupil. So visual axis obscuration is one of the most common complications if you are doing a pediatric cataract like how you would do an adult cataract. The other complications, CME, retinal detachment and all are rare. You need to watch this child lifelong for secondary glaucoma. So the last slide, most important thing is to manage amblyopia. And immediate optical correction and amblyopia therapy should be immediately after surgery. So thank you all for your patience here.
I think that was a very nice presentation on pediatric cataract and how different it is from the adult cataracts. Do you capture the lens behind the PC? I mean, there is a technique described
gimbal,
like that.
Gimbal's technique.
Yeah, that's a gimbal. Is it? Do you do it?
I don't do it anymore. At one time, it was believed that gives an advantage over not capturing it. But I think now general consensus is that if you do a good, adequate sized posterior capsulorhexis and a good anterior vitrectomy, then it is as good as an optic capture. So it's really not required.
And your cutoff for not doing a posterior CCC is about 8 years? Is that,
not
generally followed?
Not just the age. I would also assess that particular child preoperatively, whether the child is able to cooperate on the slit lamp. Because I know that if I don't do it, within a month or two, I'll already have an opacification. So I already know whether this child is able to cooperate and sit on a slit lamp for a year.
Any questions for sir?
How exactly do you do a posterior capsulorhexis? Can you tell the details? Do you do it before introducing the lens, right?
Yes.
Not after that. It's not possible.
It is
Or
possible.
It is possible.
It is possible.
Can you just give some details?
Okay. So I'll just tell you what works for me. I don't deepen the bag too much. So I put a little bit of viscoelastic, deepen it a little, and then I scratch it with the capsulotomy to to make an opening. I need a little bit of force too, because unlike an adult capsule, it doesn't tear that fast or that easily. So a little bit of force is needed to make an opening with the cystitome. And sometimes I try and extend it a bit, or sometimes I just take a forceps and then hold one edge and then try and tear it. In my hands, I found a posterior capsulorhexis easier than an anterior capsulorhexis. It doesn't tend to run out as much as an anterior capsulorhexis does. In a child, yes. So I don't think it's too difficult a technique to do, and the sizing becomes important. You can also put the only problem with doing it before you introduce an IOL is sometimes, if you're not careful, your IOL can go through that posterior rhexis into the vitreous when you're dialing it in. If that is a concern, then we can put the IOL and then lift up one edge of the IOL, go below that, and then do the posterior rhexis very much. I've done it only in 1 or 2 cases, but I prefer doing it before I put in the IOL.
So did you use vitrectomy cutter for posterior capsulotomy?
Yes.
Vitrectomy cutter,
Yes,
that is
yes.
the,
Yeah.
yeah.
So that's a good question. The younger the child, so like if I'm operating a 2-month-old child, then anterior capsulorhexis and posterior capsulorhexis become even more difficult because the capsule is so elastic and you need a lot of force to fracture it, and then your chance of it running out. So the younger the child, more elastic the capsule, you can get away with vitrectomy rhexis. The problem with the vitrectomy rhexis is, theoretically, it is not as good as a manual rhexis because the edges are not continuous. It is still discontinuous, though it might be very close to each other. So it is not as strong as a manual rhexis. But the younger the child, the better it is for a vitrectomy.
Yeah. The cutters anterior segment people use would be in the range of 1,500 to 2,000 cuts, but what we use is 7,500 cuts. In that, you can actually make the shape of the posterior capsule whichever way you want. So
the shape is usually round. However,
what I meant to say is the precision is so much so that with 1,500 to 2,000 cuts, yes, you said is what is right, because the margins will be irregular. But as the cut rate goes higher and higher, you can get really good margins out of it.
Yeah. Shane, my point is that however circular it looks, it is still discontinuous. It is never continuous as you get in a manual.
Okay,
so,
in a manual.
Yeah, so the strength will never be as, if you have to choose between the two, a manual is always better.
And the strength should also be a problem when we are putting the IOL. You have to put the IOL in after, right? So that's... and I just wanted, I don't do pediatric cataracts anymore, but I've watched a lot of Dr. Sudarshan Khokar's operating. So he generally, the first step of making the rhexis, that puncturing the posterior capsule, as you said, is a little difficult. He basically uses an MVR blade to make that entry. And then it seems that's much more easier. I just wanted to make that point.
And like what Shane said, I think many of these posterior capsule opacifications that you see,
you have no option but to
with
the
high-speed
cataract
cutters,
and
high-speed cutters, you get beautiful round openings.
That's true. Especially while silicone oil removal along with cataract surgery, the posterior capsule can be tackled very well with.
And for many of these cases, we have no other option because you, in a PHPV, for example, your posterior capsule has a thick fibrous plaque there. There's no way you can tear it. You have to resort to vitrectomy.
Yeah, sir, just one doubt. I've not ventured into pediatric cataracts for this singular fear about this posterior capsulotomy.
It's easy.
Thanks for that reassurance.
I haven't heard anybody else say that, and I've always wondered why. But I'm letting out a secret.
No, I'm sure there will be others as well. But I wanted to ask you, just in case it runs out, is it okay to put a sulcus 3-piece IOL?
Yes, and capture it.
Yeah,
it's
of
okay
this
to
optic
put
capture.
it in the sulcus, but if you don't capture your optic, then it's a bad surgery. It will you'll get an optic capture
Exactly.
post-operatively. So if you're putting the lens in the sulcus, capture the optic into the anterior capsule.
And don't get scared so much, because the pediatric vitreous is very gel-like. It is unlike adult vitreous. So obviously you will not land up with serious complications like the IOL dropping down and going, unless you are really messing it up.
And would trypan blue help? Some studies have shown that for the anterior capsule in adults, it makes the capsule a little more less elastic and more brittle. Would injecting trypan blue into the bag after removing the lens, would that help?
I don't know. See, I use trypan blue for anterior excess, but I don't need it for posterior excess. It's much easier.
Thank you, sir.
That's one thing I forgot to say. Actually, historically, when you look, there is this editorial in 1957 by Coster-Baader. He had done a lot of work on pediatric cataract. And in 1957 editorial of Archives of Ophthalmology, he said, I haven't seen a single case of a child who has benefited by pediatric cataract surgery, just 60 years ago. And we have made a huge advancement from that post 1990s. And it is the surgical technique that has made the difference, the anterior rhexis and the posterior rhexis and the anterior vitrectomy. Now the success is very good. It is not, the surgery is not the difficult part now in the hands of a good surgeon, but it is the post-op care and how much care you give them post-operatively, how well you follow them up, make the changes in spectacle number at the appropriate time, see if patching is going on, looking for secondary glaucoma. These are the most important things that would determine the lifelong outcome.
Thank you, Satish. Thank you for the wonderful talk, quite informative.
Now, I invite Dr. Amida Verghese to talk about recent developments in cataract surgery, how we practice. Dr. Amida Verghese completed her post-graduation from the prestigious Lady Hardinge Medical College, Delhi. She is specialized in phacoemulsification, glaucoma, and pediatric ophthalmology. She was the president of Pathanamthitta and Kottayam Ophthalmic Club. She received Rambo Medal for Best Postgraduate and Trehans Medal for Best Paper, Delhi Society of Ophthalmic Surgeons. She is currently running her own institute, Eye Microsurgery and LASIK Center, Tiruvalla.
Good afternoon to everybody. To thank Dr. Rachel Jose and the Pathanamthitta Ophthalmic Society members for giving me this opportunity today. I'll be talking on recent advances in cataract surgery and how we practice. There are no financial interests. The most common surgical procedure performed in medicine is cataract surgery. And the technological progress and instrumentation has enabled cataract surgery to become the safest and most predictable surgical procedure. However, patient expectations are high. Longer life expectancy and better quality of life has made all these things more, they have raised the bar for the expectations, but along with that, there is more incidence of systemic and ocular comorbidities, which again make it a challenge. A comprehensive history regarding the visual disability is very much important, and also we need to inquire about the lifestyle and the work pattern of the patient. Previous and current refractive status have to be noted down, and just by correcting the Snellen's visual acuity, many patients, they miss out on the benefits of cataract surgery. By removing the crystalline lens, it makes the patient lose all accommodation. There will be surgically induced astigmatism, loss of contrast sensitivity. There is loss of the UV barrier. There are spherical and chromatic aberrations because of the IOLs, and all these factors need to be addressed. Now, biometry is very important because the accurate estimation of the axial length will impact onto the IOL power predictions. I'll be talking about the IOL Master 700, which is based on the swept source OCT technology. It has a unique fixation check as the foveal pit is visualized during measurement. and fewer refractive surprises are there. Both eyes can be measured in 45 seconds. Cataract penetration rate is more than 99%. It supports biometry data, the review, analysis, IOL calculation, etc. It has additional features that it directly measures the posterior corneal surface, and toric calculation is inbuilt, no additional hardware is required, and the image can be transferred to the Callisto system in the OT during surgery. So this is the IOL Master 700 on the right hand side with the picture which we see on the Callisto during the surgery, and we get a reference image printout from the IOL Master. Then we get the IOL calculations along with the summary. Like in this patient, it says that the patient has a short eye and she has a cylinder which is high. And we also get a printout of the analysis where you can see the image of the cataract. You can see from where, the points where the keratometry has been taken and the foveal pit. Now, there are other investigations which are also important: the dry eye assessment pre and post surgery, corneal topography, specular microscopy, because all these help in better planning of the IOL selection and the surgical procedure. So these are just the printout of showing of a patient who has astigmatism, and we can compare the topography with the IOL Master readings to make sure that the readings which we have taken are accurate when they are similar. And the specular microscopy is also very important. Then talking about intraocular lenses, good quality intraocular lens has properties of adhesiveness, square edge, and adequate water content to prevent PCO formation. Adhesiveness helps in stability. Good biocompatibility and endurance is required for the IOL to stay in the eye for a longer number of years without causing any deleterious harm. Fully usable optics. The lens should have fully usable optics, and it should have UV light protecting properties, and there should be no glistening phenomena. So this is a difference between an IOL which has fully useful optics, and some of them do not focus the light which is hitting onto the edge of the IOL, causing a distortion of the image. Now sometimes when the IOLs are when they do not have good biocompatibility, over a period of years the IOL becomes opaque, and they need to be exchanged because the patient's vision decreases. So this is an example of an IOL which we could remove from the bag and could put a secondary IOL in the bag. The surgery was done elsewhere. The initial surgery was done elsewhere. Then this is another example of an opacified IOL. In this case, we could not we could not salvage the bag, and the capsular bag and the IOL complex came out together, and then we had to do an anterior vitrectomy, then a posterior vitrectomy, and then put in a sulcus fixated IOL. This is the posterior vitrectomy being done. The sulcus fixated IOL was. So this is an example of a good quality IOL which has unsurpassed optical clarity and smooth unfolding. And just to show the smooth unfolding, there are injector systems. This is an autonomous carbon dioxide powered delivery system which allows smooth IOL delivery. So there's a lock before you, after putting viscoelastic, you release the lock, and you have to press the lock to push the piston forward so that the IOL comes near the tip of the injector system, and then it is delivered into the capsular bag by smoothly pressing the lock on top. The latch which is there on top of the injector, and it delivers the IOL smoothly into the eye. Then this is a picture showing the precision edge design of the IOL, which is important for preventing PCO. Now there are different types of IOL depending on their function and how the light is focused with each type as shown in this picture. So the monofocals focus only for distance, the bifocals for distance and near, and the for distance and intermediate and some amount of near, and the trifocal focus for distance, intermediate and near. And nowadays we have the extended depth of focus IOLs, which have a range of distance, a range of focus from distance to intermediate and some amount of near. Now how do we do an IOL selection for a patient? With the availability of extended depth of focus IOLs, more patients opting for monofocals can be motivated to go for the extended depth of focus IOLs. They provide a reliable distant vision, good range of intermediate vision, and low dysphotopsia. And they are based on a monofocal platform but with an extended range of vision, and they are suited for active and dynamic patients who perform significant number of activities at intermediate range and desire only some degree of spectacle independence. So this is an example of one of the extended depth of focus IOL. It looks like a monofocal IOL, and the method of implanting is also similar. Then coming to the multifocal IOLs, the patient selection is important. Multifocal IOLs, they focus for distant, intermediate and near. They have good depth of focus, but they require a process of neuroadaptation, and they are better when implanted in both eyes. Glare, halos, starburst, difficulty in night vision and all are side effects of these IOLs. Residual refractive errors can be there. A good patient counseling is needed and do not promise 100% spectacle free vision. This is a new Technis Synergy IOL which has a very good range of distant, intermediate and near vision, continuous vision with even in low contrast, and it is based on chrome aligned technology. Here's an example of the IOL being implanted in one of the patient's eye. Both the eyes were operated and the patient was very happy after the surgery. So you can see the rings on the multifocal IOL, and a good centration was achieved at the end of the surgery. Now coming to toric IOLs, toric IOL designs are to correct regular corneal astigmatism, which is identified by corneal topography and IOL master. Newer IOL designs are stable and rarely they show any rotational instability. They can be used in patients with astigmatism more than one diopter, and surgical techniques for accurately marking the IOL axis are available for manual as well as with automatic devices. So this is toric IOLs also available in all platforms: monofocal, extended depth of focus, and multifocal IOLs. So this is an example of a monofocal IOL being implanted with the help of the Callisto system, which will give us the where to make the incision, how big the rexus you want. You can adjust it onto the machine, and then finally the axis markings will be there. So you dial the IOL parallel to the markings to get correct positioning of the IOL. This is a multifocal toric IOL being implanted, and you can see the axis markings on the IOL on either side. And this is a Vivity toric IOL. These are the markings on either side of the IOL. Then coming to the phaco machines, the latest phacoemulsification machines make surgery safer, faster, and less taxing for the surgeon. And we use the Alcon Centurion Vision System. I am not going into the details of the machine. This is a Alcon Vision Centurion system which we have with the Zeiss Callisto for the marking of the toric IOLs, and also it is like a video, it's like a TV monitor, so you can keep seeing the surgery during the when the surgeon is operating, and also you can record the surgeries, and you have the laminar flow in the OT. Now coming to bilateral simultaneous cataract surgery, these have been used over the years for general anesthesia patients. When cataract surgery is being done under general anesthesia, and the advantage is that you restore binocularity and stereopsis faster. It is important in patients with multifocal IOLs. The major concern is endophthalmitis and risk of post-operative refractive error. Following carefully the inclusion criteria for the SBCS post-op refractive errors can be reduced, and to reduce endophthalmitis risk, we have to consider each eye as an individual. So to conclude, cataract surgery is just not the removal of the obstacle and restoration of vision. It is a complex procedure which should not be trivialized. It has become a refractive procedure to eliminate all refractive errors, astigmatism, and coexisting presbyopia. Scientific vigor, cost effectiveness, and industry collaboration is important to make it available for all. We still can be better, and there is demand for techniques that are even more perfect. Let us all strive for that. Thank you.
Any questions? We have a little problem. We want to do the oculoplasty session now, and then we'll break for lunch, then glaucoma in the afternoon. Is it all right?
Or we can have an option as to, because Dr. Kiran and Dr. Annie Sridhar ma'am has to leave a little early. Can we mix up the sessions? It's okay, sir? Can we take... So is it okay if we have oculoplasty session, lunch, and then glaucoma? Is it okay with everyone? Yes. Okay. Thank you. Thank you, sir. Yes, we'll shorten it to half an hour. Everyone can eat fast.
Okay. Now I think we switch on to the oculoplasty sessions.
Ma'am, we'll just give up the mementos first. Thank you so much, Arup sir, for coming. Oculoplasty. We are having oculoplasty session now. Arup sir, we would just like to give you a memento before you. Shobana madam, can you please give memento to Arup sir? Madam, can you give off the memento to Sai Kumar sir? Madam, few more. To Philip Kurla sir, Dr. Philip Kurla sir, memento. To Rachel Jose ma'am. Verghese Joseph sir. Amita Varghese, ma'am. Jacob Koshi, sir. Thank you so much, madam. Satish, sir. He's just gone out. Thank you, madam.
Now we will move on to the next section, oculoplasty.
Dr. Sai Kumar is also leaving. Thank you, sir, for coming.
We will move on to the next session, oculoplasty. The moderators for the section, Dr. Philip Kuruvilla and Dr. Siju Joseph. I invite Dr. Philip Kuruvilla and Dr. Siju Joseph.
Right, shall we go on to the first talk by Dr. Marian Pauli on orbital tumors. Dr. Marian Pauli is a very famous and well sought after oculoplasty surgeon in Giridhar, and whenever I have a doubt I just send a photograph to her and say, what do you think about this? And then she very kindly gives an immediate and prompt and proper and academically accurate reply. Thank you very much, and over to Marian.
Yeah, good afternoon. I know all are waiting for the lunch. At the outset, let me thank Believers Church Medical College, Tiruvalla, and Pathanamthitta Ophthalmic Society, especially Leena, our own alumni, for organizing this meeting. Without wasting my time, I just go to the orbital cloud burst. This is primarily a collection of cases, like, like we know orbital lesions might not present to you like I have got a lesion in the orbit. So this is some kind of subtle findings that we should pick up in our OPD to detect orbital lesions. So first case, he is a 40-year-old manual laborer presented to our OPD with injury with metal rod while cutting the tiles 6 hours following the trauma. So this is his clinical examination findings. Yeah, we can see a small wound, but not a big deep laceration. Total ptosis. Coming to the ocular motility examination, vision is PL. All movements are restricted. Pupil is RAPD. Fundus show disc edema. Left eye is within normal limits. So obviously the next thing to do is like get an imaging done. It shows an intraorbital foreign body. And so now you cannot delay because patient is having compressive optic neuropathy, orbital foreign body. So without much delay, patient has taken under general anesthesia and the first thing to do is don't explore the wound first. Do a lateral canthotomy. It releases orbital compression. So first we did lateral canthotomy, then extended the wound. Then foreign body removed and started on IVMB. At 6 months follow-up, patient has regained 6/6 vision. There was a minimal limitation of adduction because the foreign body was in the medial orbit. It was injuring the medial rectus. Even though disc was pale, and he had visual field defects also. Vision was 6/6. Initially, he was given prism glasses, and later he underwent squint surgery also. I've just briefed the surgical management principles. Evaluate for globe rupture in case of orbital trauma. Explore to the depth of wound for superficial foreign bodies. Decision to remove foreign body should be individualized, and any surgical removal can be associated with excessive tissue damage. So do not remove in emergency unless otherwise you are quite sure that it is superficial. Always take the patient to theatre and explaining the risk. Indications, not going. Surgical approach is always maximize location, minimize additional trauma. Superficial direct approach. Then excise, devitalize tissues. and irrigate with antibiotic solution. So this is a case of trauma. Now this is a second case where a child, 7-year-old child, presented to us with lid edema of 1 day duration. She gave a history of fever 1 week back. So look at the pattern of lid edema. There was a lid edema in both eyes, left more compared to right. And look at the color of the edema. Is this allergy? No, definitely no, because this color tells you, and there is a history of fever also. So on examination, vision is 6/6 right eye, 6/12 left eye. Left eye she had mild proptosis, EOM restriction, and suspicious RAPD. So in this case, what we should do first? Don't send the child for CT scan immediately. So it's a clear-cut case of orbital cellulitis with suspicious RAPD. Can be an abscess also. So start the patient, start the child on IV antibiotics, and then send the patient for scan. Because if you send the patient for scan and they'll come back after 1 hour or 2 hours, child might cooperate, might not cooperate. So in that time you can lose the vision. So always admit and start IV antibiotics, and then send the patient for imaging, blood culture, all those investigations. Then, so she had a subperiosteal abscess, treated with IV antibiotics, monitored every 4 hourly, and she has improved. So the question comes whether we should drain the abscess or not. In this case, no. Why? So Garcia and Harris has given a criteria. Observation with IV antibiotics only is indicated when the child is less than 9 years, no intracranial involvement, middle wall abscess of moderate size, as we have seen in our case, no vision loss or definite RAPD, then no frontal sinus involvement, no dental abscess. In all these cases, we can treat with IV antibiotics. Treatment has to be continued for 3 weeks in total. So this is another case. Here the scenario is little different. 11-month-old baby presented to us after IV antibiotics. There is a definite RAPD, and there is, you can see, a superior abscess. So in this case, you need an immediate intervention. Child underwent abscess drainage and improved well. So here is a case of pediatric cellulitis. One is abscess. Where will you drain? Where you will not drain. So now coming to the third case. So 61-year-old gentleman presented to us with watering right eye since 4 months. No discharge, no history of any cellulitis. He's a known diabetic on OHA. He had already received topical lubricants and antihistamines, everything. So this is his external eye picture. So coming to the ocular findings, if you look very carefully, there is some fullness in the superior sulcus. Globe is little displaced up, and there is a mild proptosis. So again, should I treat this with antihistamines and lubricants? No. So there is something is there in the orbit because of subtle proptosis, unilateral superior sulcus fullness. And if you look closely at the face, nowadays, because all are wearing masks, most of the time we'll forget to examine the face. You can see some fullness here also. So the next thing to do is get an imaging done. Ocular movements were full, lacrimal workup was suggestive of some partial NLDO. So imaging showed a mass. So it was sino-orbital mass arising from the maxillary sinus going to the ethmoid and to the orbit. Some malignant mass, so small round cell tumor, endoscopic biopsy confirmed, underwent chemo and radiation. And he did well actually because his orbital involvement was very less. Later he underwent cataract surgery also, and he is still alive with vision 6/6. So what are the indications for imaging in a patient present with watering? Like you cannot push the mass like either dry eye, allergy or whatever. Always look for proptosis, then telecanthus and a palpable mass. This is a third case, again treated as scleritis and orbital abscess. You can see the globe is, there is mild proptosis, sulcus fullness, globe is displaced outwards. Imaging is very, very important because in this case what happened was, you can see imaging again showed a sino-orbital mass. This mass was indenting the globe and it was causing exudative retinal detachment and scleritis like picture. So always look for external eye examination is always very, very important in all the cases. Again, another case, this is a 47-year-old female teacher presented with the NLDO, already diagnosed as NLDO and came to us for diacrocystal rhinostomy. So now this is external eye. Again, I have already told you external eye examination, what is there in the left eye. There is an esotropia, that is, it was sensory esotropia, it was present since for a long time. Again, you can see some fullness. Is it fat prolapse? So always palpate and see. And in this case, examine the medial fornix. So look into the medial fornix. What is it? It's a classical salmon patch seen in orbital lymphoma. So patient presented with watering, already diagnosed as NLDO and presented to us for DCR, but turned out to be something else. It was a lacrimal sac lymphoma, and we did MRI, biopsy turned out to be lymphoma, and she did well with EBRT. Coming to another case, 54-year-old female presented to us with a mass in the left eye. So actually in this case, she was gone to a camp for cataract surgery, and no, actually everybody picked up the cataract, but she told the doctor that, see, I have got some mass here. So naturally, when you say unilateral superior sulcus fullness, always try to palpate the orbit. That's the message which I wanted to convey. She had a mass, again it was a lymphoma, and we did an imaging, and she did well with all the treatments, and she is doing well. This is another patient, again presented with a very subtle proptosis. His vision was normal, fundus was normal. You can mistaken it for thyroid eye disease, but thyroid TFT, thyroid profile was normal. So unilateral proptosis, TFT normal. Before labeling it as euthyroid ophthalmopathy, better to get an imaging done. So this is again a case of lymphoma, and he did well with treatment. So this is a 43-year-old female presented to us with the drooping in the right eye since 1 year. So it's almost 1 year she had drooping. Already treated in multiple places as Horner syndrome, dactyrodenitis, etc. So this is her external eye examination. Now there is a mild ptosis. Pupil is more or less normal. Globe is minimally displaced down, and now when you look down, what is happening? The lid is adherent to the orbital rim. That is a little bit of lid lag in the down gaze. So this cannot be Horner syndrome. Very unlikely to be dactyrodenitis also. So again, when she came to us, she already had imaging with her. It showed us some infiltrative lesion in the lacrimal gland region. So then I again asked the history, like, I was like, what is happening in this? Even I was unable to understand in the initial visit. So again I asked her. Then she came out with the history that she was treated for carcinoma breast at the age of 23. So she's now in 40s. So then it's like the whole story has been changed. Underwent biopsy. It was a metastatic adenocarcinoma. Then she underwent treatment for the same. But even though she lived for 4 to 5 years after diagnosis, then finally she succumbed. So early diagnosis is very, very important, and history taking is very, very important, because patient might not feel, I'm coming to an eye doctor, why should I say about my cancer history? So when some history and findings are not correlating, always dig the history in all the cases. So this is a 44-year-old female, just came for a presbyopic glass. She is a known hypothyroid, already on L-throxine. So this is her, I'm sorry for this eccentric picture. This is her external eye examination. She knows her eye is little proptotic, and she was thyroid. She thought it was due to thyroid because already see elsewhere. She came to us for presbyopic glasses. So now this is her refraction. So what is atypical in this? Right eye plano plus 1.5, left eye she has got a +1. So from where this +1? So now in this case, when you see such kind of refraction, her movements are all full, mild proptosis in the left eye. Fundus will give you the clue. So there was a disc edema and engorgement of vessels. Again she underwent imaging, showed cavernous hemangioma. So she underwent surgery and did well, underwent excisional biopsy. she's doing well. Another case of cavernous hemangioma. This was actually persisting for a long time. And when he presented to us, it was counting fingers 2 meters. It was a huge hemangioma and it was causing fixed choroidal folds. So what I mean is, like cavernous hemangioma, we know it's a benign tumor, but in long term it can cause fixed choroidal folds, and even after surgery he didn't improve it to 6/6, he was like just 6/12. So early diagnosis and treatment is very, very important. 64, another case, 64-year-old, watering double vision. So watering and double vision obviously will go for imaging. So she had proptosis, mild movement restriction in the adduction. This is diplopia charting. So this was a CT scan orbit. So in this scan, you can see a mass in the lacrimal region extending to the bone. She has got some lytic lesions in the skull also. So in this case, we had multiple differential diagnoses: tuberculosis, then lacrimal gland tumor, adenocystic carcinoma, metastasis, myeloma, hydral lymphoma, etc. She underwent extensive evaluation, and this is the chest X-ray. She had some lesions in the lung with mild pleural effusion also. But finally, we did an incisional biopsy under frozen section. It was not fitting into any of those. M protein was negative, what was not confirmatory for tuberculosis also. So we did a biopsy under frozen section, which showed atypical cells, and final histopathology showed it as plasmacytoma. So when the diagnosis is uncertain, frozen section always gives you a clue, and it helps in the further management. And she did well initially, but finally she died. So now this is another case, young female, 35 years, presented to us with itching and watering both eyes in 6 months. So 6 months itching, watering, that's a history. So now look at her external eye. Again, she has got a mild periorbital puffiness, but more in the right eye, and the globe is little displaced down. So this warrants an imaging. So she had pleomorphic adenoma, and we did surgery and did well. This is her post-operative picture. So periorbital puffiness persisting for a long time, examine carefully primarily. So I just wanted to show this also. This was again a case of pleomorphic adenoma, treated, like not treated, he was treating with Ayurveda for quite a long time, because benign tumors, people will think it will not create any troubles, but when you keep it for a long time, one, it can cause pressure effects, second, it can turn into malignancy. So this was his CT scan. He had cystic degeneration, globe is almost displaced down. It was a case of pleomorphic adenoma with a capsular invasion and all. So he did well with surgery, like excisional biopsy, bilateral orbitotomy, and we did post-op radiation also. He developed radiation-induced cataract, and he did well he's still alive and he's well at 5 years follow-up. So now I come to a spectrum of thyroid cases, because nowadays in our part of the country, actually thyroid eye disease is very common now. Diagnosis is quite certain, because late retraction, proptosis, chemosis. So this is a case of active thyroid eye disease, 47-year-old male. With compressive optic neuropathy, vision is 6/6. This is the fundus. Fields are relatively normal. There is no RNFL defects also. So we treated him with pulse methylprednisolone, and we have added on immunosuppressant, but later he developed CSR. So we have to reduce the steroid a little bit. So again he developed recurrence. So we have added orbital radiation, and he did well with 8 years follow-up now. Okay, even though mild proptosis is remaining, all the other findings are subsided. So orbital radiation can be done in steroid responsive thyroid eye disease, but it should be used with caution. You cannot radiate all the orbits. Now I will show another patient, 64 years, diabetes, hypertension, hyperthyroidism, non-case of glaucoma on 3 drugs, presented with defective vision both eyes. So she was already diagnosed with active thyroid eye disease already received 5.5 grams of IVMB before presenting to us. So this is her clinical picture when she presented to us. Right eye, active thyroid eye disease, lag ophthalmos, chemosis, exposure keratopathy, and corneal infiltrate. Vision is PL, left eye 2 meters vision and active disease, again lag ophthalmos. You can see exposure but not yet infected. Fundus, right eye we couldn't take because of the media haziness, left eye showed features of early venous occlusion. So in this case, this is very complicated because she has got an active thyroid eye disease, bilateral compressive neuropathy, already received 5.5 grams of methylprednisolone. We know the maximum dose we can give is 7 grams. Both eyes lag ophthalmos with exposure keratopathy. Right eye there is an infective element, corneal ulcer. Glaucoma can be both. She is a known case of primary open angle. Now probably steroid must have added to her glaucoma. Diabetes, steroid induced, and hypertension, and in fact she had a fracture also due to steroids. So, so in this case, each component has to be dealt like very logically and needs very close follow. We got a cornea opinion from Dr. Vinay, did scraping. Scraping showed fungal elements. Meanwhile, we gave 1 gram. So now, so there is a fungal corneal ulcer also. So as an emergency measure, at least to save the left eye, we did a lateral canthotomy, cantholysis, blepharotomy, so to release the lid. The lid was very tight because of the LPS fibrosis, and lateral tarsography. Right eye also we did the same procedure in back to back. And after 5 days, the corneal lesions has started improving, but compressive optic neuropathy was persisting. So she underwent endoscopic orbital and optic canal decompression. She was on oral steroids, immunosuppressants, and post decompression at 1 month, vision has improved right from PL to CF 3 meters, left eye 636. But when we tapered the steroids, again vision deteriorated. So we sent her for orbital radiation, and she finally at 6 months follow-up, she has actually did well. Right eye improved to 618 N10, left eye 612 NH. This is her external picture. Right eye tarsography still I have kept it with corneal opacity. Fortunately, it is not in the pupillary axis. A little bit of cataract is there. Right eye fundus still no view, but we can see the disc is pink only. Left eye fundus became normal. So judicious use of all the treatment modalities is very, very important, especially when you manage complicated thyroid cases. So to conclude, orbit is a window to the human body. You can get a myriad of clinical conditions and various typical and atypical presentations. External eye examination is very, very important. Very, very important as slit lamp and fundus. Regular follow-up and imaging in selected cases, biopsy in suspicious lesions. It helps in avoiding the delay in diagnosis. It saves the vision as well as it saves the life. Thank you. Any doubts?
Yes, doctor, you told maximum dose of 7.5 grams you have given. Did you use any biologics like rituximab, intuximab, or the other things for this thyroid ophthalmopathy?
No, in this case I have not used.
Yeah, because in your routine practice.
No, I have used, but biologics I'm already using. But in this case, she had a fungal corneal ulcer. So if I start
that developed later, no, before.
No.
Because when you are in the market, there's the teprotumab that reduces the proptosis also, they climbs.
Yeah, it reduces, but it is not in Indian market so far.
Because the newer one in the.
Yes.
Yeah.
Rituximab we are using.
Rituximab we are using. Okay, thank you.
One more question. This parasitic granuloma is common in this area. What do you suggest for that?
From the history view, no. Like, recurrent lid edema, there is no signs of redness will be less, and patient complains of itching. So first visit, I'll start the patient on ivermectin and low dose steroids. Ivermectin is used in dog. Actually diarrhea failure is seen in dogs. So in veterinary doctors are using ivermectin for dogs. So, but 50% of cases will respond, but 50% will end up in excisional biopsy. Actually, that paper got the best paper. Our paper got the best paper in last KSOS. So finally, excisional biopsy is both diagnostic as well as therapeutic. But when the patient presents with the live worm and you can see the live worm, don't give ivermectin, just take it out, either conjunctiva or lid. But lid, taking out the live worm is very tricky because it is moving. So what you can do is don't waste any time. Put a mark where the patient and where the worm moves. Then give peri-lesional, like peri-worm local, so that you know the worm is going to be there and is not going to move because of local anesthesia. Then make a small nick and then remove it.
Albendazole and steroids have got no role.
Albendazole not effective. Steroids primarily we are we are giving to counteract the inflammation. Actually, it will not cause peripheral eosinophilia, so hetrasan has got only limited role. Hetrasan is given for eosinophilia, so it has only limited role. If there is peripheral eosinophilia, we can give.
It's usually dilophyralim, no? So
actually,
hetrasan is effective for filariasis, so the worm is of the same family, no?
Yeah, yeah.
So okay.
Albendazole decreases the migration of the worm. Actually, and steroids, after the worm dies, the inflammation, it's only effective for the inflammation. Some patients have immunity so that the worm dissolves by itself and there is no mass. Some patients mass will develop. So in those cases, which mass, I think it mainly depends on the patient's immunity, whatever we give. Albendazole just reduces the migration of the worm. But usually there is no migration around the eye, it dies around the eye. So
yes.
I don't think
anything
is
usually
hetrasan and ivermectin I have given for 3 or 4 weeks after you gave, but I have not seen any. It's all depends on the patient's immunity. That's what I think. Yeah,
it may present as edema. It may present as recurrent edema in the lids, and later on only granuloma will appear. Yes, recently I had a patient.
Sometimes no granuloma, it will dissolve by itself.
Yes.
It dies and dissolves. But Brugge malai is the one which I had 2 patients with Brugge malai. That is a very active worm and small worm. I think that is the one which penetrates into the vitreous, and that can produce eosinophilia. And you can give hetrasan or whatever.
In fact, I always do ultrasound in all the suspected parasitic cystic because recently I had one patient thought it as parasite, but it turned out to be xanthogranuloma. So I always do at least ultrasound. You can see the cyst very nicely. It is not very it's not very costly also.
And it's usually in the anterior orbit.
Yeah, anterior.
Yeah, usually in the anterior orbital
so you can
area.
take it out if you want.
Yes.
But if it is coming in the superior oblique area, you have to be little careful. Superior oblique area. Otherwise, you can take it out easily. But Brugge malai is the one we have taken out a live worm, and that is different from the dirophilaria one. That is very active and small. I think that is the one which penetrates.
How long? What's the size?
Very small. Very small. 3 or 4 millimeter. But the dirophilaria is 10 to 15.
It is long.
Quite long. That doesn't go inside the eye.
No, it is usually in the orbital area.
Anterior orbit.
We had one orbital one. She presented with the live worm in the conjunctiva. Somehow we couldn't retrieve. After 4 months, she presented with a recurrent orbital inflammation, and the CT scan showed worm in the orbit behind the globe. So finally, I had to do lateral orbitotomy for her to rake out the granuloma.
Yeah, that is the question I wanted to pose.
Yes.
Under the conjunctiva, many times it's very difficult to remove the worm. I had an interesting case. I did vitrectomy for a macular hole. 3 weeks post-op, he comes and says that redness. See, even after 5 days post-op, there wasn't that much of redness. He comes with redness, and I'm thinking, okay, maybe he has stopped using steroids. Again, called after 5 days, the redness is not going off, and I saw a subconjunctival worm. Well, maybe people might laugh, but I'm just asking, is there any role of using topical steroids and this coming down from the orbit? I don't know.
No, you can use immediately, you can use either homide or lignocaine to paralyze the worm a little. Periorbital injection, yeah.
And the difficulty I faced was, I took him up immediately, went to the OT, cut the conjunctiva, but the worm doesn't stay there. It just goes off.
Yeah.
So
nowadays we stopped taking the patient to OT. In the slit lamp, like in the minor OT itself.
You just remove
it
off.
Remove. It's a small neck and then remove.
Yeah, is there a method to immobilize the worm?
Yeah, atropine can be used.
Yeah,
atropine can be used.
Yes.
we put atropine.
Dirophilaria usually comes out in the evening. I don't know if we have learned in the, it comes out in the evening so that when the mosquitoes come and bite it, the larvae can enter the
Propagation is much
mosquito.
easier.
So one patient had come saying that when she comes out to see TV, the worm also comes out too.
Maybe to
and
watch
comes
serial
in.
together.
So actually it is not the TV which is attracting the mosquitoes.
the night.
Coming out.
CT or MRI, which do you prefer in?
CT. An orbital lesion is primarily CT. If it is a child and we are suspecting glioma or something like that, we'll go for primarily MRI. Because
if you want to do orbitotomy, don't take MRI and send the patient. Then we'll have to again take a CT. We have to see the bone when we want to do the case, isn't it? So
CT is always the first image.
Even the soft tissue masses, everything you would
Yeah, yeah, we can see.
Whatever soft tissue, only after biopsy we can see.
With contrast.
With contrast.
Wow. Ma'am, do you have lava? I have never come across.
I have never
come across.
We send it to Amrita for, we put it in spirit, the live worm, or even parts of the worm, dead worm, and then we send it to Amrita. Dr. Anil Kumar will do the PCR. So he only diagnoses which worm it is. So mostly it has been Dirophilaria, but one or two I think have been Brugge Malay.
I had one case of lova.
He said you sent it there, no?
No.
He said he had one case of lova. Maybe I don't know.
Morphologically identified, no?
No, that we sent to the lab. Then in DDRC Trivandrum they were doing that and
They look only at the morphology. If you do PCR only, you can find out the real
exactly.
what worm is it.
Thank you.
The next speaker is Dr. Ani Sridhar. Dr. Ani Sridhar, first of all, to me is my mentor, as I did my fellowship under her. Ani Madam has done her MBBS from Thrissur Medical College and MS Ophthalmology. And MS Ophthalmology from Calicut Medical College. Madam joined Little Flower Eye Hospital, Angamali, where she worked in various capacities since 1996. In 2002, she mentored under Dr. Santosh Honawar at LV Prasad Eye Institute, Hyderabad. She then started the oculoplasty and neuro-ophthalmology unit at LF Hospital, which she heads. She started the first full-fledged prosthetic eye clinic in 2005. Since then, she has trained many ophthalmologists and won awards at CMEs. She won the MS Subramaniam Award at the Oculoplastic Association of India conference in 2019 for her detailed study and paper on dirophilariasis in Kerala. So that's the person you should ask about these things.
I don't know. Okay. I worked in various capacities in LF, starting from Dr. Itira's fellow actually, for 5 years, doing all the and undergraduate jobs after MS that too. But all that helped me, I think, in the long run to be. So today we'll deal with lid malpositions and anomalies. Upper lid malpositions are entropion, ectropion, and lid retractions. So first we'll do the upper lid entropion. It is inward rotation of the lid margin. The lid can be divided into two lamella, as I don't know if there are any PGs here. Anterior lamella consisting of the skin, the orbicularis and the lashes, and the posterior lamella, the tarsal plate, the conjunctiva, molars, and the vertical lid retractors. Usually we do not have any lashes in the posterior posterior lamella, but there can be metaplastic lashes, as in Stevens-Johnson syndrome. And upper lid entropion is never involutional; it's always cicatricial. Oh, that was a video there. Oh, is it? Okay. So, the entropion, the correction surgery depends on the thickness of the tarsal plate. If it is a thick tarsus, as in trachoma or recurrent chalazion, you can do a wedge resection. Usually we don't do a wedge resection now as it recurs. But the tarsal fracture rotation is a preferred surgery now if you have a thick tarsus. If the tarsal plate is thinned out, as in Stevens-Johnson or alkali burns, then you have to do an anterior lamellar repositioning. I'll show the videos. In anterior lamellar repositioning, here the lid is split into anterior and posterior lamella. Here you can see some metaplastic lashes in the posterior lamella also. And then it is split along the gray line into anterior and posterior lamella. I am sitting at the head end of the patient and I am operating under the microscope. So all the images will be actually inverted, the videos. So at the gray line the lid is split. I have already made a lid crease incision. And then the two incisions are joined. You have to be careful not to cut through the lid. Actually nowadays we put a squint locking forceps at both ends. It is much easier to do now. We have stolen the locking forceps from the squint surgeon. And you reposit the anterior lamellar about 3 or 4 millimeters above the lid margin. And we place continuous sutures of 6-0 vicryl, which can be locked. 1 or 2 can be locked so that it doesn't loosen. These sutures are not removed. When you put these sutures, always invert the lid at times to see that it doesn't go full thickness. Somebody should hold the lower lid margin so that the lash line should be at least 3 or 4 millimeters above the lid margin. Then the lid crease is then closed. Here you can see the post-op appearance. The lash line is well above the lid margin, and this raw area can be left alone. You need not cover it with mucous membrane or amniotic membrane. It will heal quite well. No, we reposit it. That surgery is we displace it superiorly. Not eversion, no eversion. Only because the tarsal plate is already very thinned out in Steven Johnson. Steven Johnson and alkali Burns tarsal plate is thinned out. So you just reposit the anterior lamella. When the tarsal plate is thickened, what we do is we cut out a triangular wedge of tarsal plate from the anterior part. And when you close the triangle, the tarsal plate is said to be everted. But this is a very old video, and now I don't do it much because this always recurs. You cannot cut a huge part of the tarsal plate.
In chronic trachoma, you do this?
Yeah, I don't do this much now. Now we do the tarsal fracture rotation. If you have a thick tarsal plate, you can mouse work. The tarsal plate is cut full thickness from the lateral to the medial end till you see the orbicularis. You can do it with a cautery, but if you do it with a knife, it can bleed. This is also bleeding, I think. Then you place sutures, double-armed vicryl sutures from the tarsal plate to near the lash line. Take about 3 to 4 millimeter wide sutures. It should emerge out near the lash line so that after you cut the edge of the vicryl suture, you can use a cutting needle, 1 centimeter cutting needle. And when these are tightened, the lid will evert. If the endopropion is localized, as in a trauma, you can do a pentagon excision. And if it's a large area of cicatrization, you can release all the tissue and then do a skin graft. Ideally, it is from the upper lid of the other eye, or you can even do a post-auricular skin graft. If the eyelid is very floppy, this is called the floppy eyelid syndrome. This is actually a type of ectropion where the lid will evert on sleeping, and there will be lag ophthalmos and dry eye. When the patient sits up, you may not be able to note it. Always, when there is a dry eye, unexplained dry eye in a young patient, you have to ask if there is lag ophthalmos on sleeping. So here you have to do a pentagon excision and shorten the lid. Now coming to dysthyroid ophthalmopathy, where there is a lateral flare, that is the lateral part of the upper lid will be above the medial. Usually the lateral part is 1 millimeter below the medial in normal eyes, whereas the lateral flare, you will have to do a conjunctiva, Muller's and levator recession or incision. Here with the cutting cautery, evert the lid on a desmar and then just incise the conjunctiva. Step by step, you can see the Mullers, incise the Mullers, you can see the conjunctiva retracting, and also the lateral part of the levator. You can also cut the levator. But this is a good result, but when the patient remains hyperthyroid, sometimes the lid can go back to the original position. So you have to tell the patient that it can recur. He may require a re-surgery. Coming to lower lid entropion, it can be either involutional or cicatricial. So what is the pathophysiology of involutional entropion? This is a question which is asked frequently in PG papers. It may be due to vertical laxity of the lower lid retractors, overriding of the preseptal on the pretarsal orbicularis, interning of the tarsal plate, and they may or may not be horizontal lid laxity. So here you can see a band in the lower lid, which is due to the overriding of the preseptal over the pretarsal orbicularis, and you can see that the tarsal plate has also been interned in the diagram. So how will you differentiate between the two? In involutional, there are only intermittent symptoms and it returns to normal after reversion. But in cicatricial, the symptoms will be constant and it returns to the inverted position because there is a scarring after reversion. And always look for horizontal lid laxity by pulling the lid laterally and see the excursion of the punctum. Is it at the medial canthus, is it at the pupillary area? It can even go up to the lateral canthus. And also the snapback test will pull the lid vertically down. If it is more than 6 millimeters and how much it snaps, how much time it takes to snap back. So the factors which are corrected by surgery, this Jones plication which is usually done, is a vertical retractor laxity corrected by plication of the retractors. I'll show the video. Overriding the orbicularis is corrected by barrier of the suture, and inversion of the tarsus by suture bite through the lower tarsus. So that prevents the inversion of the tarsal. Horizontal lid laxity, if it is there, you have to do a lateral tarsal sling or a pentagon excision. So this is a Jones procedure. The lower lid is anesthetized by just injecting 2 ml of lignocaine under the orbicularis. The horizontal fibers of the orbicularis are retracted and then sutures are placed, taking bites from the orbicularis, now plicating the lower lid retractors, take it out and then pass the final bite through the lower edge of the tarsal plate. You will have a gritty feel when you pass it through the lower edge of the tarsal plate. Then only it will remain like that, little permanent. So 3 such sutures will have to be placed. After the central suture, you may have to fish out the lower lid retractor from the depths of the incision. When you place traction sutures on the edge of the lid surgeries are always much easier, those who do lid surgeries. And then the skin is closed, the final result should be a little bit of eversion. This is the appearance after lateral tarsal sling and entropion correction. If the entropion is acute and the patient cannot undergo surgery, if he is on clopillet or if you want emergency cataract surgery, patient is bedridden, you can tape the lid like this for a few days, or you can do lower lid everting sutures. The sutures are passed from the depths, fornix, on the conjunctival side and taken out through the skin side near the lid margin. 6-0 vehicle, that needle can pass through the whole length of the incision. If you want to save the vehicle, you can thread a 1 centimeter cutting needle you can get from the surgicals there. This is a temporary procedure. Sometimes it can remain permanent also. cicatricial entropyon of the lower lid. If the lid retraction is mild and there is no lag of thalamus, that is, cornea is fully covered, lower lid retractor recession or incision of the lower lid retractors is enough. But if the retraction is severe, you may have to do a mucous membrane grafting. Here below the tarsal plate, a full thickness incision of the lid is made. Below the tarsal plate. Tarsal plate in the lower lid is only 3 or 4 millimeters wide. So here you are seeing the orbicularis in the depth. And then after harvesting a mucous membrane from the mouth, we have just used a glue. You can put 1 or 2 sutures also. Glue is quite costly. So this is the immediate post-op appearance in the second this thing. But the lid has again retracted somewhat. So whatever you do, all these surgeries will have some amount of, always tell the patient that you may have to do resurgery and then do surgery. So involutional ectropion of the lower lid, where here is a peculiar case where the lower tarsal margin was tarsal plate was not attached to the lateral margin. So here the tissues were very lax. He also has a ptosis. I don't know if Marian has noticed these type of cases where the tarsal plate is not attached to the margin. So here again we did a lateral tarsal sling, where the tarsal plate is shortened and attached to the lateral orbital margin. Here I have inverted the diagrams because I am sitting at the head end of the patient so that you will understand. Here after a canthotomy, I am doing a cantholysis where the lower canthal tendon is strummed and then cut to release the lid. So the lower tarsal ligament has to be, palpebral ligament has to be cut, and then the excess of lid is then cut into anterior and posterior lamella at the gray line. The skin and the orbicularis is held by the assistant. You can do all this with a cautery to minimize the bleeding. And then you tighten the lid and see how much of the tarsal plate has to be thickened, shortened. And incise the tarsal plate at that level. And then whatever is going to be buried, you have to remove the epithelium by de-epithelializing with the cautery itself. Then 5-0 ethibond sutures double armed are passed through the tarsal plate. You can see how it's only 3 to 4 millimeter wide, the tarsal plate, and knots are put so that it doesn't cut through. These are double armed 5-0 ethibond sutures. Then they are passed through the lateral orbital margin. It's said to, you should pass it a little above the lateral orbital tubercle. And then you tighten those sutures. Those are the traction sutures. This 5-0 ethibond, you should have a good grip of the needle holder. The needle holder is slipping actually. And then the excess of skin is cut. As this is a young patient, there is not much of excess of skin. So after that you have to form the lateral canthus. This suture is very useful when you are repairing after injuries, lateral canthal injuries. This is a slanting mattress suture, where a large bite and a small bite are taken as you suture a lid margin, pull margin of the lid. Siju will remember, I see. Mattress suture which is slanting to form the lateral canthus. Okay, that is tightened and the skin is closed. So this patient had ectropion only on looking up. So he wanted that corrected. This was very well corrected by a lateral tarsal sling. And what is epiblepharon is seen in young children, where a roll of skin pushes the lower lid in. Only if the patient has symptoms like watering or corneal erosion, which is rarely seen, need you to do surgery. Otherwise, as the child grows, it will disappear. This is a Holt's procedure where a elliptical skin and orbicularis is cut away, and as you suture the wound, you take a bite from the tarsal so that tarsal plate rotates out. Do you have time for few more slides? I don't know.
Yeah, sure.
3 minutes, okay. So this is in blepharophimosis. When do you do surgery? If the ptosis is severe, always do surgery when the child sits up. Do not touch the medial canthus then. Medial canthotomy is done, canthoplasty is done only at 3 to 4 years of age after the canthus and all develops. And whenever you do a canthoplasty, you may have to repeat sling. So all these are just general knowledge. So in plexiform fibroma, you have to do horizontal and vertical shortening of the lid. And sometimes you may have to sling the patient again. But sometimes you can you can excise enough of tissue so that you don't have to do a sling. Upper lid colobomas corrected with a simple tensile flap without any cutler beard or any graft. This is again a golden hair syndrome with primary closure. I think the skin of the children, they can be corrected primarily without any graft or cutler beard because they are very elastic. Thank you. From the land of Purams. I am living in Thrissur.
Any questions?
Double? Yeah, for the entropion. Yeah, I think whatever you do, you create a scar there. You can do Weiss procedure or any procedure. You create the scar there so that the orbicularis will not ride up. I have given Botox also, but that does not act much. It recurs. And the vical sutures outside the skin also are not taken out. You have to create a scar there so that the orbicularis does not ride up and push the lid in. So whatever procedures, there are many procedures described. So whatever you do, I think the scar there is the most important thing. Dr. Sabida, you do some oculoplasty. Yeah.
Entropion and ectropion correction I used to do.
You have anything different from what I do?
Now I am doing that lid sutures. Earlier we used to do with the speculum and all. Now with the sutures it is very easy, and with the RF cautery it's easy to do now.
Traction sutures on the lid margin makes surgery very much easier. So you can control the lid.
No other questions. Thank you, ma'am.
Thank you, ma'am. Medical College. She has fellowship in cataract, anterior segment surgeries, medical and surgical glaucoma, medical retina and ROP from Aravind Eye Hospital, Madurai. She was a consultant at Aravind Eye Hospital, Madurai, and now she is a consultant at Chaitanya Eye Hospital, Trivandrum. I welcome you, ma'am.
Good afternoon to you all. Thank you very much for having me today. I won't be I'll be rushing because everybody will be sleeping. Medical and laser managements of glaucoma. Glaucoma is still the commonest cause for irreversible blindness worldwide, and it's a progressive optic neuropathy with irreversible visual field loss, and only modifiable risk factor is raised IOP. So before starting a medical management of glaucoma, there are certain factors we have to consider. So medical therapy, once initiated, it will be lifelong. So before starting any anti-glaucoma medications, please think about it and ensure that it is a correct diagnosis. Since it is an optic neuropathy, many other optic neuropathies can mimic. Example, ischemic or compressive optic neuropathy. So we have to be sure of the diagnosis before we start the treatment. Once we start it, many other people will be continuing the very same thing without thinking much about it. So we have to be very sure, especially if you see disc asymmetry between each eye. Then assess the severity of the disease and presence of any risk factors such as age, strong family history, myopia and pseudoexfoliation. This is very important because certain diseases like pseudoexfoliation and those with thin central corneal thickness will progress very fast. So we need close monitoring of these patients. Diurnal IOP variation, if possible, you can check, because you should not treatment with just a single IOP, high IOP level. At least 2 or 3 measurements at different timings, it is needed. And all the patients for the first time when you are seeing, please do the gonioscopy. Sometimes many patients, central anterior chamber depth may be normal, but periphery it may be closed. So all the patients you are diagnosing as glaucoma, please do the gonioscopy and rule out angle closure. We have to evaluate the disc, and you can take the photographs and visual fields and OCT RNFL as baseline investigations. And once you are sure about the diagnosis, rule out all the medical condition affected by glaucoma medications such as asthma, heart block, antihypertensive treatments, drug allergies, hypertension, diabetes, stroke, urinary stones, so that you can prescribe accordingly. Compliance to the therapy and affordability of the treatment is very important. So we know we have got a glaucoma patient, we know that we have to reduce the IOP. How much we have to reduce? For which we have a target IOP level. There are various definitions for it, but simply the target IOP is that IOP for a particular patient that will stop the progression of the optic nerve disease. So it may be like different for different patients, for which we have to consider certain parameters like presenting IOP, optic nerve head changes, visual field defect at the time of presenting of the disease, age of the patient, family history, central corneal thickness, associated features like pseudoexfoliation, pigment dispersion, other diseases like cardiovascular disease, ischemic attacks and other systemic problems. You have to consider all these things and find the target IOP. There are various methods to find target IOP, but if you want to simplify it, in mild to moderate disease, it is like near 15. 18 to 15 will be fine. Moderate disease, okay, 15 to 12. And in advanced disease, 12 to 10. And end stage, less than 10 in general. You can tell it like that. And if you consider the percentage reduction from the baseline presenting, it is like 20 to 30% in mild disease, 30% in moderate, and advanced disease, 40% is a must. So in case lower target IOPs are needed at the if the presenting disease is advanced glaucomatous damage, life expectancy if it is long, untreated IOP if it is long low, because in low IOPs itself, if glaucomatous damage has already occurred, that means it is difficult to control, and we need a more lower target IOP. And if there is any additional risk factors, yes, we need lower target IOP. And on anti-glaucoma medication, if the disease is fastly progressing, we have to again reassess and make it more lower. So we have got lots of anti-glaucoma medications like prostaglandin analogs, beta blockers, alpha agonists, carbonic anhydrate inhibitors, parasympathum mimetics, ROCK inhibitors. So how will you choose? So what to give, when to give, we'll see. So there are certain practical considerations we have to see. Plan and achieve target IOP range and reduce the IOP 24-hour IOP fluctuations with minimal possible medications. You should select a drug with adverse effect profile compatible with the patient's systemic illness. That we cannot give a beta blockers to a patient with asthma. Even a single drop of timolol can precipitate an acute attack. So we have to know the patient systemic disease thoroughly and then select your medications. Select minimal drugs to achieve maximal IOP reduction. You should discuss the common side effect of the particular drug to the patient so that patient can pick up the symptoms of ocular allergy very fast, because many a time patient will be using the same drug, usually brimonidine or some medications, for past 3 or 4 months, and patient will be presenting with full blown dermatitis like picture. So we can avoid all those things. if you tell the patient that this particular medicine has got a tendency to have allergy and these are the symptoms, you have to come back whenever if you feel so. In patient with ocular surface disorders, you have to use a preservative-free medications, or if it is not available, along with the lubricants, you can ask the patient to put the lubricants before, and after 10 or 15 minutes, he can apply the anti-glaucoma medications. Use fixed combination to enhance compliance. One is to enhance compliance, and rather than giving two medications separately, all the medication has got the stabilizing agent. So those agents can cause ocular surface disorder. So one drop, instead of one drop, if you're giving multiple medications, every drop has got BAQ or preservative. So you can safely switch on to the fixed drug combinations. Compliance will be better, patient will tolerate it better, and chance of using the medication properly will be more. Switch the drugs. Usually we'll start with glaucoma is not a emergency disease, like it has been there for some time before we diagnose it. So there is no need of rush to reduce the IOP drastically within a month itself. So we have time. It's a like slow progress in disease. So we can always start a monotherapy, and you have to check the IOP levels after 4 to 6 weeks. If that particular drug fails to produce a 20% reduction, then you have to switch to some other medications, or you can add on. Usually add-on therapy is preferred, especially if it is like moderate or advanced glaucoma. Add or combine if first drug reduces more than 20% but still fails to attain the target IOP levels. Maximum medical therapy is like if the patient is using 3 or 4 medications, it is called as maximum medical therapy. Then you have to be prepared for going for a laser therapy or filtering surgeries. Always in young patients with juvenile glaucoma, you have to take the history of pregnancy and lactation. So all the anti-glaucoma medications will come to this group. Either they will reduce the aqueous humor production or increases the trabecular meshwork or uveal scleral outflow. Among the agents, the most potent is like prostaglandin analogs. It can reduce up to 30 to 35% of IOP. Next will be like alpha agonists and beta blockers. Carbonic anhydrate, it is like mild. It can give to 15 to 20% only. So coming to the prostaglandin analog, usually this is going to be a first drug of choice because the patient complaints will be better. You have to give only just once. Usually allergic reactions are much less and systemic side effects are also less. So the mechanism is it will increase the uveoscleral outflow. There are various agents like latanoprost, bimetoprost, travo, tefluprost. But if the patient is going to be on prostaglandin analog for some time, and we have to take up the patient for surgical procedures, or if you feel that it is like moderate to advanced glaucoma, it is better to stick on to latanoprost because bimetoprost and travoprost have got more complications like peripapillary, periorbital fat atrophy, and it will be very difficult to open the eyes, and the conjunctiva become very fragile, and the following surgical procedures will be very difficult, like trab or tube procedures will be difficult. So if the patient will go for a surgery procedure, it is always the latanoprost will be the better choice. And in Arvind, we are slowly switching from the bimeto and travoprost to latanoprost. And combination therapy is available. The dosage is like once daily dosage, usually at the night time. Whenever the patient is just before going to bed, you can use it. So indication, any type of glaucoma you can give prostaglandins, any glaucoma you can give, and usually there is no absolute contraindications, but we have to be careful in if patient gives a history of allergy and uveitic glaucoma, term period of the pregnancy, and any inflammatory conditions we will try to avoid prostaglandins. IOP reduction is good, 25 to 35%. Maximum IOP reduction occurs like 3 to 5 weeks with minimal IOP fluctuation over 24 hours. there is 10% non-responders. In those cases, we have to switch to another medications. But in between the groups itself, even if one patient doesn't respond to one medication like bumetopros, you can try to switch on to the latanoprost or any other prostaglandins, because it may work. So complications, this is like it can cause orbital pigmentation, iris pigmentation, long lashes, and congestion is the most common, burning sensation, and prostaglandin associated periorbital fat atrophy is a known thing. So you have to take care. When you are seeing the sunken globes, please switch over to from bumetol to latanoprost. You can. Second is beta blockers. We are usually using timolol. We have got non-selective and selective. Timolol is non-selective, betaxolol is selective. So we'll use any asthmatic patients, we can give betaxolol, but it is less effective. Mainly reduce the aqueous production, and it can be given in all forms of glaucoma except normal tension glaucoma with systemic hypotension. We have to take care while giving beta blockers, because it has got it can cause severe systemic side effects like exacerbate bronchial asthma, COPD, bradycardia, heart block, and cardiac failure. Twice dosage, 20 to 30% reduction, 2 weeks maximum myopia lowering, and 20% non-responders. So you have to be careful about the systemic side effect in this case. Adrenergic agonists, we have brimonidine, apraclonidine is not available. Brimonidine we have, and we have got low dosage also, 0.1 and 0.2 normal dosage. We can give BD or TID dosage, reduce the aqueous production as well as increase the outflow. Good control, 20 to 30%, but the problem is that you cannot give to young children, because of the it can cross blood-brain barrier and cause respiratory arrest, and also it can cause severe allergy. You have to think about it. Any patient on anti-glaucoma medication, if coming with conjunctivitis like picture, just check that the patient has got brimonidine or not. If it is there, stop it, it will revert. Carbonic anhydrase inhibitors, they are mild. We have dorzolamide and brinzolamide and combination therapies. Dorzolamide, the pH is less, so it has got more stinging action. Brinzolamide, more pH neutral, but it has got blurring of vision because of the it is more suspended. It can cause IOP control up to 15 to 20%, but oral carbonic anhydrase inhibitors can cause like 30 to 40% reduction. But you have to be careful that you have to ask for the sulfur allergy before starting these medications. Renal stones, renal diseases are contraindicated. Parasympathomimic, usually we are not using it unless it is a chronic angle closure glaucoma where no other medications are effective, or narrow angles waiting for laser PI will be plateau iris syndrome, also you can use it. Contraindications like high myopia, chance of RD, any inflammation. It can cause inflammation, so that in those cases it is contraindicated. Hyperosmotic agents can be given in the case of very high IOPs. For sudden reduction, we may need it. We can give IV mannitol or oral glycerol. Acute pressure lowering and prior to the definitive treatment in the case of acute angle closure glaucoma, we can give this. These are the newer drugs. Maybe sir will be talking more about this. ROCK inhibitors, ROK kinase inhibitors. These have got, it will increase the ocular blood flow, improve the retinal ganglion cell survival, and promote axon regeneration. So it has got a neuroprotective effect also. So this is not given as a first line medication, but we are giving it, using it regularly nowadays. It has got transient conjunctival hyperemia, but it is effective in decompensated cornea also. So it is helpful in those cases with decompensated cornea. Fuchs endothelial corneal dystrophy, acute corneal damage, post cataract surgery and all, it will help. So there is even if the patient stops the drugs, there is a washout period for the drug. That is like prostaglandins, its effect will last for 4 to 6 weeks, beta blockers for 2 to 5 weeks, alpha 2 agonists 2 weeks, and rest less. So these are the medical management. We'll go for the lasers. Lasers we are using mainly for laser peripheral iridotomy. ND-YAG laser will be used. It is to make a hole in the iris so that it will there will be a connection between the anterior and posterior chamber, relieving the pupillary block. And those cases where all the medications are used, eye is absolute, there is no PLPR, but still it is a painful blind eye, you can go for a cyclodestructive procedures where diode cyclophotocoagulation can be done. And if there is visual potential, we can try micropulse transcleral cyclophotocoagulation, so that the IOP can be reduced before we take up for any definite surgical procedures. So take home message: establish the diagnosis before starting the treatment. Do gonioscopic evaluation of angles to rule out angle closure component, and we have to repeat it every yearly, because in open angle glaucoma or PXF case later it can go for an angle closure or narrow angles. Assess the severity of the disease and risk factors. Plan target IOP for the particular patient. Start with monotherapy or combination according to the presenting IOP level and disc damage. Proper counseling regarding the strict compliance to the medications and need of regular follow-up. Reassess the target IOP at regular intervals and can step up or step down the AGMs. And screening for the family members, we should not forget. For Arjuna, it may be the parrot's eye, it's a target, but for a glaucoma specialist, it is a target IOP and optic nerve head progression. Thank you.
Thank you, Danya. I think take home message, the last part should be upgraded to as the first part, explaining the condition to the patient. And while choosing the drug, I think the most important thing is to ask the patient how much he can afford. That is very, very important. If you prescribe a costly drug to a poor patient, you can be sure that you will have a blind patient at the end of few years. So it is very important to find out the financial condition before choosing the first line of management. And I think timolol is equally effective, but not promoted by any company or anything. And everything in this world is market driven, you know. So there are promoters for costly drugs. Timolol, unless it is contraindicated, it is very effective. Another thing is, if the patient is hypertensive, just ask the patient to tell the physician, or you can contact the physician and tell that the systemic BP should not be below a certain level, because that will reduce the perfusion pressure in the optic nerve head. That is very important to maintain an optimum level of blood pressure. That is equally important. And most of the time what I see is, as years go by, we are seeing more cases of normotensive glaucoma. Before I have been in the field for nearly 50 years, like Dr. Rachel Jose and Dr. Philip Kurula. So earlier we were seeing with the POAG with high IOP. But nowadays, most of the cases I see are normal tension glaucoma. So we are in a fix. There is no effective agent in our tools kit to prevent the progression of glaucoma. But most of the time, it is not such an aggressive glaucoma we are seeing. Luckily for the patient and for us also.
Dr. Ramya, those who are on systemic beta blockers, this may not work out. Yeah, because first you have to ask, ma'am told hypertension, then you can switch over to the now OD dose has come. You can, because of why beta blockers, usually we will prescribe twice daily, but there will be the less aqueous production in the night. It won't affect you. Yes or no? Now we have in the market beta blockers with the preservative free. OD dose we have, that is the better. Now, any treatment before you start glaucoma, please do all workup, starting from gonioscopy visual field. If you do visual field 24-2, next time same thing you have to repeat. Don't jump into 30-2. Then OCT RFNL, stereoscopic disc photograph, all basic, at least 3 visual field per year you have to do. Then you have to see the progression of the disease. Then very important, first year depends upon the young or old patient, because young patient and pseudo exfoliation we need more aggressive treatment. Old is quality of life, age is not, because of POAG's progression is little less than compared to the pseudo exfoliation. These are the very important thing while starting any medications. All medications associated with pros and cons and its own side effects. Because of prostaglandins are very costly, ma'am, as said by Dr. Ma'am, is cost about 3 ml is cost of the 400 rupees, because insurance is not covered here. And yes, I know, that's why. Thank you, very good presentation, doctor. Thank you.
One more, I would like to ask a question. The timolol OD is given as morning dose, but all the prostaglandin analogs are given at night. Is there a reason for that?
No, ma'am. No reason, just because.
Because
it will
already
cause congestion,
the IOP is going to be lower at night. So why give it at night? I was wondering. Anybody
Because,
any?
Prostaglandin usually starts 4 to 6 hours. Maximum peak effect is 8 to 12 hours. If you check the morning, if you check the IOP in the morning will be low. This is the one citation I saw in the many, because maximum is 12 hours. There will be no.
Whereas for timolol?
Timolol is the BD.
No,
every 2
OD
hours.
OD is also available and we are opting for OD.
Yeah,
now.
because night there will be aqueous production will be the less.
Yes.
That's why it is more effective.
Now I invite Dr. Kiran Ji to talk about optimizing glaucoma medicines for cataract surgery. Dr. Kiran Ji completed his MBBS from Government Medical College, Trivandrum. He completed his MD Ophthalmology in 2008 from AIIMS, New Delhi, and was honored as Best JR. After completion of fellowship training in glaucoma and cataract at AIIMS, he joined Vasan Eye Care Center, Trivandrum as consultant. He has several publications in national and international journals.
Thank you to Pathanamthitta Ophthalmic Society and the Believers Church Medical College organizing team for the invite. And thanks Dr. Kashi to give you your slot for the second talk. My train is at 3:50, so I am a little bit of rush. So I'll discuss about how you adjust your glaucoma medications for cataract surgery. Now, if you look at the number of cataract surgeries performed in India, it's around about 6.5 million, which took a hit during the pandemic years, but it's back to pre-pandemic levels now. And according to the paper by Dr. Ronnie, in 2010, the estimate of glaucoma in India was about 11.2 million, and if you extrapolate the data to 2022, it's around 14 million. So we are dealing with millions in both cataract surgery and in terms of prevalence of glaucoma. So it's only natural to expect a lot of overlap between cataract surgery patients and the ones who have glaucoma. So we will, in the context of this talk, discuss 3 scenarios. One is you have a patient already diagnosed with glaucoma and is already on some multi or mono drug therapy for glaucoma, and we want to see how you can modify these drugs. Then you have a set of patients who have been diagnosed with glaucoma as part of their cataract screening. So we want to see which would be an ideal drug to start. And the third scenario is you have a post-cataract surgery intraocular pressure hike, and we want to see which are the ideal drugs in this scenario. So while there are about 6 different classes of medications which we use regularly, in the context of cataract surgery, only 3 classes are particularly important, which is prostaglandin analogs, carbonic anhydrase inhibitors, and ROCK kinase inhibitors. We'll start with the interaction between carbonic anhydrase enzyme inhibitors and cataract surgery. So dorzolamide and brinzolamide, they act on the ciliary processes, on the isoenzymes 2 and 4 by acting on the ciliary processes inhibits the formation of aqueous. Unfortunately, the same enzyme is also present in the corneal endothelium. This is immunofluorescence localization. And the first question is, do these drugs inhibit the enzyme in the corneal endothelium? Now, the answer is, we'll see. So
You see that black precipitate, this is Hansen's histochemical stain, that is the carbonic anhydrase enzyme in the corneal endothelium. You add brinzolamide, you find that the precipitate disappears. That means the enzyme is not only inhibited in the ciliary processes, but also inhibited in the corneal endothelium. Now, so the answer to the inhibition part is yes. So it follows naturally that if the enzyme is inhibited in the corneal endothelium, there should be an increase in corneal thickness of patients and progressive corneal decompensation if you are using carbonic anhydrase inhibitors for a prolonged period of time. And this study looked at the change in corneal thickness with all anti-glaucoma medications over a period of 8 years, and they found that the only drug which actually increased central corneal thickness was actually carbonic anhydrase enzyme inhibitors. But millions of patients are on these drugs and they do not develop any corneal problems in our practical experience. And why is this so? This is because though there is an increase in central corneal thickness as shown previously, it's only about at most 5 microns in a given year, which is not very significant over the course of a patient's lifetime. Yet in literature you will see multiple reports of using dorzolamide and brinzolamide and patients developing corneal decompensation, right? You see multiple case reports, but there is one caveat in all these cases. These are all patients who already had a compromised corneal endothelium. So essentially carbonic anhydrase enzyme inhibitors creates corneal edema only in compromised corneas, and there are some basic sciences reasons why this is so. Because of lack of time I won't be discussing that. So let's look at some practical pearls. So what do you do in the context of cataract surgery when you have these medications? So there are two things basically that determines whether you want to modify this drug. One is the health of the corneal endothelium, and the other is the complexity of the cataract itself, right? So let us look at the first scenario. So you have a newly diagnosed glaucoma and you want to perform cataract surgery. You can basically initiate this drug in all cases as long as the corneal endothelium is healthy and the patient doesn't have fuchs or anything like that. This is not a grafted cornea. Where you have a suspect corneal endothelial problem, you have other choices. You might as well avoid this. And the cataract is relatively simple. If you are expecting a very hard cataract and you feel that the endothelial cell loss in your hands in this particular eye is going to be more than average, you can switch to consider starting some other drugs, right? You have other choices. Now, the same thing, if the patient is already on carbonic anhydrase enzyme inhibitor and you want to perform cataract surgery, as long as the corneal endothelium is healthy and the cataract is of a simple nature, you need not change anything. You can basically continue. In the postoperative intraocular pressure hike, the only thing that you would want to check is if the pressure hike, generally in the presence of an intraocular pressure hike, there will be some epithelial edema, but this will be different from the stromal edema that is created during endothelial cell loss. So as long as the endothelium is healthy and there is not much of stromal edema, again these drugs can be given. But keep in mind, these are not first line drugs in terms of intraocular pressure lowering efficacy. You have drugs which are stronger. To ROCK inhibitors and cataract surgery. Now ROCK inhibitors have been around for quite a long time now. In the last couple of years, it's been available in India as well. You had Repasudil, which was first approved in Japan in 2014, and then you had Netarsudil, which was approved in the US in 2017. Now, these drugs act on the ROCK enzymes, which are mainly present in the trabecular meshwork. You can see these tightly compacted actin filaments. You can see that those actin filaments are very tightly compacted, and when these drugs act, you can find that they undergo disorganization. So what happens is that the trabecular meshwork now has increased outflow, and that is how it reduces the intraocular pressure. But the same thing, the same enzyme is also present in the corneal endothelium. However, the effect of these drugs on the corneal endothelium is actually beneficial. So this is an in vitro model. So you can see in the central picture there is a surgical wound that is created in the corneal endothelium, and you can find that when you add this drug, the endothelial cells actually undergo proliferation and migration and is actually closing up the wound. And this has prompted our corneal specialists to use these drugs right, left and center in multiple corneal endothelial conditions. So they have now published a lot of case series. There are a lot of case series since more than a year now, and this is just an example of one of those case series where they have used in iridocorneal endothelial syndrome, graft failures, all conditions where there is a corneal endothelial problem. And in general, they do work well. This is an example of a pentacam image of a patient with more than 700 microns corneal thickness in an ICE. And after 1 month's therapy with Netarsudil, you find that the central corneal thickness has come down by about 600 microns. However, as these corneal people started using these drugs more and more in corneal endothelial conditions, reports started surfacing about a new kind of edema developing in these patients, and these were referred to as either corneal honeycombing or reticular bullous epithelial edema or transient reticular cystic epithelium, essentially a kind of honeycombing of the cornea. As you can see on the picture, you can see a honeycombing of the cornea with a lot of vesicles in the epithelium, and you look at the anterior segment OCT, you will find that these vesicles are confined to the epithelium and the stroma is unaffected. But when you withdraw these drugs, these vesicles tend to disappear. Now, there's a paper published recently, about 6 months back from Shankar Nethralaya, which looked at this honeycombing, and it actually provided a little more data that was not previously available. One thing was that this can occur even in the absence of a pre-existing edema. Initially, it was thought that if you had an endothelial edema, like in a Fuchs case, and you put these drugs on, it will shift the edema from the stroma to the epithelium, and that is how it caused edema. But the Indian paper actually showed that it can occur in the absence of pre-existing edemas, but only in the presence of compromised corneal endotheliums. And initially it was believed that this honeycombing was not going to affect visual acuity, but it does affect visual acuity. And between the two drugs, repasudil and netarcudil, this particular side effect actually varies. You find that with netarcudil, the frequency is much more, and the size of the vesicles and the area of vesicles is actually more widespread, as you can see on the left hand side with netarcudil. With repasudil, the epithelial honeycombing is pretty much more localized, and the time to edema with netarcudil is only 25 days. It's much more with repasudil, but only once you withdraw the drug, the repasudil patients will take much longer for the edema to disappear. So basically, ROCK inhibitors in the cornea will act as a double-edged sword. One, it reduces stromal edema, but it can cause epithelial edema. Now let's look at some practical pearls again in the context of cataract surgery. So in newly diagnosed glaucoma, again, it can be initiated in absolutely all cases. There is absolutely no contraindication. You can use these drugs. In already diagnosed glaucoma, the patient is already on these drugs, you can continue. You don't have to think too much about it. In fact, in postoperative intraocular pressure hike, this is again absolutely useful in all cases, because this will not only reduce the intraocular pressure to some extent, but will also help in reducing the stromal edema. Just watch out for the epithelial edema happening, and if it happens, you can simply withdraw the drug. And in the postoperative intraocular pressure hike situation, you might be better off using repasudil, because the time to occurrence of edema is much later, and since we are using this drug in the post-op scenario only probably for a short period of time until the edema and the intraocular pressure comes down, repasudil might be a better option in these particular circumstances. Now, PG analogs and cataract surgery, the eternal question: do PGAs increase the risk of CME following cataract surgery, and do we stop PGAs prior to cataract surgery? Now, the original hypothesis of how PGAs and prostaglandins cause CME was described way back in 2002 by Dr. Miyake. This is still continues to this day. So you do any manipulation in the anterior chamber, it will cause accumulation of prostaglandins and inflammatory mediators in the aqueous. Now, a part of these inflammatory mediators are absorbed by the ciliary processes, but a part of which does not get absorbed. So this will actually diffuse into the vitreous, the transvitreal diffusion, and this causes CME. And this is because it is because of the transvitreal diffusion that is going to take place over weeks. That is why CME occurs late, not immediately in the first week after cataract. It occurs 4 to 8 weeks after. And it follows from this picture that if the inflammation produced is much high, the amount that can be uptaken by the ciliary processes is also going to be less, and there is extra element of inflammatory mediators diffusing into the vitreous. Where the prostaglandin analogs act is, it will inhibit this uptake of the ciliary processes and cause increased risk of CME. This is a theoretical explanation. And if you look at literature, a lot of studies, cystoid macular edema associated with all the three prostaglandins, preservative-free formulations, preservative-containing formulations, complicated cataract surgeries, uncomplicated cataract surgeries, enough and more literature. But almost all these literature evidences, at best level 4 evidences, not very high in terms of the quality of evidence. Only 2 RCTs have been published so far which looked at this, which would be around level 2B evidence. And the first RCT actually showed that there was no change in central macular thickness whether we are using prostaglandins or not at 3 months. At 1 month there was some difference, but not statistically significant. The other RCT actually showed that there was a difference, that those who were using prostaglandins did have higher central macular thickness or higher CME, but they found that it was not enough to cause a difference in visual acuity, which means this is mostly a diagnosis on OCT rather than a change in visual acuity per se. So a systematic review, a kind of meta-analysis that looked at all the studies with prostaglandins and CME so far, concluded that there was no real evidence to stop PGAs prior to cataract surgery, but that caution is required in complex eyes in the postoperative period, and you should perform what is known as risk-benefit analysis for individual eyes. So what are these complex eyes or at-risk eyes? And these are eyes with retinal vascular disorders, diabetic retinopathy. If you have an ERM preoperatively, better avoid prostaglandins. Complicated surgeries, if you have torn your posterior capsule during the cataract surgery, or if your surgery involved a lot of iris manipulation, you have used hooks and things like that, probably avoid prostaglandins. And if you have the patient's history of a CME in the other eye, you can as well avoid prostaglandins in this eye. So again, look at the practical pearls. You can initiate PGAs in basically all newly diagnosed glaucomas, even though you're planning a cataract surgery, as long as they are not what I described earlier as at-risk eyes or complex eyes. In an already diagnosed glaucoma, you need not stop, you can continue except in the complex eyes or at-risk eyes. And as far as post-operative intraocular pressure hike is concerned, this would be one of the last drugs you want to use, because the intraocular pressure hike will usually in the early post-op period will be accompanied by some higher than normal degree of inflammation as well, so you might increase the risk of CME. Now, when you use prostaglandins in all the three scenarios, you better add topical NSAIDs also as part of your drug regimen to reduce this risk of CME. And one important thing is, when you stop PGAs for whatever reason, you have to understand that you might decrease the risk of CME, but you might increase the risk of worsening glaucoma, because PGAs are simply the most powerful drugs in terms of intraocular pressure lowering efficacy. So we have seen some general guidelines on these three drugs and how they interact in the context of cataract surgery, and these general guidelines should help you to formulate individual actions. But I leave you with the words of Dr. George Spaeth, which he wrote as part of his foreword to the EGS guidelines published a couple of years back, that care must be personalized for it to be optimal. So no guidelines can apply appropriately to every unique situation. What it means to say is, you might think that, okay, there is no evidence in literature to stop PGAs prior to cataract surgery, but you have a patient who is, say, one-eyed. Now the other eye is what you want to operate now. Suppose this patient has minimal disc damage, which is currently being on control with prostaglandins. Would you want to take the risk even if there is a slight increased risk of CME? Because after all, the glaucoma is minimal and the prostaglandins are, well, you can easily substitute it with something else for the time being. But on the same, if the same eye had a very advanced disc damage and you are now pretty much on maximal medical therapy, and now you want to perform cataract surgery, there you might not want to stop PGA. So eventually our care is personalized. Thank you.
If you want to stop
it's
the
okay.
prostaglandin, for how many days prior to the surgery would you stop?
That is another issue. That is why I usually don't stop prostaglandins. If you really want to, have a good washout period, you will probably need at least a month prior stopping prostaglandins, because if you have seen the patient today and you're posting the patient for cataract surgery in about 3 days time, and you are stopping prostaglandins, there's a quite a significant concentration of the prostaglandins in the aqueous. So that would mean that you would want to stop it at almost 4 weeks prior to the surgery, and that is why most surgeons do not these days stop PGAs.
If you want to stop the prostaglandins, okay, you can stop, then you can start oral Dimox for at least 2-3 days, other choice.
But the problem is, sir,
because systemic other problem,
No, not the systemic issue. If you were to stop prostaglandins,
1 month.
for 1 month,
6 weeks is the washout period minimum. 4 to 6
even
weeks.
if
The
you assume it's 4 weeks, you can't give Dimox for 6 weeks.
No. We can alternate, substitute to the other drugs.
Yeah, that is
like
what I said.
Newer one. Yeah.
If it was a single, the patient was on a single monotherapy and the disc damage is not much, then you can easily substitute it with something else. And the problem of substitution of prostaglandin with something else is that, in general, if you want to get similar efficacy in terms of intraocular pressure lowering efficacy, you will need to use a combination. So instead of prostaglandins, using an alpha blocker is not going to, alpha agonist is not going to work. If you want, you will probably need to use a combination, say timolol
dorsolamin or timolol. Yeah, it's a combination.
No,
But if the
but,
patient is already on, say, 2 bottles, one on the combination and prostaglandins, then the change from PGA to something else becomes very tricky.
Yes. Then in advanced stages glaucoma, especially during the cataract surgery, the phaco, surgeon should be take very careful because of the during the phaco also will increase the pressure.
Yes.
That is the one. Second, post-operative, so many times we see because of viscoelastic left in the chamber. 2-3 days it will usually subside.
That will be fine.
Yeah. Otherwise, you continue the same glaucoma restart.
As a corneal surgeon, I'm as far as glaucoma drugs are concerned, I'm not really worried about the endothelium. There are theoretical risks and all.
Yeah, theoretical risks only. But as I said, this is, see, there are lakhs of patients on dorzolamide and brinzolamide. None of them develop any corneal problems. And there is a reason actually. The reason is that this has been demonstrated in animal studies. If you do, there's a study, I had actually put that study initially. Due to the lack of time, I withdrew that. There's an IOBS study which actually showed that across the endothelium, there is ion transport mechanism. In human eyes, it's actually not blocked by brinzolamide or dorzolamide because there are other mechanisms. Whereas in bovine eyes, where this carbonate-based mechanism of ion transport is predominant, you add this drug, corneal decompensation happens very fast.
There are various pumps in the cornea. It's not just
these pumps. That is why it doesn't happen in
carbonic anhydrase pumps, because recent articles in the glaucoma this June they told the honeycomb appearance patient underwent dull can dissect patients.
Okay. That's a different.
What I really wanted to drive was, as corneal surgeons, we are not really worried about the endothelium and glaucoma. Glaucoma drugs are mainly our enemy of the ocular surface. So even when you're giving dorzolamide or any other drug, the preservative that comes with them, that is the real villain as far as we are concerned. More than their endothelial problems. Many times we see patients who are on anti-glaucoma medications containing BAK post-operatively developing all sorts of ocular surface, though temporary, but it can be distressing to the patient. We have to either convert to we have to ask our glaucoma colleagues.
Are you sure it is because of the preservatives?
Mostly,
how do you
yes.
know?
Mostly, yes.
But how do you actually know? That is the problem.
It's a clinical diagnosis. There is no real way of.
That is the
no
problem
real way because when you stop the BAK containing drugs, you can have the preservative-free formulations. I mean, it is not the actual drug within the bottle that is producing problems. It's the preservative. When you
look, this preservative issue is with respect to its ocular surface. I'm not going to comment on it too much, but I'm not 100% sure whether preservative. I'll just tell you with prostaglandin and CME. I showed you a diagram of CME caused by Dr. Miyake. He had given this as part of the Binkoff's lecture, a very prestigious lecture back in 2004. And he said that the CME is not caused by the prostaglandins but by the preservative. That was his hypothesis, and that was his Binkoff's lecture. And everybody thought it was the preservative that was causing CME and not the prostaglandins. But subsequently, all studies have essentially shown that even with preservative-free tafluprost, CMEs happen for one reason or the other.
Maybe true regarding the CME.
So
but the ocular surface is quite obvious. I mean, we've seen so many cases where you stop when you convert to nowadays preservative-free formulations are
available. So that is the general advice for all situations where you have a preservative-free formulation available. Always start a preservative-free formulation.
I think they should, invent preservative-free formulations for all the classes of glaucoma drugs. Because just word about the ROCK inhibitors. The ROCKs have been going around a lot. I've seen many people using it right, left, and center, not for glaucoma, but for frank pseudophilic bullous keratopathy. It doesn't work for that.
It will not work.
Doesn't
work for that. It will see again with ROCK inhibitors. We know to some extent that it works to reduce the corneal stromal edema because in most of the patients, part of the reason why honeycombing is probably developing is because it's able to, kind of absorb the fluid from the stroma into the epithelium. That probably one mechanism by which
this interest actually came after the Japanese study by Kinoshita et al. They did they are still working on it, on injection of corneal endothelial cells along with ROCK inhibitors inside the eye, which probably can replace all sorts of endothelial keratoplasty. That is still in the experimental stage. I think that is from where this idea got picked up. And now they're giving the ROCK inhibitors after decimetorexis, all those procedures. But I don't think it will be advisable to give to a frank
No. Now it's mostly being used in the early post-operative hikes. You know, day one you find some edema, some intraocular pressure hike. You can basically use this drug because one, okay, intraocular pressure reduction is there. It's not too much, but it is there. And then it will probably have some effect on reducing the edema. And plus, the worst thing about these drugs is its hyperemia.
Because hyperemia.
Yeah, yes, bad hyperemia. But in the post-op period, the patient is on bathing in steroids anyway. So that hyperemia gets masked to some extent. So that is why in the early post-op period, this has become like a, a very go-to drug.
And the reticular edema I've been seeing more now.
Yeah.
With the Ripasudil also.
Yeah, you will see more and more because in the trial data for these drugs, which was originally approved for glaucoma, right? It was never approved for corneal endothelial cell use. So both the approval in Japan for Ripasudil and Nethram 2017 was for glaucoma and ocular hypertension. And none of the trial data, this defect came up. This never came up. It started coming up when cornea people started using it for edemas and corneal endothelial problems.
Yeah, another thing it can produce, the Nethram can produce is the vortex keratopathy. It doesn't produce any visually significant effects, but it can.
Okay.
Hyperemia and irritation.
Oh yes.
Very
Notorious.
severe. Yes.
Notorious.
Recently, I had a patient who was started on Nethram from Ernakulam. The patient is from Alleppey. The next day, she landed in my clinic saying it is so bad. She can't tolerate it.
It's a third-line drug for glaucoma.
Yes.
So, if that is the end, I'll probably take leave. My train should be arriving in time.
Yes.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Sir, now I request Dr. Satish Thomas to give memento to Dr. Kiranji. Thank you, sir. Now I invite Dr. Kashinath Shenoy to talk about newer modalities of glaucoma medicines.
Good afternoon to all. Thank you for giving me an opportunity to talk in this symposium, especially Patented Ophthalmic Society and cases. I would like to talk about targets of the medication pipeline and update on some new and emerging treatments. Glaucoma is one of the most common cause of irreversible blindness in the world. Glaucoma is the second leading cause of blindness in the world, especially 60 million people are affected by glaucoma. No financial interest or financial conflict. Outlines of my talk: new topical pharmacotherapy, fixed combination drugs, preservative-free drugs, sustained release drug delivery, drugs in pipeline, neuroprotection, and conclusion. Yeah, go back to history. First we started 1887. 1887 we started with physostigmine like pilocarpine. Then after so many decades, 100 years, 1996, prostaglandin is marketed and now it is the first line of therapy for glaucoma. After 20 years, 2017, we started one more nitric oxide donating prostaglandin analog. 2019, rocklatan, combination of netazoxanide and latanoprost. Then 2020, intracameral brimatoprost is in the market. Yeah, what are the available anti-glaucoma medications? Prostaglandins, nitrous oxide donating compounds, rho kinase A, NCX47 is the pipeline, muscarinic agent, beta blockers, alpha agonist, carbonic inhibitors. Combination therapies, advantages: increase compliance and adherence, decrease preservative, rocklatan, Cosopt, Combigan, Simbrinza. Extended duration of intracameral, Duracet, bimatoprost SR, then Envisa, extended ocular insert, bimatoprost ocular ring. Why we need drugs? The unmet needs. Changes for next generation IOP lowering therapies, improved outflow to trabecular meshwork, especially nitrous oxide. We will discuss next slide. IOP reduction, non-inferior to timolol,
consistent 24 hours IOP reduction, sustained long-term IOP control, lack of systemic side effect as said by Dr. Danya, like beta blockers we cannot use in many cases, reduced dosing complexity, fixed combination. Next is neuroprotection. Yeah, come to Vyzulata, latanoprostone binod. Latanoprostone binod is a prostaglandin analog that contains arm of nitric oxide, providing dual mechanism of action, IOP lowering mechanism by latanoprost by uveoscleral pathway, butanediol monotitrate break down into nitric oxide, which relaxes the trabecular meshwork, increasing aqueous outflow through conventional pathway. Especially in the primary open angle glaucoma, nitrous oxide level is less. That's why nitrous oxide is the known for dilatation of the smooth muscle. It acts on trabecular meshwork and Schlemm's canal. Yeah, you can see trabecular meshwork, contracted meshwork, decrease the outflow. Butanediol monotitrate relaxes the nitric oxide, relaxes the meshwork and increases the outflow. Latanoprostone binod. In the phase 3 trials, Apollo and Luna treatment with Vyzulata demonstrate a mean IOP reduction 7.5 to 9.5 millimeter from the baseline between the 2 and 12 weeks of treatment. No significant safety findings were reported. Side effects same as the prostaglandins. Next, Ropressa, Netastudil. Ripastudil is available in the Japan from 2014. Netastudil nothing but rhokinase inhibitor and rhokinase norepinephrine transporter NET inhibitor. Mechanism of action: reducing the aqueous production, increasing the trabecular meshwork, increasing the trabecular outflow, decreasing the episcleral venous outflow. Yeah, there's some clinical studies. Randomized phase 2 study, 24 hours efficacy and tolerability of Netastudil in ocular hypertension open angle. What they found, Netastudil is exhibited consistent IOP lowering efficacy at the each time point of SS over 24 hours, diurnal and nocturnal IOP. Nocturnal IOP lowering effect of Netastudil was equivalent to the diurnal effect. Phase 2 clinical trials compared with Netastudil to the Timolol. Out of the 1,167 patients were enrolled. Once daily dosing Netastudil was effective and well tolerated in the treatment of patients with ocular hypertension and open angle glaucoma. Then multicenter open label study of Netastudil for the reduction of elevated intraocular pressure, open angle glaucoma and ocular hypertension. Netastudil decreased mean IOP from the baseline in the treatment of native patient. Netastudil demonstrated a comparable IOP control replacing the prostaglandin. Effect on aqueous hemodynamics: it increases the trabecular meshwork, decreases the aqueous production and decreases the episcleral venous pressure. Next is Rocklatan, is Netastudil and latanoprost. It is a fixed combination, once daily used. Yeah, study in a pooled analysis of Mercury 1 and Mercury 2 phase and 3 studies, greater statistical superiority was achieved with the combination of Rocklatan than the latanoprost. A total 62% of the patient treated with Netastudil latanoprost achieved 30% or greater reduction of the IOP. Drug delivery system. Yeah, we have developed many drug delivery systems. Few are in the market, few are in the pipeline, like surface implant, bimatoprost ling, latanoprost eluting contact lens, topical ophthalmic drug delivery, gel forming drops like solid drops, intrascleral implants, ophthalmic micropump, intracameral implant, bimatoprost, it is in the market, iDose tevatoplast, tevoprost XR, subconjunctival implant, the Duracet, punctal plugs, Evolute OTX TP, injectable, especially Grayberg is under trial, it is used for neuroprotection. Yeah, next we will come across Durista, bimatoprost implants and 10 micrograms. Yeah, mainly used of open angle glaucoma or ocular hypertension. Contraindication: corneal endothelial dystrophy, Fuchs dystrophy, then patient underwent DESEC, absence of posterior capsule or PCR due to risk of implant migration into the posterior segment, and acute uveitis and narrow angle glaucoma. Yeah, what is the most common side effect? Artemis study, 27% of the patient developed hyperemia and 5 to 10% developed uveitis, fluctuation of the vision and corneal endothelial cell loss, especially in the Apollo study. Non-ocular side effect is mainly the headache is in 5 to 10% of the patient. Yeah, this is a bimatoprest biodegradable intracameral implant. It is a single dose. It is injected into the anterior chamber. It settles in the inferior angle and stays for IOP control for 4 to 6 months. Then again you have to inject. Is the bimatoprest implant. Yeah. Challenges in glaucoma management: drug ineffectiveness, intolerance, poor patient adherence, compliance and persistence. Ocular surface disease, those attributable to the active ingredient and those attributable to the preservative. And systemic side effects of some drugs like beta blocker, no neuroprotection till now. For this fixed combination, a mainstay of glaucoma management today and tomorrow, fixed combination are highly effective as monotherapy when added to the prostaglandins. Rocklatan is available in the market. Cosopt, dorzolamide and timolol is the only the one drug without timolol combination is available is brinzolamide and brimonidine, Simbrinza, Azagra, timolol and brinzolamide. Yeah. A study fixed versus concomitant unfixed glaucoma treatment on adherence and ocular surface. Yeah. In cases of fixed, you can say 75 in the 3 months, 75% of the patients are adherence, and 3 months 73% of the. If the more unfixed in case of 6 months, it come down to 61% adherent to the medication, and about unfixed only 57%. That's why fixed combination better than unfixed combination. Adherence decreases with additional medications. Once daily or twice daily dose 49%, because of this bar chart shows about 49%. Here more than twice daily it comes down to 39. 2 or more medication daily, 31 patient comes to the 32% of medication. Compliance and long-term burden. It is becoming a standard practice to use fixed combination with the prostaglandin. Beyond 3 eye drops, it is difficult to maintain a long-term compliance. The burden of the family to instill eye drops in elderly patient must also be taken into account, another reason for using the fixed combination therapy. Preservative-free drugs, dorzolamide Cosopt, timolol maleate, tefloflos zeoptin. Glaucoma pipeline view into ongoing innovation. Now we have NVISA, NVI515. It is a biodegradable implant. It is injected into anterior chamber like Tavaprost. Depot implant get injected and target the anterior chamber up to 6 months from the single dose of injection. This is the iDose. iDose is nothing but a titanium implant. It is injected into anterior chamber, angle of anterior chamber. It, according to them, it lasts for 36 weeks. It is a titanium, and advantage of it does not causes any endothelial cell loss. And it is a, once the drug is depleted, we can replace the titanium implant. Now this is the Helios. Is a bimatoprost-laden polymer matrix, 1 millimeter thick and 24 to 29 millimeter thick ring can be inserted in the fornix. Drug releases up to the 6 month. Advantage is excessive mucus production and irritation. Next, OTX-TP, it is sustained release of Tavaprost punctal plugs. It usually stays up to, releases the drugs up to 4 months. Main disadvantage is false. Patient may or may not be knowing. Hopefully coming soon. Neuroprotective therapy is another unmet need in the glaucoma management. Neuroprotective factors delivered inside the eye via injectable vehicles are currently being studied in animal models glaucoma, grey bug. A phase 1 trial of an intraocular device that releases a neurotropic factor NT501 CNTF implant has been completed in patients with primary open-angle glaucoma. Medical strategies, as you know, brimonidine, memantine, brimonidine, second, omega acids, these are tried for neuroprotective. Clinical trials are ongoing. Adenosine receptor agonists like trebodenosine, cannabinoids, and lateral ranunculars. All it affects on the trabecular meshwork and stem cell canals. It helps in the conventional pathways. All are under trial. Now, how to improve the drug delivery system, topical eye drops under innovation. We have nano dropper. Yeah, it is a silicon tube, a elongated dropper. Just you have to remove the dropper and fit into the our AGM eye bottles, because the long dropper, it prevent the touching to the eye and reduce the eye drops about 60% and cost effective silicon tube. Second is another device, gentle drop. You can fix into the nose and fix the AGM bottle to the device. It reduces the touching onto the cornea and better deliveries. Concluding remarks, typically starts with monotherapy with the prostaglandins. If not sufficient, add another agent from different class. Fixed combination therapy should be used if possible to reduce the number of drops and preservatives. Because of compliance is very important. If you give more drops, the patient may not use. Majority of the patients with the glaucoma need combination therapy. Fixed therapy advantages, better compliance, eliminate the washout effect. Thank you for listening.
Thank you, Doctor, for the extensive coverage of the topic.
Thank you, sir. Now I request Dr. Shane Matthew to come forward to distribute the mementos. I request Dr. Shobana ma'am to receive the. I welcome Dr. Kashinath Shenoy to receive the memento. I welcome Dr. Danya to receive the memento. I welcome Dr. Satish sir to receive the memento.
Now I invite the quiz master, Dr. Prashav Mohan, for the most awaited PG quiz.
One, two, three. 1, 2, 3. Testing. ഇതിന് ഓഡിയോ ഔട്ടല്ലേ? അതിൻ്റെ വോളിയം ചെക്ക് ചെയ്യാം. വോളിയം ഒന്ന് ചെക്ക് ചെയ്യാം. ഇത് കാണിക്കില്ലല്ലോ അല്ലേ? ഇത് കൊടുക്കല്ലേ? ഇത് കൊടുക്കല്ലേ? അത് തന്നെ. ഹലോ 1, 2, 3. എവിടെ? അവിടെയാണ് വരുന്നത്. ഓക്കെ, കുറച്ച് അങ്ങോട്ട് തിരിച്ചു വെച്ചാൽ മതി. ഓക്കെ, ബസർ റൗണ്ടിന് മുമ്പ് ഒന്നും കൂടി ടെസ്റ്റ് ചെയ്യാം.
All team members are requested to occupy their respective seats.
Score. Hello and welcome to the PG quiz for this year. I hope it happens every year because quizzing is my passion, and if not me, somebody should do this. I think quizzing should be made a part of all CMEs. That is my opinion. And you should give big prizes to the winners, even to the participants, so as to encourage the participation. Okay, so first of all, I thank Pathanam Thitta Ophthalmic Society for giving me this opportunity. And I will start with the teams have already drawn lots, and I'll start with the introduction of the teams. Team A, please introduce yourself, your names, your college.
I'm Dr. Jayalakshmi R, first year PG student.
Which college?
Believers Church Medical College.
We have home team in Team A.
I'm Dr. Aishwarya Xavier, first year PG student from Believers Church Medical College.
Great, please give them a big hand. Big home support here. Team B.
I'm Dr. Sajna from Chaitanya Eye Hospital, Trivandrum.
I'm Dr. Rubina from Chaitanya Eye Hospital, Trivandrum.
Please give them a big hand. Team C.
I'm Dr. Reshmi from Government Medical College, Kottayam. I'm Dr. Divya from Government Medical College, Kottayam.
Team C, Kottayam. Team D.
I'm Dr. Christy from Giridhar Eye Institute.
I'm Dr. Anne Maria from Giridhar Eye Institute.
Please give them a big hand. Giridhar Eye Institute in Team D.
I'm Dr. Rajlakshmi from Pushpagiri.
I'm Dr. Sinu from Pushpagiri Medical College.
Pushpagiri Medical College in Team E. So please give them once again a big round of applause. And with that, I think we'll start the quiz because you're already late. We'll go straight into the quiz. This will be our first 2 rounds. They will be bounce and pounce. The participants have already been, they have been told about the rules, but for the benefit of the audience, I will repeat it. So both direct and pass questions carry the same points, that is plus 10. We'll follow this format because this is the most fair format of quizzing. The next direct question goes to the team next to the team which has answered the last question. After any question is read out, there will be 5 seconds, which is called the pounce timing. So anybody who knows the answer can say pounce. You raise your hands and just shout pounce. Do not say the answers out until I tell you so. Do not say the answers out at all. In fact, those who have pounced. You can write it down on a piece of paper and you can just show me. The quizmaster can be shown the answers. How I will see it is a little difficult, so just write it in block letters so that I can see it from here. Okay? Please supply them with pen and paper. And if you pounce and you get it wrong, you get -5. But the direct and pass questions all carry plus 10. There are no negative points for not pouncing. I hope all the rules are clear. If nobody answers it correctly, then the question comes back to that first team that I asked the question to. Or if everybody pounces or everybody gets it right, the question again comes back to the first team. Those who have pounced do not get another chance at the pass question. So we'll start with a few trial questions. I hope all of you are ready. There are no points for this. Now, who famously said these words? An eye for an eye makes the whole world blind. Your pounce timings, this question is to team A. This is your direct question. The pounce time starts now. Anybody can pounce. So nobody has pounced. So team A, what is your answer? You have to speak into the mic. There are no negative points. This is just a trial question. Speak into the mic, please. Even if you say pass, say it on to the mic.
Pass.
Team B.
Pass.
Team C, take a guess. So eye donation fortnight. Team D. Team E. No, this is not done. You have to make some guesses. There are so many people. So many politicians, so many actors. Anybody's name you can say. Anybody from the audience? Mahatma Gandhi. Yes, this was said by Mahatma Gandhi. All right, next trial. We have 3 trial questions. Next trial question again goes to Team A. This is your question. Who said the following words? We live in a wonderful world that is full of beauty, charm, and adventure. There is no end to the adventures we can have if only we seek them with our eyes open. Your pounce timing starts now. Anybody wants to pounce on this? At least for trial's sake, pounce. We are very timid people here. Team A, your time starts now.
Jawaharlal Nehru.
Absolutely right. So this is the importance of making educated guesses. You should make guesses, all right? Jawaharlal Nehru is the right answer. He said this in the Discovery of India. And the last trial question, this will go to Team B. Who is making these gestures? Volume up, please. Who was making these gestures? Nobody is pounced? Pounced. Team A has pounced. Anybody else has pounced? C. You can write it down and show me. Show me so in such a way that other teams don't see, okay? Okay. Team A is right. You would get plus 10 if it was a normal quiz. You would also get plus 10. Team B, what is the answer?
Pass.
My God. Team D?
Narendra Modi.
That is the right answer, Narendra Modi. If it was a normal quiz, you would get 10. And you, A and C, would also get 10. But the right answer is, of course, Narendra Modi. And what was he doing this for? Anybody? He was doing this in the parliament. He was mocking Rahul Gandhi for the winking. Okay, now we are coming to the serious business. Okay, the first question will go to Team A. Now, what are these eponymous structures represented by X? Your pounce time starts now. Nobody has pounced. So, Team A, your time starts now. Within 10 seconds, you have to give your answer. Pick up the mic, please.
Pass.
Pass. Okay, Team B.
Pass.
Please answer. Take an educated guess. Team C. Team C.
Pass.
Team D.
Valvo Hasner.
Hasner is what you're saying. No, that is not the right answer. Team E.
Rosenmuller.
No, this is not Rosenmuller. Any other guesses, audience? Any other names? What would that be here? Okay, it is cross. Those are the glands of cross and the valve of cross. Not a very well-known valve, but the glands are pretty well-known. Okay, so nobody gets the answer, nobody gets any marks. The next question goes back to Team A. Team A, you ready? If you pounce, shout loudly into the mic, okay? Say pounce so that I hear. What is the spectral wavelength of visible light? Your pounce time starts now. Nobody wants to pounce? You have to pounce before you write the answer, okay? Okay, Team A. Say loud into the mic.
400 to 600.
400 to 600 micron. 400, 600 what? Nanometers. Team B. I'll reserve my points now.
400 to 700 nanometers.
Again, I'll reserve my points. Team C.
390 to 720 nanometers.
Team D.
420 to 700.
420 to
700.
and Team E.
420
380 to 700.
None of you have exactly got the answer that I wanted. It is 380 to 700 nanometers. However, I'm inclined to give all of you 10 points for it because you have came very, very close. So I'll give all of you 10 points. And well done. So the next question again goes to Team A. So scorers, please note, everybody gets 10 points. Team A. What is the power of this prism? Look at that figure and you have to tell me the power of this prism. Pounds, anybody wants to pounds? Nobody is pounced. Team A, your time starts now. Within 10 seconds you have to give your answer. 4, 3. No answers from Team A. Okay. Team B. No answers. No negatives. Team C. There are no negative marks. Say some number on the planet.
10 prism diopter.
10 prism diopters is the right answer. So for keeping quiet, I should reduce marks for people. Okay, plus 10 to Team C. Quizzing is all about educated guessing. You never know the right answer all the time. It's all about educated guessing. How did I get that? Multiply the distance by 10 centimeter. If it's displaced by 1 centimeter, it's 1 prism diopter. The number of centimeters the image is displaced at the distance of 1 meter is the prism diopters, power in prism diopters. Okay, so Team C has answered. So next question is to Team D. Name this instrument. Does anybody want to pounce? Again, playing safe, everyone. Team D. No negative marks. No laughing if you get it wrong. Your time is up. Team E. Team E. Pass. Team A. Pass. Team B. I need you to speak into your mic. Javel shouts.
Keratometer.
No, it is not a keratometer. Team C. Team C. The time for chatting is over.
Pass.
Pass. This is really disappointing. I mean, you should. I don't expect you to know the answer, but say something. What could it be? The audience, anybody knows the answer? It is a lensometer. Nowadays, people don't see a manual lensometer. They only see automated lensometers. Even that, I'm not sure if they see. It's a manual lensometer. Okay, that question was to Team D. Nobody has answered, no points. So Team D gets the next question again. Give me the diagnosis. The vision of this patient was no PL. Pounce time. Nobody wants to pounce on this. Team D, your time starts now. So no PLI.
Optic nerve avulsion.
Yes, absolutely right. Why are you doubtful about it? Where is the optic nerve? It's a big hole over there. It's optic nerve avulsion post-trauma. So you get plus 10. Team D gets plus 10. So next question goes to Team E. You have to name X. The structure or the space which is marked X. The other things, okay, Team B has pounced. The other things are just clues. Okay, Team B, show me your answer. Okay, plus 10 to Team B. And Team D, your time starts now. Team D, time up. Team E. Keep your mics in your hands so we can speed up the quiz. I have to reach home before the match starts. Cricket match. No? Team A? Where is your mic? You have a mic in your hand? Home team, come on, you have to buck up. Team B? Team B has already answered. Team C? No. Okay, then Team B can say the answer loud.
Canal of Hanover.
Yeah, it's the Canal of Hanover. That's the city of Hanover in Germany, and that's the canal over there. It has nothing to do with that, but just kept as clues. So it is a Canal of Hanover. So only Team B has answered by pounds. The direct question nobody has answered. So the question again goes back to Team D. Look at the picture of this crying infant and tell me what's wrong with it. Pounds time starts now. Nobody has pounds. Team D, you can give your answer. Anything wrong with that picture? I think you have it. You have to tell why also. Yeah, please.
No tears.
Blue tears.
No tears.
No tears. But I can see tears. Should tears have not come? Why did you say no tears? Can you explain why you said no tears? Or blue tears, whatever did you, what did you say? You said no tears. Can't explain why. No. Okay, Team E.
No tears.
No tears. No tears should come or no tears are there. Please make a sentence out of it.
No tears are seen.
No tears?
Are seen in the image.
No tears are seen?
In the image.
In the image. No tears are seen in the image. That is the problem with the image. That is your answer?
Normally tears should not appear.
Normally there should be tears, but there are no tears.
It's a newborn infant.
So it's a newborn infant, so?
No tears.
No tears? Put it in a sentence so that I can understand.
Normally no tears are present.
Normally no tears should come. Is that what you're saying? Or is that what you tell that to me in a sentence? You're making me answer.
Yes, sir.
Say that in a sentence.
It's a newborn infant, so normally there's no tears.
Normally no tears. Why? Why newborn infant don't have tears?
Lacrimal.
Lacrimal?
Gland development.
Development?
It's not formed yet.
Okay, it's not that lacrimal gland development is not complete. I'll give you the marks. Plus 10 to Team E. Please give him a big hand. The newborn infants cannot produce tears. The tears production starts at around 3 months. So Team E gets plus 10. Okay, always be bold, loud, and put it in a full sentence. Okay, the last question of this round will go to Team A again. Plus 10 to Team E. No other points for anyone. Where is the far point of a hypermetropic eye? Pounds time starts now.
Pounds.
Team D has pounced. You will get the time to answer. Okay, plus 10 to Team D. Team A, you can answer.
Behind the retina.
Behind the eye, that is the right answer. In a hypermetropic eye, the far point of the eye is behind the eye. So Team A gets plus 10 as well. So with that, we come to the end of the first round, and the scorers can calculate the scores. During that time, I have some sweets for the audience. This is just for the audience, what is aphantasia? This was an article that I saw on the internet recently. The mind's eye, pupil size may be an indicator of aphantasia. There was a study conducted by a few scientists who found out that pupil size may be an indicator of aphantasia. What is aphantasia? Anybody with any guesses? That is brilliant. That is the right answer. You just have to go by semantics. It is a lack of ability to vividly imagine the images like you would see it in real life. So they said they found that the sizes of the pupil are different in such people. I don't remember the answer to that. Probably larger, I guess. Yeah, so the scores, please. Any mic for the scorers?
Team A, 20 points.
20 points. Team B, 20 points.
Team C 20 points.
20 points to Team C. D?
Team D 30 points.
30 points.
Team E 20 points.
So Team E is 10. All are having 20 points except Team D. They're leading by a slender margin of 10. But don't be comfortable, it can change very soon. So the next round will start from Team E. It will be the rules are the same. It's the same bounce and pounce round. So Team E gets the first question. Are you ready? This is a 30-year-old with a history of trauma. You can see the pictures and you have to give me the diagnosis. Anybody wants to pounce?
Pounds.
D and B have pounced. Show me the answers, please. Okay, Team D gets plus 10. Team B, unfortunately, the answer is not complete. They get minus 5. B, boy, gets minus 5. Delta gets plus 10. So this question is to Team E. You can give your answer now. Traumatic? I need a more specific answer. Looking for a more specific answer. D has already answered. So C.
Siderosis.
Siderosis bulba is the right answer. Why do you say it is siderosis?
It's an intraocular foreign body.
That is there.
And
on the CT you can see that.
In the cornea there are deposits.
That's not really on the cornea. Okay, it's on the anterior lens capsule. Anything in the first picture?
There is a
There is heterochromia.
Heterochromia.
Okay, you get plus 10 for that. C also gets plus 10. So that is the right answer. But B, you said IOFB, you have to be more specific. I was looking for siderosis. You get minus 5. So C has answered this, correct? Am I correct? So next question goes to Team B. Direct question to Team B. A patient with a 30 prism diopter alternating exotropia sees this during a Firth 4-dot test. That is the result that he sees. Now you have to give me the diagnosis. Anybody wants to pounce? Nobody is pouncing there. Your Team B, your time starts now. No negatives. No answers from Team B. Team A.
Pass.
Team A wants to pass. Team E. No answers from Team E. Team D. You have to give some diagnosis. Can only be 1 or 2, 3 diagnoses at the max. No? Team C.
No suppression.
No suppression. Why no suppression?
Inferior dot will be.
Why would you have a person with alternating hypertropia? Alternating exotropia with no suppression? This was a direct question to Team B, I guess. Direct question to Team B. So nobody gets the marks for this. It is because of harmonious ARC. It's abnormal retinal correspondence. That is why there is no suppression. So nobody gets marks for that. Again, the next question goes back to Team B. Be ready. Look at that video. A 60-year-old hypertensive woman. Read the question carefully. Most likely to be on which class of drugs? Your pounds time starts now. Nobody wants to pounce there. Team B, your answer?
Alpha blocker.
Why would a woman be on alpha blockers?
Antihypertensive.
This is the antihypertensive alpha blocker.
Labetalol, alpha plus beta. Labetalol.
No, I'm looking for the most common answer. Team A. Team A, any guesses? No. Team E. Any guesses? Team D. No. Team C. No. Pass. Audience. This question is taken from a study actually. Women, so probably tamsulosin is ruled out. It is not the only drug that produces IFIS. Now we know it is IFIS, correct? It is produced by? No. It's actually, I've seen in many female patients, it is actually the angiotensin receptor blockers, the losartan, candesartan, etc. Irbesartan, those drugs that can produce IFIS. They are the most common reason for IFIS in women, according to one study. So nobody has answered this. Again, the next question goes to team B again. B for boy. This is your question. Look at the image there. It's not an image in a video. You have to identify the condition. Some procedure has been done, and this is a pre and post procedure investigation report. So I hope all of you have seen the video. The pounce time starts now. Anybody wants to pounce? C wants to pounce. Please write your answer and show me. Okay, nobody else has pounced. Plus 10 to team C. Team B, your time starts now. That is the right answer. And what is the investigation that is done? Okay, this is an angiogram that was done. I'll give you that anyway. So the answer is keratico-cavernous fistula. It's a three-dimensional digital subtraction angiogram that was done. That is what is the procedure that was done? Pre and post procedure, what was it? Coiling, yes. That is the right answer. So B gets plus 10. Big hand for them. And the next question will go to team A. Correct? So team A, here is a direct question. Give me the diagnosis. Look at the fundus picture and give me the diagnosis. Anybody wants to pounce? C has pounced. Write your answer down, please. B has also pounced. You have pounced? E has also pounced. D hasn't. So only D has not pounced. Everybody else has. Show me the answer, please. Okay, plus 10 to team C. Plus 10 to team B. Minus 5 to team E. I need the right term. Team A.
Cilioretinal artery occlusion.
That is the right answer. It is a simple question. Cilioretinal artery occlusion. Plus 10 to team A as well. So with the next question will go to team E. Look at this. These two pictures. One's a both are topography pictures, and one is a raw image. And the first picture, the astigmatism value is given above. If you cannot read the one below, some drug was given, and after 2 weeks, the astigmatism reduced to that much. Can you guess what this astigmatism reducing drug is? Your pouncing time starts now. Nobody has pounced. Team E, your timer starts now. Magic astigmatism reducing drug. Stop doing toric IOLs from now on. No? Team D? You have to think slightly different. It's not a straightforward thing. No? Team C? Name some drug. No? Team B? Myotic. A good guess, but then it wouldn't change the topography. Team A?
Paracane.
Proparacaine. A good guess, but no, it does not change the ocular surface. What would change the ocular surface?
Lubricant.
It's a simple lubricant. It is just a dry eye that has changed into that has shown this kind of astigmatism. So that is the right answer. So nobody has given the answer. So no points to anyone. Team E gets the next question again. Am I right? Is that I have made a mistake? It's okay. Team E, the next question. Look at this picture. It is a right eye, picture of the right eye. 25-year-old lady with IOP of 35 in the right eye and 14 in the left eye. That is a specular microscopy image.
Pounds.
Who all have pounced? D and B. B and D have pounced. Okay, D gets plus 10. Dog D gets plus 10. B boy also gets plus 10. And team E, your answer? I?
IC.
What is IC?
Iridocorneal endothelial
Iridocorneal endothelial syndrome. That is the right answer. Plus 10 to team E. And plus 10 to that I've mentioned before. D and B, I think, have. That is the right answer. So the next question goes to team D. Actually, I should hear more applause for the teams, please. Excellent. So team D, this is your direct question. Last question of the round. The 15-year-old astronomy enthusiast boy
Pounds.
with
Pounds.
who all have pounced? D and B have pounced. C also has pounced. So 3 teams have pounced here. And show me the answers, please. You have to give your diagnosis looking at the fundus image and the OCT picture. I can't see. Your hand is covering. Oh, use your direct question. Okay. Okay. Plus 10 to team C. Plus 10 to team B. And this is a direct question to team D. Yeah, your answer, please.
Solar retinopathy.
Solar retinopathy is the right answer. So, what did he do? This usually happens after solar eclipses. So, they see the sun directly. So, solar retinopathy. Plus 10 to team D. Next question. Okay, this round is over actually. So scorers, please calculate the scores. And it's sweet time for the audience. This is a song. Please raise the volume. Really nice song. The stage name of this musician was Kerry Adams. Okay, he's a very famous ophthalmologist. I was desperate. I deliberately removed his real name from the record image of the record. Can you guess his real name? The song is called Telephone Numbers. He's as accomplished a musician as an ophthalmologist. Any guesses? Yes, that is the right answer. This is a song by Charles Kalman. So his stage name was Kerry Adams. So sir, you should give some sweets to others also. Others also should get chance. Okay, the scores please.
Team A 10 points.
Team A 10 points. Team B with 35 points.
Team C 60 points.
Team C 60 points.
Team D 60 points.
60 points to Team D and Team E.
Team E 25 points.
Team E 25 points. So still lot of points to be had. So don't worry for those who have fallen behind. You can easily catch up. All right, we'll go to the third round. It is called Take Your Pick. Okay, so we will go from the team with the lowest scores. They will get the first chance to take the image of their choice, and they will be asked questions based on that image. Okay, so who is at the lowest score? Who has the lowest score? Team A.
Team A 30.
Team A is 30. It's not 10.
30.
Okay, that is a small mistake by our scorers. No problem. We have a 25. We have Team E with 25. So we'll start with Team E then. Team E, you have to take your pick here. In the rules I've explained, it's plus 10 for each right answer. You get 3 questions, no negative marks. You can take your pick. Which one do you want? A, B, C, D, E, F. You can't think so much. A. You have gone for A. So let's see what's in A. Question is to you. You can answer now or at the end. Okay. Name this Nobel Prize winning scientist. His picture is given there. That is for the second question. If you don't know the answer, I can go to the second question. You can come back to the first question later. What is X in that picture? Look carefully at the picture. Something is written on the side. Can you say it loudly? I can't hear you. Into the mic, please. Third question is, what does this graph represent? All these three are related, okay? All these questions are related to each other. So if you get one, you might get the other. In this graph, look at the graph, look at what's written on the graph. What does it represent? Do you know the name of the scientist? No, you don't know the name of the scientist. What is X in that picture? All trans-retinoic acid. That is not the right answer. What does this graph represent? You can see three graphs in three colors and one graph without any color. You can see figures written there. Can you read it? I can read it. Can the audience read it? No? It's wavelength at the bottom. No? Any guesses? Okay, I think we have enough time. Only no marks for the team. The answer was George Wald. The picture that was shown was Wald's visual cycle. Okay, and X was all trans retinal, not retinoic acid. So I can't give you the marks for that. That graph was discovered by Wald. It was the absorption spectra of the cone and rod pigments. So the clue was the three colors and the one without a color. Okay, so we'll go back to the next higher team, which is Team A. 30 points. Who was on 30 points? Team A. I would like you to work together, the scorers, if possible. So Team A, you can take your pick. A is already taken. You have to take something else. Please be quick. I don't want to miss the match. D for Delta. All right. These are your questions. You can see the picture over there and another picture down. Look carefully at that video. And you have to name this Scottish ophthalmologist. The picture gives the clue to his name. If you don't know, you can answer at the end as well. You want to answer now or later? Later. The second question is, you have to give the diagnosis of this. It's clearly written. One is with bright light. One is in dim light. The same eyes of the same person after instilling 1% phenylephrine before and after. Any guesses? You have to guess something. I won't leave you like that. You have to guess something. No? Third question. You have to name this condition. This is the same eye. This is in bright light. That's a torch that's shown there. This is in dim light. These are after putting mydriatic drops. C and D are after putting mydriatic drops. You have to name this condition. You want to try question 1? No? Question 1, no? 2? 2? RAPD. You mean question 2? Question 2 is not RAPD. And third one, last shot. No? Anybody else? No marks? Nobody else from the audience? That's honest. That is honest because there's greater anisocoria in dim light and there can see a mild ptosis. And that is, scientist is Marcus Gunn. It's a Marcus Gunn pupil. And that would be polychoria. It will be polychoria and not pseudopolychoria. Why? That is why the light and the drops and everything. Because both the pupils have sphincters around them. Okay, and they are equally dilating and constricting. So this is a true polychoria, very rare condition. What you commonly see is pseudopolychoria. So no marks there to team A. Which would be the next team in the order of audience? Audience sweets? No, sweets should be given to sir. It is the next team in B. 35 points. 55 points. So team B, what take your pick?
C.
B wants to take C. And these are your questions. You have to name this strabismologist. The clue to his name is in that picture. You want to attempt now or later? Later. Second question, describe one peculiarity about fourth nerve. There are about 3 peculiarities.
Longest course.
The nerve with the longest intracranial course, I'll give you that, plus 10. Third question, look at this picture and name the procedure. It's a surgical procedure. Remember, all the questions are connected. The name of the scientist is not linked to this procedure. The name of the scientist is linked to that picture there. Any of 1 or 2, 1 or 3, do you want to answer now? Take a guess. Say it loudly, no negative mark. I did not hear that fully.
Brownson.
His name is Brownsy.
Brown.
What is it?
Brown.
His name is Brown. I mean, I don't expect you to remember the full name. It is Harold Brown. I'll give you the marks plus 10. That is a Brown syndrome there. And this would be, the procedure would be?
Superior tuck.
No, that is not a superior oblique tuck. I was looking for a named procedure. Sweets, audience. No strabismologists here. That would be the Harada-Ito procedure. No more sweets for you, sir. So I'm going to run through that. So you get 20 points. 20 points, right? Yes, 20 points to team B. Yes, time for the next team to choose their picture. That would be team C and D with 60 points. Would you want to give the chance to each other? You want to answer first or them? Do you want to yield to D? Or you want the first chance? If you want, then I will put a toss. You want to yield or you want the first chance? Or do you want to yield? You want them to take the first chance or you want it?
We'll take the first chance.
You want the first. Both of you want the first chances. So you have to, this is a toss here. What fingers, not number of fingers am I holding behind my back? No, seriously, we have to decide the toss here. D and C. Say the answer. 2. So yeah, you get the chance. It's 2. C gets the C gets the chance. C. So what do you want to choose? A and C and D are taken.
B.
B. B for boy. Okay, here are your questions. If you attended a session in the morning, you will be able to answer this very easily. Name the university, that's a university there, where the first corneal collagen cross-linking was performed. These are the 2 gentlemen who were instrumental in it. Either you give me the name of the university or the name of these gentlemen, I'll give you the marks. You want to answer now or later? Later. So university in Germany. Name this law. The amount of product of a photochemical reaction is determined by the total amount of radiant energy falling on the photochemical system, that is, the product of the radiation intensity and the exposure time. Again, if you attended the morning session, you will easily answer this. No? On to the next question. If 370 nanometers is to riboflavin, what is 532 nanometers is to? What 370 nanometers is to riboflavin, 530 nanometers is to? A? Do you want to answer A? Why did you choose that picture first? Thinking what it was? Sydney. No, that is not the right answer. The law? No, you don't know the law. And the last answer? Can't hear you.
Yeah, the laser.
No, you have to see the 370 nanometers and what is written. It's not a name of a laser, it is name of a pigment, no? Riboflavin. What would that 532 be? Okay, no marks to you. No sweets this time. Because she is there, no sweets. Anyway, what is the answers? Dresden University, where it was done. All of you must be familiar with the Dresden Protocol. So it is done by Theo Seiler and Sperl, Eberhard Sperl. Those are the two scientists. And the law is Bunsen-Roscoe's law. And this is a newer development. We are trying to find out alternatives to riboflavin for cross-linking. Riboflavin uses ultraviolet light. You can use green light with rose Bengal. That is the latest studies that are happening. Rose Bengal cross-linking. So no points there to team C. And next team would be team D, I guess. You're the last team. Okay, you can take a pick. You have two choices. You have E and F, I think. Yeah.
E, sir.
E. You chosen E, thinking what it is. What did you think E is? Or just like that?
Optics.
Huh? Yeah. All right. E is for optics, actually. Name this Nobel Prize winning ophthalmologist known for his work on optics of the eye. Don't stare too much because you won't be able to find the answer. You either know it or you don't know it. You want to answer now or later? Now, later. Gullstrand. Alvar Gullstrand is the right answer. Big hand. +10 for them. Next question is this. If a lens of 2 diopter power is decentered by 5 millimeters, what is the resulting prismatic effect in prism diopters? 5 millimeters, 2 diopters power. Decentration of lens produces prismatic effect. Correct? And the third question is this. Describe the refractive error. The cycloplegic used is atropine and the working distance is 67 centimeters. This is a retinoscopy. Cross power that is written there. I'll give you some time to decide on that. Meanwhile, somebody who hasn't answered yet in the audience can think of the answer. Alright, do you have any answer for me? 2 or 3? You have an answer? No, you don't have 1 minute. Alright, I need your
Prismatic effect is 1 diopter.
1 prism diopter.
1 prism diopter.
And?
Refractive error is
come on, say the right answer, otherwise I will have to sit and calculate.
compound hypermetropic astigmatism.
Compound?
Hypermetropic
astigmatism. No, that is not the right answer. But you do get the marks for the prism diopters. That is 1 prism diopter is the right answer. It is a simple hypermetropic astigmatism. Against the rule. Why? Because Atropine is 1 diopter, isn't it? And 67 centimeters is 3 by 2 meters, that is 1.5. So total 2.5 you have to subtract from both. One meridian is 0 and the other meridian is plus 0.75, that being the vertical meridian. It can only be against the rule as simple hypermetropic astigmatism. So you get 20 points. 20 points to team D. Big hand for them. So with that we come to the end of this round. All teams have answered. While the scorers calculate the scores, audience question. So this is a champion athlete. He's an Olympian. Okay. And he ran the 1924 Paris Olympiad. He ran for 1500 meters. That is the newspaper clipping. I deleted his name from there. He actually collapsed and did not wake up for an hour after he finished the race because he had a damaged foot and he ran. He's actually bronze medal winner in the Olympics. He's a very famous ophthalmologist. He wrote this book as well. It's one of the first editions of the book. Any guesses? Eye surgery? No, it's not Von Graffe. Not that old. Eisler, no. Eisler was an Olympian? I don't know that. No. Anybody else? Eye surgery? Stellard. This is Stellard. He was actually a champion runner. So please give the sweet to sir. Henry Stallard, also known as Hyla Bristow Stallard. So do we have the scores? Just a minute. Henceforth, we would like to the scores be announced in an order.
Team A, 30 points.
30 points to Team A.
Team B, 75.
75 to Team B.
Team C, 60 points.
Again, I expected it to be in the ascending order. Okay, no problem. Next time we can make it. Team B, Team C, 60 points. Correct? Yes. Well done, Team C.
80 points.
Team D, 80 points.
Team E, 25 points.
Team E, 25. So Team D is leading at the moment with 80 points. But nobody is far behind. You can all catch up. Henceforth, if you can say the scores in the ascending order, that would be nice. All right. So we'll go to the next round. This is a buzzer round. All right. So what I'll do is I'll test the buzzers. The rules I've explained to you already. For the sake of the audience, I'm saying again. The answer can be given only by the person who has pressed the buzzer first. If you get it right, you get plus 10. If you get it wrong, and one of the other teams gives the answer, then you get minus 5. That is, if you don't know the answer and any of the other team knows the answer, you get minus 5. You can also choose to go for double after pressing the buzzer. If you choose to go for double, you get it right, you get plus 20. But if you get it wrong, and if any of the other teams know the answer, you get minus 10. The teams which have not pressed the buzzer don't get any marks, positive or negative, but you do get the opportunity to punish the team which has pressed the buzzer first. Okay? So, get ready. Buzzers, can we have the test? A. All right. Reset, please. Reset buzzer. Please reset the buzzer. Is this the technician is gone? Okay. Team B, please reset. Team C, okay, please reset. Team D, all right, please reset. Only once, you need to press only once. Team E, okay, great. So keep your hands on the buzzer, please reset. Yeah, keep your hands on the buzzer, the question will come. The first person who buzzes, only after I tell you to answer, please answer. Okay, don't give the answer before that. Ready? Are you ready? Okay, team B is ready, nobody else is ready. What is common to these three? Now 3 pictures are going to appear. Okay, can be anything. First picture, the second, and the third. There is something that is common to all these 3. There's a trick to the buzzer round. If nobody is pressing the buzzer, that means nobody knows the answer. That means if you press the buzzer and get it wrong also, you won't get minus. Most probably. Who has the courage? Let me see. Especially those who are behind, if you want to get ahead, this is your chance. Nobody wants to give an answer. Have all of you given up? Maybe think about what these are made of. Okay, nobody has given the answer. I'll ask the audience. No, they are not made of PMMA. They are all collagen polymers. Made of which collagen? One particular animal. Porcine collagen, that's it. Meru gets the sweet there. No sweet for you. They are all made of porcine collagen. So that is the artificial, the artificially synthesized bioengineered cornea that's recently come in the news. Even some of our Indian scientists have synthesized it. This is the ICL, which is made up of collamer, that is porcine collagen. That is the Ologen implant. That is also made of porcine collagen. So no marks. All playing too safe. Too safe, if you play, you will always be falling behind. Okay. So ready for the next question, all teams? Hands on the buzzer. The appearance that is common to these three, this particular kind of appearance. 1, 2, 3. Team D has given the buzzer, so you can answer it.
Starry sky appearance.
Starry sky appearance is the right answer. Big hand for them. Plus 10. If you're sure of the answer, go for double. Okay, you'll get 20 points. You'll get only 10 points now. If you're sure of the answer, go for double. Okay. 10 points to Team D. That is a starry sky appearance of. One is Drusen. The second is VKH. And the third one is something that's not common. It's Burkitt's lymphoma. That is the histopathology picture of the Burkitt's lymphoma. So next question. Please reset buzzer. Okay. Hands on buzzer. Here we go. One word which is common to the description of these three conditions. Three conditions will be shown on screen. 1, 2. Don't say your answers loud because other teams can hear it. Okay, only Team D.
Sunset sign.
Sunset is the right answer. This is the sunset sign. That is also a sunset sign. And what is that? Third one? Sunset glow fundus in VKH. So you get it. Get that plus 10. Again, go for double if you know the answer. Did you say go for double? No, it's not good. It's not good enough to press the buzzer twice. Press the buzzer only once you tell me that you want to go for double. Okay. All right. So the next question, buzzer reset. All teams ready? Plus 10 to Team D. What is common to these three pictures? This is the first picture. One term that is common. Don't blurt your answer out. Press the buzzer first. This is the second picture. It's a formula picture. That is an instrument. This is a formula. And this is a disease. I need the word that comes in front of it. I don't think anybody knows the answer. So Team B has gone for it. Yes, Team B. What? Histo. This should be term should be common to all three. So you said histospots. Is that the histospots formula? And is that some histospots instrument? Anybody else knows the answer? If anybody else knows, you get -5. You want to punish teams B. No, you don't get negative marks. Tubular vision disease, tubular vision formula, tubular vision instrument. Anybody else knows the answer? No other teams wants so either they don't know or Team B is praying that nobody knows. So nobody knows, no negative marks for Team B. Okay, no negatives here. Nobody knows the answer. Audience? Okay. Okay. That is not the right answer. Any other guesses? I'm looking for name of a person. Goldman. That is the right answer. This is a Goldman-Favre disease. This is the Goldman's formula or equation, and that is the Goldman's perimeter. I thought you would know that. It's a Goldman's perimeter. Okay. I could have put easier things in Goldman, but then everybody would have guessed. So I get the sweets for this. No marks to anyone. Next question, ready? Buzzers reset. What is common to these three again? This is the first picture. This is the second. Again, I'm looking for a name. And this is the third. Team B has gone for it. Go for it. Axenfeld. What is this? Does it look red? You get the marks. I'll give you plus 10. What looks red and commonly seen in the OPD? What is it called? Red eyes. Axenfeld. Morax conjunctivitis or Axenfeld conjunctivitis. It is angular conjunctivitis, also known as Axenfeld conjunctivitis. That is, the middle one is? Mic on, please. Axenfeld nerve loop. And the last one is?
Posterior embryotoxon.
Called? What did you say? What is the answer?
Axenfeld-Rieger anomaly.
Axenfeld anomaly. So you get plus 10 for that. So that is Axenfeld. So you get the drift how it is, how this round is going to go. All right. So buzzers reset. All ready. You have to identify X. There's no tricks in this. Team B has gone for it. You have to say it into the mic.
Ranibizumab.
Ranibizumab is the right answer. Plus 10. Again, double your answer if you know that you are sure it is true. Ranibizumab. Why ranibizumab?
Body fragment.
It is a fragment, FAB fragment. The others are full monoclonal antibody, and that the other one is the VEGF trap. So you get the plus 10. Buzzers reset. Going for the next question. Hands on buzzer. Again, remember the double. Which neuroophthalmic condition characterized by a difficulty in looking downwards, that's impaired down gaze, shows the following signs on MRI? I'm not going to show you the MRI, but I'm going to show you this. Okay, team D has already gone for it.
Parinaud syndrome.
Parinaud syndrome. Okay, I will not give you the answer. I mean, give you the marks. You get -5 if anybody else knows the answer. Does anybody else know the answer?
Morning glory.
Morning glory syndrome. That is not the right answer. That is a morning glory, obviously. It's a neuroophthalmic condition. Nobody else knows the answer. Any guesses? No? Audience? Yes, that is the right answer. So gets this sweet. It is progressive supranuclear palsy, PSP, and it produces what? The hummingbird sign, the Mickey Mouse sign, and the morning glory sign, all produced due to the atrophy of the tegmentum. Sorry, atrophy, relative sparing of the tegmentum in the midbrain atrophy. So that is the right answer. Oh God, we got that answer was out for the next question. So I don't think I can ask this question, can I? The answer is out, sorry. So this is what I wanted to ask. This is a electron microscopy picture before treatment, after treatment. CHX stands for chlorhexidine, and the answer is acanthamoeba. I'll ask the next question. Hands on the buzzer. Buzzer reset. You still have 2 more questions. Okay, which one all of the following is a T1 weighted MRI image? Look at the images A, B, C, and D. You just have to tell me which is the T1 weighted MRI image. Team D has pressed the buzzer. You can give the answer.
D.
D. Why do you think D is the T1 weighted mRNA? Vitreous is? Vitreous is hypo? Yes, that is the right answer. So you get plus 10. Again, double if you know the answer. It is D. That is a T1 weighted image. So you get plus 10. So this is the 9th question. And this is the last question of the round. Buzzers reset. Here we go. Which of the following is typically seen in a patient with Arnold-Chiari malformation? You can look at the 4 GIFs that are running. Team C has gone for it. Give your answer.
B.
B. Why do you think B is the answer?
Downbeat nystagmus.
Downbeat nystagmus. Brilliant. Give them a big hand. And you did not double again. Plus 10. Plus 10. So that is the right answer. You get downbeat nystagmus in Arnold-Chiari malformation. So that is the last question of the buzzer round. So scorers, while they tabulate the marks, the audience can answer this. This is a famous ophthalmologist, not very famous, but famous as a politician. What is her claim to fame? Dr. Baljit Kaur. Any idea? She's an Indian politician. No? Okay, she's actually the Minister for Social Security, Women and Child Development and Social Justice Empowerment of Minorities of Punjab. The Aam Aadmi Party in Punjab has 2 ophthalmologists in the government. One of them is her, Dr. Baljit Kaur. She has left her government practice for pursuing her political career. Okay, can we look at the scores?
Team E 25 points.
Team E gets 25 points.
Team A 30 points.
Please give them a big hand as the scores are announced. Okay, let's go.
Team C 70 points.
70 points.
Team B 95 points.
Team B 95 points.
And Team D 110 points.
Team D is leading again with 110 points, but there's one more round to go, which is the rapid fire round, and 10 questions, 100 points, anything can happen. Any team can win technically. So in the rapid fire round, the rules again are simple. No, you should not answer the answers into the mic. Keep your mic down, keep your pen up, take your pad and write your team name at the top right now. Okay, and you have to write your answers down. At the end of time, our scorers will snatch the papers from you. When I say pen down, you have to keep the pen down. Doesn't matter if you are in the middle of writing an answer. Okay, scorers, please be ready at the end of time. Just get the papers from all teams. Are you ready? So here we go. All of you have written your team names. This is the first question. This is the rules which I've explained again. No negative marks, plus 10 for the right answer. The posterior remnant of hyaloid artery is called dash. Posterior remnant of persistent hyaloid artery is called. I'll give you some time to write the answer, after which I will be moving on to the next question, which is, which pigment gives the macula its yellow color? Macula lutea. Why is it called so? What is the pigment that gives the macula its yellow color? So I'll go to the next question now. The commonest morphological type of congenital cataract. What is the most common morphological type of congenital cataract? Congenital cataract is of several types. Which is the most common type? This is your next question. Which is the gene that is thought to be strongly associated with pseudo-exfoliation syndrome? The gene that is, I want the gene, not the location, that is strongly associated with pseudo-exfoliation syndrome. Name the study that evaluated the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma.
the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma? The answer might be there in the question. Next question is this: expert opinion is considered to be of higher quality of evidence than cross-sectional studies. True or false? Is expert opinion a better quality of evidence than cross-sectional study? True or false? Just have to write true or false. Which country has the largest number of blind people in the world? The blindness capital of the world. The country, not the city, the country. What is the criteria for blindness as per the International Classification of Disease 11, ICD-11? What is the criteria for blindness? Distance visual acuity criteria for blindness as per the ICD-11. So I'll go to the next question, which is pi on the floor field defect is produced by lesions of, typically produced by the lesions of which structure in the visual field pathway? And the last question is this: teprotumumab is an FDA approved treatment for FDA approved for the treatment of this. Again, if you attended the morning session, you would know the answer. When I tell you to keep your pen down, you should keep your pen down. Scorers, please be ready. Okay, and I think the time is up. You can keep your pen down, please. Please collect the answer. Okay, the scorers are going to have a busy time calculating the scores. So let's go to the answers then. So the posterior remnant of hyaloid artery is called Bergmeister's papilla, and the anterior remnant is called Mittendorf's dot. The pigment that gives the macular yellow color is xanthophyll. The commonest morphological type of congenital cataract is either lamellar or zonular cataract, the same thing. The gene that is associated with pseudoexfoliation is LOXL1. And the study that evaluated the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma is EAGLE study. The expert opinion is not above the quality of evidence, above cross-section study in the evidence pyramid. In fact, it's at the bottom. It has the least value. Which country has the largest number of blind people in the world is, of course, our India. And the criteria for blindness as per ICD-11 is visual acuity less than 3/60. Pi on the floor is produced by parietal lobe field lesions, and teprotumumab is FDA approved for treatment of thyroid ophthalmopathy. So, was I too fast, or could the scorers calculate? You can still calculate. There are some audience questions. You all know who is this guy, right? Which ophthalmic procedure has he undergone? This is Ballala Deva. Everybody forgot. Huh? Prosthetic eye? No, not prosthetic eye. No, it's not retina detachment. Huh? No, he is not Marfan's. He's undergone corneal transplant. He's undergone a penetrating keratoplasty, is what I think. All he mentions is a corneal transplant. So probably a penetrating keratoplasty. But he can't see well out of his right eye, I think. Right eye. That's what he claims. So that is the first question to the audience. No sweets this time. And let's go to the next question. I want you to look at this picture very carefully. Our retina specialists, retinologists, everyone. Look at the picture carefully, and I need a diagnosis. And if nobody's giving a diagnosis, I'll give a clue. This is the clue. When I search for it on the Oxford Dictionary, this is what I found. Conforming to a standard. And used in a sentence, it's quite dash for puppies to bolt their food. Please say that loudly again. It is a normal OCT. So you get the sweet. Sometimes we always find it difficult to diagnose normal things. That is the Oxford definition for normal. So, choroid thickness, all those things. Sometimes too many CMEs can confuse you. Okay, I think that the scorers are ready with the scores. So this is the final round. So this is the final scores. So let's go from the bottom up. Are the scores ready? Let's go from the bottom up.
Team E 75 points.
Team E 75 points. Please give them a big hand.
Team A 80 points.
80 points to Team A, home team.
Team C 130 points.
Team C 130 points.
Team B 155 points.
155 points. Team B in second place with 155 points.
And Team D 200.
And the winners are Team D, Giridhara Institute with 200 points. Please give them a big hands. So I think all of you performed very well. The questions were, what do you think? How were the questions? Too tough? Kind of tough? It wouldn't be fun if it isn't a little tough. So I made it a little tough. So anyway, Team D has performed, all of you have performed excellently. And Team D gets the prize. And I'll call the organizers to do the honors. We are giving three prizes. Three prizes.
I request Rachel Madam to come and give the prizes for the quiz. First prize goes to Giridhara Institute, Christy Sarah Matthew and Anne Maria Davis. The second prize goes to Chaitanya Eye Institute, Rubina Manaf, Trivandrum. Yeah, Trivandrum. Rubina Manaf and Sajna K. Rahman. On the third prize goes to Kottayam Medical College, Divya T. Gopalan and Rashmi Rajan. Congratulations to all, especially all those who participated. Thank you for coming. Yeah.
Can we have a group photo?
Yeah, we can. We should.